Welcome you all on the third and last day of UPTBCCON-2022. The response and feedback of both the delegates and faculty over the last 2 days have been overwhelming for us. We couldn't have asked for more. We have planned a very interesting day with various sessions on pulmonary critical care, lung cancer, thoracic radiology and surgery for today. I am confident it will be worth of every minute of your time. Starting with the first session on pulmonary and critical care medicine, I invite on stage the chairpersons for the session. Dr. Haider Abbas sir, he is professor and head Department of Emergency Medicine at KGMU Lucknow. Dr. Sohail Siddiqui sir, he is associate professor, Department of Critical Care Medicine, KGMU Lucknow. And Dr. Syed Nabil sir, associate professor, Department of Critical Care Medicine, KGMU Lucknow. Thank you sir.
Good morning, everybody. I would like to welcome Dr. Dilip Kumar Dubey, who will be speaking on antibiotic stewardship and optimal use of beta-lactamase inhibitors in ICU. Dr. Dilip Dubey is head critical care medicine at Medanta, Lucknow. He has done his MD from All India Institute of Medical Sciences, New Delhi. Welcome, Dr. Dilip Dubey.
Very good morning to all. Today I will start with the first topic of the day, that is antibiotic stewardship and the optimal use of beta-lactamase inhibitors according to antibiotic stewardship fundamentals. So, as we all know, the great Louis Pasteur says, when mediating over a disease, I never think of finding a remedy for it, but instead a means of preventing it. If we see in a scenario of a current situation, so disease is a MDR infections. So to prevent the MDR infections, the one way is to optimally treat the MDR infections. So this was a review on antimicrobial resistance chaired by Jim O'Neill. This was the data from 2014, and according to this data, the death attributable to antimicrobial resistance expected to be 10 million by 2050. That is higher than the deaths because of cancer, road traffic accidents and all. And if we see in the Asian regions, the burden is too high as compared to other areas. So antimicrobial resistance is a devastating situation, and to deal with antimicrobial resistance, we have the fundamental of antibiotic stewardship. So what is antibiotic stewardship? So it's a systematic measurement and the coordinated interventions to promote the optimal use of antimicrobial agents in terms of drug choice, dosing, route and duration. So CDC proposed 7 core elements for antimicrobial stewardship. That is leadership commitment of the hospital in terms of resources, financiers, information technology and the healthcare personnels. And the accountability of that program leader who will be responsible for the program outcome. Pharmacy expertise is required for antimicrobial stewardship, and the priority intervention in terms of prospective audit, feedback, pre-authorization and other actions. Monitor antimicrobial using and resistant pattern tracking. Continuous reporting and the reporting to the users as well as reporting to the hospital leadership also. And the last and the most important point is education of the experts regarding antimicrobial resistance and the optimal use of antimicrobials. So if we see the main reasons for this crisis of antimicrobial resistance, So there are three main reasons. One is the overuse, other is the inappropriate use, and third is the environmental antibiotic pollution. So epidemiological studies demonstrated that the amount of antibiotic consumptions are directly correlated with the emergence of the resistance. There is an environmental antibiotic pollution via the use of antibiotic by the veterinary physicians in animals, and the most important part is antibiotic therapy is incorrect or suboptimal in up to 40 to 50% of cases. So if we see these three main reasons for this crisis, overuse can be controlled by the promotion of the medical education, and the environmental antibiotic pollution can be prevented by the restriction over the veterinary physicians to use the antibiotics. And the most important part is inappropriate use. So that needs the knowledge and education of the experts who are supposed to prescribe the antibiotics. So if I talk about antibiotic stewardship, in ISSM 2019 guidelines, there were 57 questions and 4 questions were regarding antibiotic stewardship. The one question was, does antibiotic stewardship improve patient outcome in ICU? So regarding this, if you see the data, we have almost 8 systemic review or meta-analysis and around 58 randomized controlled trials. And after review of this data, the conclusion is that among inpatients, antibiotic stewardship program reduced the duration of hospital stay as well as reduced the number of antibiotic days. And pooled data from the observational studies showed that there is a relative reduction in the risk of mortality. So recommendation is that all hospitals should have an antibiotic stewardship program, including the intensive care units. If we move ahead, so the antibiotic resistance is growing. This is the burning issue in front of us. So there are 2 ways to deal with this. One is the new antibiotic discovery to deal with the antimicrobial resistance. The other is the better use of what we have already in use. So if I talk about the new antibiotic discovery, so it will take around 5 billion to discover a drug, and 80% time of the research is failed. Now the question is that who will discover the new antibiotics? Responsibility is over the academic institutions or the pharma drug makers. So now in current scenario nowadays, no academic institution is in position to discover an antibiotic. And the pharma companies, the major pharma companies pull out their hands from antibiotic research facilities because of high cost consumption, chances of antibiotic resistance and other issues. So if we see the data from 1980 to 2014, the number of antibiotic discovered at every 5 years reduced from almost 20 to 10, now up to 5. So the only option to deal with the current situation is the antibiotic stewardship. There is better use of what we already have. And even if we see the antibiotic discovery was a bit accelerated in 2015 to 2020 via the few innovations of beta-lactamase inhibitors. Now again, to use these beta-lactamase inhibitors optimally, we need antibiotic stewardship. So either the part 1 or part 2 new antibiotic discovery or the existing drugs, antibiotic stewardship, knowledge about the drugs to use is must to control the antimicrobial resistance and to increase the outcome. So on the basis of this, now we'll discuss the second part of this antibiotic stewardship, that is the optimal use of beta-lactamase inhibitors in ICU. As I mentioned, in last 5 to 7 years, there are a lot of discoveries in beta-lactamase inhibitors. So first we will see the classification of these 4 points. Beta-lactams are the antibiotics, beta-lactamases are the enzymes which destroy the beta-lactam rings, beta-lactamase inhibitors are the antibiotic resistant breakers who control the beta-lactamase enzyme and prevent the destruction of beta-lactam drugs. So if we combine the beta-lactam with the beta-lactamase inhibitor, the drug is BL-BLI. So first classification of beta-lactam antibiotics, as we all know, that is penicillin, cephalosporin, monobactams and carbapenems. If we see the classification of beta-lactamase enzymes according to Ambler class A, B, C and D. So according to this, we can classify the beta-lactamases, narrow spectrum, extended spectrum, broad spectrum and the carbapenemases. If we see the classification of beta-lactamase inhibitors, the antibiotic resistant breakers which control the beta-lactamase enzyme to prevent the destruction of the beta-lactam rings. So if we classify the beta-lactamase inhibitors, clavulanic acid, sulbactam, tazobactam, which we are using since last so many years, comes under first generation, that comes under beta-lactamase, core beta-lactamase inhibitors. The second generations are the diaza-bicyclooctane core DBO inhibitors. And the third and last one are the boronate compound cores, which includes Vebarbectam, while the second generation includes Avibactam, Relibactam, Dorlobactam, and GDbactam. Nowadays, currently, we are using Avibactam. If we see the final classification of the drugs, that is BL-BLI, we have older BL-BLI in terms of amoxicillin chlorinate, ticarcillin, ampicillin sulbactam, 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 and piperacillin tazobactam. In the novel BL-BLIs, we have ceftazidime, avibactam. Rest three are not in use in India at present, but they are under use in global hospitals. And the third, which is unique and innovative, is the beta-lactam. We combine with the beta-lactamase inhibitors that have property of BLI as well as BLE, that is beta-lactam enhancer. So now we discuss few fundamentals regarding the optimal use of beta-lactamase inhibitors. So if you talk about the point one, that is anaerobic coverage of beta-lactamase inhibitors. As we all know, if we see the activity of antimicrobial agent against anaerobes, so there are three classes of drugs which are nearly always active. One is the metronidazole, other is the carbapenem, and last one is the beta-lactamase inhibitors. Clindamycin is a drug which is usually active in anaerobes but not nearly always active on the anaerobes. So we have only, and because of clindamycin, we have almost up to 60% resistance in Bacteroides. So we have three options to control the anaerobes. Now if you talk about beta-lactamase inhibitors, so the addition of beta-lactamase inhibitors to beta-lactam control the beta-lactamase enzyme produced by the anaerobes. So almost all the carbapenems, BL-BLIs, which includes sulbactam and tazobactam as a BLI, have excellent anaerobic coverage, almost as equal as to metronidazole. So if we are using a drug which includes a BL-BLI and then the BL-BLI is sulbactam or tazobactam, then there is no need to add anaerobic coverage. This is one of the optimal use of BL-BLI for anaerobic drugs. But we have to know simultaneously that ceftazidime avibactam, which is a novel BL-BLI, is not have any anaerobic coverage. So if we are using piperacillin tazobactam, sulbactam, sulbactam, we are not supposed to use additional anaerobic coverage. But if we are giving ceftazidime avibactam, we have to consider for anaerobic coverage if required in the patient. Now the second point we move ahead, that is Esbl Enterobacterials antibacterial efficacy. So here we will discuss the optimal use of BL-BLI in comparison with carbapenem. So most of the data in BL-BLI is for piperacillin tazobactam versus meropenem. So now we will move ahead with the case scenario. A 75-year-old female presented from the community. She is a non-case of diabetic, uncontrolled hyperglycemia, also non-case of irritable bowel syndrome. She presented with high-grade fever with chills, burning micturition, recurrent vomiting. Hemodynamically and respiratory wise she was stable. USG QOB saw no structural abnormality, no evidence of pyelonephritis. Urine culture was reported as E. coli and no history of antibiotic exposure in last 90 days in this case. So what are the antibiotic of first choice and second choice in this case, and is that a Esbl organism? So if we see the culture report in detail, so we have options of beta-lactamase inhibitors, we have option of cefepime and carbapenems and piperacillin tazobactam. So among the beta-lactam we have 6 options to treat this patient. And other than beta-lactams, we have a few other drugs which are sensitive. But in this case, as we know, it's a urine infection, so doxycycline is not a drug of choice for urinary infection. And nitrofurantoin is not useful in this case because of the elderly patient and case of irritable bowel syndrome. And if we talk about the higher antibiotics, so this is an Esbl organism, so higher antibiotics are not supposed to be used in this case. So we have to choose among the beta-lactams. We have sensitivity for 6 drugs, 1 cefepime, 2 to 3 BL-BLIs, and 3 drugs of carbapenem class. So what is Esbl? So Esbl is extended spectrum beta-lactamases, are enzymes that confer resistance to most beta-lactam antibiotics including penicillin, cephalosporin and the monobactams. How we can identify Esbl in labs? There are few methods to identify Esbl in labs. But according to CLSI, none of the method is so much standardized to definite identification of Esbl. So how can we identify the Esbl? to optimally use the drug according to antibiotic stewardship fundamentals. So this is a proxy definition by IDSA 2022 guidelines. If in the culture ceftriaxone is showing a MIC of 2 or more, that is to be considered as a ESBL organism. So now this culture we have a lot of antibiotics showing sensitivity. First we have to identify is that a ESBL or it's a non-ESBL, that is a narrow spectrum beta-lactamase. So in this case we had seen ceftriaxone MIC of more than 8, so that is a ESBL E. coli. So now we are on the diagnosis that on this culture that is a ESBL E. coli. So what are the treatment options? We have carbapenem, we have BL-BLI combinations. Now what we have to choose among this carbapenem versus BL-BLI? So for this there are a lot of studies, data, literature, but I will directly go to the guideline, IDSA 2022 guidelines which published in March 2022. So the question number 4 in the guideline, is there a role of piperacillin tazobactam for ESBL Enterobacteriaceae when in vitro susceptibility is demonstrated? So culture if the ESBL Enterobacterial and BL-BLI is sensitive, even though it was recommended that piperacillin tazobactam should be avoided, even if susceptibility to the drug is demonstrated. The rationale behind that, they proposed that controlled trial of ESBL Enterobacterial bloodstream infection indicated inferior results with piperacillin tazobactam compared with the carbapenem therapy. The reason is that piperacillin tazobactam MIC testing may be inaccurate or poorly reproducible when ESBL enzymes are present. So we have to identify that always that organism is ESBL or it's a narrow spectrum. So after this I will move ahead to the third part of the BL-BLI optimal using, that is independent bacterial efficacy of the BLI sulbactam. So we all are using sulbactam since long as independent antibiotics. So sulbactam available to us in 3 forms. One is the ampicillin sulbactam, other is the cefoperazone sulbactam, and last is the plain sulbactam. In United States only ampicillin sulbactam is available, but in our country we have all the 3 options of sulbactam. So in high doses, sulbactam has an independent affinity for penicillin binding protein 1 and 3 for Acinetobacter baumannii isolates. That's why worldwide spread of MDR Acinetobacter baumannii, for which only few options are available, sulbactam is considered as an alternative treatment option. And we are using this since long, but now it comes under recommendation of the IDSA 2022 guidelines. The question here is this: what is role of ampicillin sulbactam for treatment of infections caused by CRAB, carbapenem resistant Acinetobacter baumannii? In the question they put a term ampicillin sulbactam because in United States only ampicillin sulbactam is available as an option for sulbactam. So the suggested approach is that high dose ampicillin sulbactam is a preferred therapy for CRAB infections when susceptibility is demonstrated. And now the next part, the high dose is considered to be as 9 gram 8 hourly or 27 gram as continuous infusion. That is ampicillin sulbactam. If we are using plain sulbactam, then dose is total 9 gram per day. And now the most important part of this guideline, that high dose ampicillin sulbactam remains a treatment option as a component of combination therapy even when susceptibility has not been demonstrated. So we can use sulbactam in high dose in combination with either polymyxins or some other drug in combination therapy even if susceptibility for sulbactam is non-demonstrated, but we must have to use a dose of up to 9 grams per day. Now we move to the pharmacokinetic pharmacodynamic of the sulbactam. So again, according to antimicrobial stewardship, we have to choose a right drug in right dose and right duration of administration. So sulbactam has a time dependent antimicrobial activity, 93% stability on room temperature for up to 24 hours. So we must use sulbactam either in continuous infusion or in an extended infusion of 4 hours. Now the next part we move regarding the optimal use of BL-BLI is a newer BL-BLI. So in the newer we have only option of ceftazidime avibactam. So ceftazidime avibactam, the main component is avibactam. That is a DBO beta-Electamase inhibitor. It inhibits Ambler class A, C and some components of class D. There was a poor activity over class B MBL carbapenemases. So infections by metallo-beta-lactamase producing bacteria, therapeutic strategy consists in administering avibactam with aztreonam. Aztreonam is not hydrolyzed by class B MBL, but class B MBL also produce some component of class A and class C. So if we are using aztreonam is directly acting over class B MBL, but that aztreonam is destroyed by class A and C, few component produced by the MBL. So we have to control that class A and C by avibactam so that aztreonam works directly on the class B MBL. So this is the fundamental behind combination of aztreonam plus avibactam. So ceftazidime avibactam is the drug to us, which is a null BLBLI. The spectrum of this drug is it covers Enterobacterial as well as Pseudomonas aeruginosa. In Enterobacterial it covers E. coli, Enterobacter, Klebsiella, Proteus, and Citrobacter along with Pseudomonas aeruginosa. This drug have no activity over Acinetobacter baumannii. So drug have no activity over crab infections. So if we see the three main WHO bugs, that is CRPA, crab, and CRE. These are the top three bugs in the list of WHO. Fourth is the Enterococcus faecium. So in the GNBs, these three are the top three bugs. If I see the activity of ceftazidime avibactam, which is a null BLBLI on these three bugs, so regarding CRPA, that is carbapenem resistant Pseudomonas aeruginosa, the drug will act if the Pseudomonas is non-MBL. Regarding the crab, it has no role over the crab. Regarding CRE, it covers class A and class D, no coverage on class B MBL. Subsequently, if we combine this drug with aztreonam, now the drug is avibactam aztreonam. Ceftazidime have no role here in this combination. So now if we the scenario in the, this combination in these three situations, so regarding carbapenem resistant Enterobacterial, that is CRE, now it covers class B also. So now the coverage extended to class A, class B and class D. Regarding crab, again there is no activity. So if you combine aztreonam with avibactam, there is no activity for crab again. Regarding CRPA, so that's the extreme last resort to use for CRPA, this combination. What is the reason for this extreme last resort? We have to look for the spectrum of aztreonam here. So aztreonam have a very good in vitro activity and against Enterobacterial. So if we combine the aztreonam with avibactam, it covers all kind of Enterobacterial. But for Pseudomonas, the resistant emergence ongoing with the treatment, that's why it's the extreme last resort to combine to use this combination regarding Pseudomonas. And again, it's a poor activity against Acinetobacter, so there is a no role of ceftazidime avibactam aztreonam combination for Acinetobacter baumannii. So if we see this abstract data, so it showed that aztreonam was able to restore avibactam activity against the vast majority of Enterobacterial, but no activity against Pseudomonas and Acinetobacter. So now the next points, the optimal use of beta-lactamase inhibitor. So there are few in vitro pharmacokinetic data regarding the use of dual beta-lactamase inhibitor, that is sulbactam plus avibactam combination. If we see the PK/PD data, so there is a one study published in Microbiology Journal 2019 that showed that if we combine the sulbactam with the avibactam, there is a reduction in the MIC of the sulbactam. There is again in vitro study that showed the synergistic activity of sulbactam with avibactam for XDR Acinetobacter baumannii. So if we see the MIC for sulbactam, the majority of isolates in the study falls with the MIC of 8, but if we combine the sulbactam with avibactam, the MIC was reduced to 2 for the majority of the isolates. There is another study, that is a new twist, again with a combination of sulbactam plus avibactam for crab isolates, that was tested over 187 MDR Acinetobacter isolates, and it was found that the MIC of sulbactam was reduced more than 2 dilutions in almost all the crab isolates. So the conclusion of this study is sulbactam has activity against Acinetobacter baumannii, and avibactam in combination with sulbactam reduced the MIC of sulbactam against the crab. So this combination can be used as a last resort for pan-drug resistant carbapenem resistant Acinetobacter baumannii and the other situation where it's not possible to give adequate doses of sulbactam. Now the last component of this optimal use of beta-lactamase inhibitors, the drug beta-lactam plus beta-lactamase inhibitor plus beta-lactam enhancer. So if we see the antibacterial efficacy of the drug, I will go with the case scenario. 50-year-old female resident of Nepal, she was diabetic, hypertensive, admitted at outside hospital with the elective abdominoplasty surgery. On post-op day 3, patient developed sepsis, shock, aspiration pneumonitis. He got intubated and shifted on mechanical ventilation. Then shifted to our center on invasive ventilatory support on high dual vasopressors and abdominal drain in C2. On the baseline workup, patient was having severe anemia, leukocytosis, thrombocytopenia, acute hepatitis, transaminitis, AKI, and the serum progesterone of 182. So we kept the provisional diagnosis of complicated intra-abdominal infection post-op with aspiration pneumonitis, sepsis, MODS. So that patient was admitted around 30 days to us, and there are multiple bugs and organism comes which we treated, but I will discuss in brief only one culture scenario of Pseudomonas aeruginosa. So this is the first culture of Pseudomonas aeruginosa that showed sensitivity for fosfomycin and polymyxins. So that patient was treated with optimally higher doses of polymyxins and fosfomycin. Patient responded up to some extent, but again developed fever after 5 to 7 days. The next culture in the ET aspirate again showed Pseudomonas aeruginosa was persistent, and now it developed resistant to fosfomycin even on highest dose of fosfomycin, and sensitivity was only for polymyxins, polymyxin B and polymyxin E. So that was again treated the therapy with polymyxin B, and one higher dose beta-lactam was continued with this, and subsequently what we found after 15 days in the abdominal tissue, the post-op sample shows Pseudomonas aeruginosa that developed resistant to fosfomycin as well as intermediate sensitivity to polymyxins. So now we are dealing with a PDR Pseudomonas aeruginosa infection. We have no options to treat, and patient was admitted with us since last 30 days. She was extubated, intubated 2 times, got multiple bugs. One of them was PDR Pseudomonas aeruginosa. Now patient is running high grade fever and multiple organ dysfunctions. Now we have no options to treat this PDR Pseudomonas aeruginosa. Then we think about the newer beta-lactamase inhibitor, that is a Zidebactam, which is a triple action diazobicyclooctane, which is a beta-lactamase inhibitor and also having independent antibacterial activity and also having a beta-lactam enhancer. So that drug is cefepime-zidebactam, which is a BL-BLI plus BLE. So to use this drug, the currently at that time drug was on table of US FDA for approval to go in phase 3 trial. So we applied to US FDA and got the permission to use this drug, and subsequently we got approval from DCGI to use this drugs in our country. US FDA put a term and condition that we will have to submit all the data, all the drug vial numbers to the US FDA. And subsequently, in the meantime, we are getting approval from US FDA and DCGI to use in this patient. We sent the culture to the Aurangabad lab to test the sensitivity for cefepime-zidebactam. And the sensitivity report shows a zone of inhibition of 21. So that the drug was optimally sensitive for this Pseudomonas aeruginosa bug. So we got the approval for the drug. We treat the patient with a 12 days of therapy, cefepime-zidebactam, 3 gram intravenous TDS, each dose over 3 hours. And after 12 days of therapy, patient's sepsis was completely resolved. And after 4 to 5 days, patient was discharged optimally. Thank you.
Thank you, Dr. Dilip. It was a very informative and very lucid presentation, and I hope everybody has been enlightened with this talk. And I will just request the next speaker, but I'll take permission from the organizers if we can ask the next presenter to present his PPT, and then we can go ahead with question answers subsequently for both the speakers. Will that be okay? So if you are available, so I will ask the next presenter. Oh.
Thank you.
Yeah.
Thank you.
I would like to invite Professor R.K. Singh sir, who is Professor and Head of Emergency Medicine Department in SGPGI Lucknow. Over to you, sir.
Thank you, sir. Thank you, organizers. Thank you, chair. क्योंकि ये उल्टी घड़ी चल रही है, इसलिए बहुत जल्दी करेंगे. And the topic given is approach to septic shock. Now, to start, I would say that it is a huge topic to be covered in 20 minutes. I'll therefore put my energy and focus into. I need the help. कौन है? Okay, ठीक है. Okay. So it's a life-threatening organ dysfunction caused by dysregulation of the host response to the infection. Major healthcare problem impacting millions around the world and killing between 1 to 6 patients में से 3 से 6 can die, that is 1 in 3 to 6 it will affect, and early identification and appropriate management in initial hours after the development of sepsis will definitely improve the outcomes. Now, since this topic is an approach to septic shock / shock, so I have limited myself to what is in context and evidence based as of now, rather than deliberating on this lecture without boundaries. So it is such a huge topic, it cannot be constrained within 20 minutes. So I have straight away gone into what is available, what is evidence based, what is the recommendation, and then move on into the areas from this Surviving Sepsis campaign, guidelines for management of sepsis and septic shock. I have limited the areas which are highlighted into blue because they are the ones which have been changed over the time from 2016 to 2021. So these are the areas which I will just talk on. I will not quote on the studies because the studies are coming and going. Something that is important in 2016, in 2021 looks like it's not good. So it is changing, and this 2021 is based on some of the recommendations of best practice guidelines. Then I think I have a cursor here. Yeah, okay. Then there are, can I have a cursor? Can I have a cursor? To understand some of this, it is important that we just focus a minute on what is coming into these. These are the best practice statement guidelines. Then if there is a question mark, there is no recommendation. 1 stands for weak recommendation, 2 stands for very strong recommendation, 1 stands for red, weak recommendation against, and 2 stands again for a very strong negative recommendation. And the quality of the evidence is based on, again, the RCTs, the number of RCTs, multicentric, all these. So it is high quality if it is like this, then moderate quality, then low quality, then very poor quality, and then whether you have upgraded it from 2016 or you have downgraded or you have kept it almost the same. So it will come like this, and I've taken, there are almost, it is a 70-page document. I'll just tell you it is a 70-page document, and going through this in 20 minutes is next to impossible for me and for the audience as well as the chair. So I'll just move on fast onto these segments. Screening. The recommendations for screening are that previously we were using QSOFA, SOFA, SIRS. They've said this is not good enough. QSOFA is not good enough to alert the intensivist on the floor. So it is better you go for machine learning, better than manual learning. So you have to have ICUs which are doing this screening for sicker patients, more ICU type patients. You need those sort of screening modalities, but there is something called as a standard operating procedure. So 2016 talked only about screening, while 2021 talks about operating procedure. Screen करके करेंगे क्या? अगर कुछ करना ही नहीं है तो काय का screen? तो screen करें और operative procedures include करें. ये है recommendations for the newer 2021. केवल screen ना करें. Next, initial resuscitation. Again, the recommendations are resuscitation. This is best practice. So resuscitation should be begin immediately, not as soon as possible. It has to start immediately. Okay, this is best practice. Evidence अगर देखेंगे तो initially में 30 ml at least 30 ml per kg. Previous was minimal 30 ml. Now they are polluting 30 ml per kg. और कितनी जल्दी और कितनी देर? 3 घंटे. यानी शॉक के रिकग्निशन के 3 घंटे के अंदर अंदर ये रिसस्टेटिव फ्लूइड आपको अंदर देना है पेशेंट के. 30 ml पर केजी का इन्फ्यूजन देना है ओवर अ पीरियड ऑफ 3 आवर्स. 3 घंटे के बाद क्या करेंगे अगले 24 घंटे बीतने तक? आई विल जस्ट टेल यू व्हाट गोज ऑन. सो द फर्स्ट 3 आवर्स यू हैव टू गिव दिस मच वॉल्यूम. इट इज क्रिस्टलॉइड इन द IV forms. IV कैसे यूज करेंगे, पेरिफेरल लाइन यूज करेंगे, सेंट्रल लाइन यूज करेंगे. I'll just talk on these issues. So this is going to be hard hitting, but it is very focused. So I believe the concentration levels will not go down as I talk through you. ठीक है. For adults in septic shocks, this is again we suggest using capillary refill time. Now this was not there in the previous, just एक vague mention था. Now they are using capillary refill time as a marker to see whether or not your perfusion status is improving, whether your organ status is improving, whether you can use this bedside technique for capillary refill time. You can use mottling skin scores for stage 1, 2, 3 and 4 type mottling scores, but this is not in isolation. Clinical plus this plus the routine trends like lactate and other things are always there. So this is newer things that they have added. Again, the evidence is low. Maybe in the next guidelines when you get, there will be more studies on this, and this evidence will go from low to a higher grade as we have a newer revision in the coming days. So these are newer changes that are coming. Because why these changes are coming is because these are recommendations for the entire world. You have an ICU in Africa. अफ्रीका में तो ये सब लागू ही नहीं होगा. हमारे कितने सारे ICUs में ये सब लागू नहीं कर पाएंगे. इसलिए these are recommendations made for low resource intensive centers also, as well as for high resource intensive centers. In India, if you see the ICU structure, बहुत सारे centers high हैं, corporate में high मिलेंगे, लेकिन बहुत सारे government centers में low resource centers हैं. So these recommendations are coming for everybody. Okay, so use it wisely. That is what the so sepsis के initial fluid resuscitation के recommendation, sepsis को एक medical emergency की तरह माना गया है. Sepsis and septic shock, at least 30 ml crystalloid within the first 3 hours of resuscitation. Use dynamic parameters, not static. Static अगर कुछ नहीं है तो static is okay, but otherwise you have to go for the dynamic parameters, which include you need to have an understanding of the cardiac output of the patient. Cardiac output more than 15%, fluid responsive, assessed by either a passive leg raising test within 60 to 90 seconds of doing that estimation, or by a stroke volume variation, or by a pulse PVV, pulse pressure variation, PPV. So the plus echo has also been added. I'll just talk in the later sections what in echo can you do. Again, in the echo segment also what you can do is the cardiac output estimation. Okay, again it goes through. So these are the recommendations that are coming for dynamic. Again, if you are a resource intensive center, you may have all this. If you are a resource poor center, you may have none of this. So you will again be guided by static parameters, by JVP kitna tha, CVP kitna tha, urine output kitna hua. So those are still there. Sub-Sahara Africa mein, these will be the centers which will be there. How are you going to manage these patients? You have to manage them. So static se better is obviously dynamic. जैसे जैसे रिसोर्स इंटेंसिव होंगे, यू कैन यूज ईदर ऑफ देम टू गाइड योर फ्लूइड एस्टिमेशंस. ओके, यूज सीरम लैक्टेट. यस, डू यूज सीरम लैक्टेट एज अ मार्कर, because in patients in whom it is high, you need to see a trend towards the falling levels. So अगर high है तो low है, but remember in shock you can have many myriads of lactate. A lactate high in a septic shock patient, a lactate normal in a septic shock patient, a lactate trending downwards in a septic shock patient. So there are 4 spectrums of these patients with lactate itself. Sepsis shock में है, septic में sepsis में है, shock में नहीं है, probable है sepsis लेकिन shock में नहीं है, low risk है shock sepsis का भी, shock का, लेकिन lactate बढ़ा हुआ है. So there are 4 spectrums of this lactate that you can see. What recommendations are coming are only for the septic shock, okay? Because that is the most decisive element. So in septic shock, if the lactate is high, follow it, see the trend downwards. But remember, in septic shock, there can be other reasons why the lactate can be rise except the perfusion related. It is not a direct marker of perfusion. Please remember, it is not a direct marker of perfusion status. It could be risen because the liver is abnormal. It could be risen because you are resuscitating. It is coming into the circulation when you are giving him fluid. It could be high because you were using epinephrine, which again is increasing the muscular activity of your patient, and therefore the lactate is high. So there are many reasons why the lactate could be high in the background of a septic shock patient. So you have to understand these small nuances when you understand and track the lactate in your patient in septic shock. Capillary refill time, as I told you, is important, is needed to guide your results. इनिशियल तो हो गया, अगले 21 घंटे में क्या करेंगे? 3 घंटे में तो फ्लूइड दे दिया 30 ml per kg. What are you going to do for the next 21 hours? There is no clarity. There is no clarity in literature whether I want to give a restrictive fluid administration in those 21 hours or I want to do a liberal fluid resuscitation in those 24 hours. So the best, जहाँ पे information clear नहीं है वहाँ observation clear है. More observation, more diligence, more perfusion, more hemodynamic variable parameters to use your fluid elevation करना है, बढ़ाना है, फ्लूइड का ओवरलोड ना हो. ओवरलोड सेप्टिक शॉक में 2-3 जगह ही देखते हैं. आई जस्ट टेल यू, वन, लंग हाइपोक्सिमिक तो नहीं हो रहा विद योर फ्लूइड एडमिनिस्ट्रेशन. सेकंड दैट यू सी इज is the kidney function. If the kidney is going down because you were restricting the fluid, that is not a good strategy. So those wisdom has to be applied. Guidance is there only as a guide. Don't close your eyes. Guidance केवल guidance है, आपकी wisdom बंद करने के लिए नहीं दी गई है. क्लिनिकल एक्यूमेन यूज करना है बेड साइड में, प्लीज यूज इट. ओके, दीज आर ओनली गाइडेंस. सो वो गाइडेंस कैसे आएगी? वो गाइडेंस आएगी बिकॉज इफ आई यूज अ डायनेमिक पैरामीटर्स, इफ आई यूज अ कैपिलरी रिफिल टाइम, इफ आई यूज अ यूरिन आउटपुट एज अ मार्कर, इफ आई यूज अ मैप एज अ मार्कर वेदर द मैप इज 65 और नॉट. दीज आर इंपॉर्टेंट थिंग्स व्हेन आई रिसर्चिएट माय पेशेंट. फ्लूइड तो दे दिया, but how I carry it over for the next 21 hours is important. After 21 hours, there is no information in literature. How are you going to manage? It probably means that you will manage him based on the output and other dynamics, but at a slower rate. So restrictive versus liberal, after the 3 hours of resuscitation, clarity is not there in literature. Okay? Next, management में, as I told you, IV fluids previously said normal saline, crystalloids. Now there are recommendations for, I would say low, but suggestions for using balanced salt. Okay, there are suggestions for using balanced salt. Previously you can use either of them. Now there are suggestions pushing this idea of balanced salt. Why? Because normal saline for me means hyperchloremic metabolic acidosis. It for me means an increased incidence of AKI. It for me means another few elements like hemocoagulability parameters influenced because of this. So they are pushing the idea for a balanced salt solutions rather than for normal saline. But as of now, this is low evidence, but there are suggestions now pushing this idea for balanced or buffered salt solutions. Okay, just because normal saline is now considered an abnormal saline. Okay, just remember it, normal saline is now considered abnormal saline. Okay, next, against किसके आ गया? पहले there were recommendations कि ये नहीं देना है, कि जेलेटिन नहीं देना, हेस नहीं देना, स्टार्च नहीं देना, सजेशंस थे. लेकिन अब इतने स्ट्रॉन्ग recommendations हैं, don't use them. Recommendations are don't use them. These are very, very high quality evidences coming up. Don't use gelatin, don't use HES because of so many reasons, because of AKI, hypocoagulability, bleeding risk, all these are all negative consequences. So they have moved away from, जैसे OT में हम gelatin use कर रहे हैं shock में, HES use कर रहे हैं. These are not recommended now for shock patients management, please. ओके, वैसोएक्टिव. सेकेंड एलिमेंट इंपॉर्टेंट इज वैसोएक्टिव्स को कैसे यूज करना है. सजेस्ट स्टार्टिंग वैसोप्रेसर्स पेरिफेरली यूज करना है. सेंट्रल लाइन तो है ही नहीं, लो रिसोर्स. मैं तो अफ्रीका में काम कर रहा हूँ, आई डोंट हैव अ सेंट्रल लाइन. आई विल हैव अ सेंट्रल लाइन प्रॉब्ली इन द नेक्स्ट 6 hours. व्हाट शुड आई डू? व्हाई कांट आई यूज अ पेरिफेरल लाइन? यस, आई कैन यूज अ पेरिफेरल लाइन. व्हाई नॉट? कितने घंटे तक यूज करें? 6 घंटे तक यूज करें. कौन से साइड पे लगाएंगे पेरिफेरल लाइन? क्यूबर्टल फोसा के ऊपर वाले एरिया में, बिफोर प्रॉक्सिमल टू दिस. ओके, ये साइड से प्रॉक्सिमल का क्या मतलब है? एक्सटर्नल जुगुलर वेन. हम अपने यहाँ एक्सटर्नल जुगुलर वेन यूज करते हैं. ठीक है, सो डिस्टल नहीं यूज करना है. अगर पेरिफेरल यूज करना है, सेंट्रल लाइन नहीं आती लगानी, नहीं है, पैसा अफोर्ड नहीं कर सकता, आपको पेरिफेरल लाइन से यूज करना है. 6 घंटे का वार्निंग टाइम है. 6 घंटे के अंदर आप स्विच ओवर कर लीजिए. साइट मैंने अभी बताया एंटीक्यूबेटल से पहले प्रॉक्सिमल, तो हमारे लिए ये एक्सटर्नल जुगुलर वेन हो जाती है. हम एक्सटर्नल जुगुलर वेन यूज करते हैं. ठीक है, फॉर रिसर्चिएशन. टिल दैट टाइम आई गेट अ सेंट्रल लाइन. टिल दैट टाइम ये सब इसलिए किया गया प्रॉक्सिमल बिकॉज 85% ऑफ दी जो लिटरेचर अवेलेबल है वो सजेस्ट कर रहा है कि बियॉन्ड दिस एंटीक्यूबॉटल देर इज मोर एक्सट्रावेशिएशन विद द पेरिफेरल वैसोप्रेसर्स, देर इज मोर टॉक्सिक रिएक्शंस और लीकिंग आउट फिनोमिनास, एंड देयरफॉर इसको पहले की साइड में यूज करें. सो दिस इज नाउ द न्यूअर रिकमेंडेशंस. तो टाइम याद रखें, 6 घंटे से ज्यादा ना यूज करें. कितनी भी स्ट्रेंथ का करें, रेस्क्यू स्ट्रेंथ यूज करें, सेप्टिक स्ट्रेंथ यूज करें, 6 घंटे का टाइम है. ये डिफाइन नहीं किया गया कि आप रेस्क्यू कर रहे हैं कि सेप्टिक स्ट्रेंथ यूज कर रहे हैं. ओके, इट इज बिफोर 6 आवर्स यू गेट रिड ऑफ इट एंड गेट अ सेंट्रल लाइन प्रिफर्ड, क्योंकि 3 घंटे में आपका रिसर्स्टेशन खत्म हो जाने वाला है. दैट इज आई बिलीव, अगर आप यू आर इन अ सेप्टिक शॉक सिनेरियो. ओके, रेस्ट्रिक्टिव आई जस्ट टॉक्ड अबाउट, सो इसके बारे में नहीं बोलूंगा. वैसो एक्टिव एजेंट्स में नंबर 1 रिकमेंडेशन नॉरएपिनेफ्रिन के लिए है सेप्टिक शॉक में. नंबर 1 रिकमेंडेशन स्टिल रिमेन्स नंबर 1. डोपामिन गायब हो गया था 2016 के पहले. डोपामिन इज नॉट मेंट फॉर क्रिटिकली इल शॉक पेशेंट्स, लेकिन डोपामिन इज स्टिल नाउ स्लोली मेकिंग द एंट्री. लेकिन कहाँ पे एंट्री हो रही है, क्योंकि ये तो अफ्रीका की भी बात हो रही है ना, तो जहाँ नॉरेड है ही नहीं. जब नॉरएपिनेफ्रिन है ही नहीं, अवेलेबल ही नहीं है, कॉस्टली है, तो मैं क्या करूंगा? आई विल यूज डोपामिन, बट देन आई नीड टू नो बिफोर 2 माइक्रोग्राम पर केजी पर मिनट कहां पे काम करेगा, 2 to 5 कहां काम करेगा, 5 के ऊपर में क्या करेगा, लेस देन 2 में करेगा, डायलेट करेगा वेसल्स को. कौन सी? दिमाग की, पेट की, किडनी की, हार्ट की. ओके, तो इट विल एक्ट एज अ वैसोडाइलेटर एट लेस देन 2 माइक्रोग्राम पर केजी पर मिनट. 4 साइड्स, ब्रेन, स्प्लैंक्निक, किडनीज, हार्ट. केवल यहां पे ये फायदेमंद दिख रहा है. जैसे जैसे मैं इसकी डोज ऊपर जाऊंगा, ये वेसल्स को स्क्वीज करने लगेगा. आई विल हैव vasoconstrictive effects which may or may not be helpful in the situation, because I don't know the cardiac output, I don't know the arrhythmogenic status of the patient. So norepinephrine is believed to create less of arrhythmias. It is believed to not increase the heart rate too much, but dopamine will increase the heart rate. Dopamine is itself an arrhythmogenic medication. So जहां पे ब्रेडिकार्डिया है, सेप्टिक शॉक है, नॉरेड अवेलेबल नहीं है, डोपामिन, आई कैन यूज डोपामिन. ओके, रिसोर्स पुअर सेटिंग्स में आई कैन यूज. बट आई बिलीव जितने भी ऑडियंस यहां बैठी है, दे मे बी हैविंग नॉरएपिनेफ्रिन. अगर वो भी अवेलेबल है तो नॉरएपिनेफ्रिन रिमेन्स नंबर 1 चॉइस. ओके, देयर आर अदर एलिमेंट्स कमिंग इनटू इट लाइक वेसोप्रेसिन. जहां पे नॉरएपिनेफ्रिन फ्लूइड रिसर्स्टेशन के बाद भी मीन आर्टेरियल ब्लड प्रेशर 65 अचीव नहीं होएगा, वहां पे वेसोप्रेसिन ऐड करना है. नंबर 1 ड्रग टू बी एडेड फॉर सेप्टिक शॉक पेशेंट्स. पहले इसमें लिमिट नहीं बनाई थी कि कितने माइक्रोग्राम पर केजी पर मिनट पे मैं वेसोप्रेसिन को एंट्री करूंगा. 2016 के अगर मैं गाइडलाइंस में देखूंगा तो वो नहीं थी, बट नाउ द लिमिट्स हैव कमिंग. एनी नॉरएपिनेफ्रिन विच इज अबव 0.25 microgram per kg per minute, I have to start vasopressin for my patient. तो सब पेशेंट जिसमें नॉरेड लगा है उसको वैसोप्रेसिन नहीं लगाना है. इफ द मीन आर्टेरियल प्रेशर इज नॉट अचीवेबल टू 65 विद फ्लूइड रिसर्स्टेशन विद नॉरएपिनेफ्रिन up to 0.25 microgram per kg per minute, vasopressin is the addition that I'll add to my medication. Okay, and the dose range here for vasopressin is 0.03 units per minute. The maximum I can go is 0.06 minutes, 0.06 units per minute. इससे ज़्यादा का recommendations नहीं है. क्यों? क्योंकि मेरी vessels को squeeze करेगा, हाथ की डिजिटल इस्कीमियास क्रिएट करेगा, MI के पेशेंट्स में कार्डियक कंस्ट्रिक्शन क्रिएट करेगा. इस्कीमिया के लिए रिकमेंडेड नहीं है. जीरियाट्रिक पेशेंट्स में वैसोप्रेसिन के साथ थोड़ा केयरफुल रहिएगा. स्प्लैंक्निक वेसो कंस्ट्रिक्शन क्रिएट करता है, तो यू हैव टू बी केयरफुल व्हेन यू यूज दिस मेडिकेशन ऑफ वैसोप्रेसिन इन योर सेटिंग्स. ओके, there are 2 more drugs which are written like epinephrine and तो जहाँ पे पेशेंट को ब्रेडिकार्डिया है, लोअर कार्डियक आउटपुट स्टेट है, नॉरएपिनेफ्रिन से भी हेल्प नहीं मिल रही. एपिनेफ्रिन हैज एंट्री हो रही है, बट एविडेंस की क्वालिटी अभी लो है, इसलिए बहुत एम्फेटिकली इसको नहीं बोल रहे हैं अभी. न्यूअर ड्रग्स लाइक सर्लीप्रेसिन अभी आया है, बट अगेन द क्वालिटी ऑफ एविडेंस इज नॉट वेरी ग्रेट. एंजियोटेंसिन 2 इसके लिए बहुत ही पुअर क्वालिटी है, नेगेटिव इंपैक्ट ज़्यादा है, नॉट हेल्पफुल. ओके, तो वेसो एक्टिव का चॉइस, आई जस्ट समराइज दिस स्लाइड फॉर यू. यूज नॉरएपिनेफ्रिन फर्स्ट लाइन वेसोप्रेसर. For patients with septic shock on vasopressor, target is 65, not 65 to 80. Even if a patient is hypertensive, your target range is not 85. Okay, it is 65 to प्रॉब्ली 70-75 तक अगर हाइपरटेंसिव है, क्योंकि रीनल इंपेयरमेंट के चांसेस कम है, आरआरटी का यूज उन पेशेंट्स में जो क्रॉनिकली हाइपरटेंसिव है इट इज लेस. इफ यू कीप अ स्लाइटली हायर ब्लड प्रेशर, कितना हाई वो मेंशन लिटरेचर में अभी भी क्लियरली नहीं है, लेकिन 65 इज कंसिडर्ड एन आइडियल ब्लड प्रेशर फॉर मैनेजमेंट एंड टारगेटिंग इन पेशेंट्स ऑफ सेप्टिक शॉक. ओके, कंसिडर इन्वेजिव मॉनिटरिंग. आर्टेरियल ब्लड प्रेशर पे जाएं, बिकॉज आर्टेरियल ब्लड प्रेशर इन सेप्टिक शॉक इज मोर closely related with the monitoring status. NIBP again resource intensive settings में है, तो अब मेरे को इंट्राआर्टेरियल चाहिए. अगर रिसोर्स पुअर है तो मैं कुछ नहीं है तो मैं NIBP पे काम करूंगा. I don't have it, I'll use NIBP, but the target is again 65. okay, then consider initiating vasopressors peripherally. ये पहले नहीं था, this has now come. Periphery अभी मैंने बता चुका हूँ. If MAP is inadequate despite low to moderate dose of norepinephrine, you have to switch over to, you have to add a vasopressin to this. And if cardiac dysfunction with persistent hypertension is present despite adequate volume resuscitation, there is suggestion to add a dobutamine or switching over to epinephrine. Now dobutamine is a dicey thing for your patients. Why? If the patient is bradycardic, I will, okay, dobutamine causes increased heart rate, but dobutamine causes vasodilatation, it will increase the kick of the heart, but I have to be cautious. My style would be SBP 100 के नीचे है, कार्डियक आउटपुट लो है, डोबुटामिन लेने से पहले मैं थोड़ा सा डरूंगा, तो SBP के टारगेट पे मैं करता हूँ. SBP अगर 100 के नीचे नहीं है और नॉरएपिनेफ्रिन और वेसोप्रेसिन से मेरे परफ्यूजन इंडाइसेस इंप्रूव नहीं कर रहे हैं और मेरे इकोकार्डियोग्राफिक पैरामीटर्स में ये लगता है कि कार्डियक आउटपुट लो है इस पेशेंट का, डोबुटामिन इज माय नंबर 1 चॉइस. इफ आई हैव टू ऐड इट ऑन नॉरएपिनेफ्रिन प्लस वेसोप्रेसिन प्लस अ डोबुटामिन फॉर अ लो कार्डियक आउटपुट स्टेटस. न्यूअर रिकमेंडेशंस फॉर लिवोसिमेंडान, हमने बहुत लिवोसिमेंडान यूज किया. लिवोसिमेंडान के अगेंस्ट recommendations हैं. Now we are not promoting the idea of using levosimendan. Why? It may not be available in Africa. It is a costly medication. I don't know how to properly monitor it. So don't use levosimendan if you're not well versed with the idea. So recommendations are not in favor for levosimendan. They are in favor for dobutamine. Okay? Okay. Antimicrobials बिना इसके काम नहीं चलेगा शॉक के पेशेंट्स में, चाहे वो सेप्सिस हो चाहे वो सेप्टिक शॉक हो, बिना इनके काम नहीं चलेगा. सेप्टिक शॉक विदाउट सेप्सिस, विदाउट सेप्टिक शॉक, एंटीबायोटिक प्रिस्क्रिप्शंस आइडियली 1 घंटे के अंदर. ओके, अभी जो बेस्ट प्रैक्टिस है, वी रेकमेंड एंड असेस लाइक्लीहुड ऑफ इन्फेक्शन, क्योंकि अगर कई पेशेंट्स ऐसे होंगे जिनमें सेप्सिस तो है लेकिन शॉक नहीं है, तो क्या उसको 1 घंटे में नहीं देंगे? उसमें फिर असेस करेंगे कि ये पेशेंट इन्फेक्टिव वाला है कि नॉन इन्फेक्टिव है. यू हैव टू असेस दिस आइडिया. इज ही एन इन्फेक्टिव पेशेंट, इज ही एन नॉन इन्फेक्टिव पेशेंट? सो यू हैव टू टेक दिस इनटू कॉन्सिडरेशन. तो आपका टाइम लिमिट क्या है? फिर अगला टाइम लिमिट है 3 घंटा. यानी अगले 3 घंटे में यू हैव टू डिसाइड वेदर दिस इज एन इन्फेक्टिव पेशेंट और अ नॉन इन्फेक्टिव पेशेंट. इफ द प्रोबेबिलिटी ऑफ इन्फेक्शन इज लो, डू नॉट स्टार्ट द एंटीबायोटिक्स. सबसे इजी है एंटीबायोटिक स्टार्ट करना, सबको पसंद है एंटीबायोटिक स्टार्ट करना, सबके पेन के पीछे एक कंपनी लगी है एंटीबायोटिक स्टार्ट करने के लिए. सबसे आसान काम है एंटीबायोटिक करना. हर फीवर के स्पाइक पे एंटीबायोटिक चेंज कर देना, सबसे इजीएस्ट काम. मेरा एमबीबीएस फर्स्ट ईयर कर लेता है तो काम. इसमें क्या कमाल है? स्टैनफोर्ड की टेक्स्ट बुक गाइडलाइन सारी एंटीबायोटिक की डोजिंग के साथ जेब में रखूंगा, इसमें क्या सीखना मुझे? Anybody can do it. Okay, so don't be so motivated about writing antibiotic. Learn to write them nicely, learn to write them with the correct patient, and learn to withdraw them early. That is your style of managing for these patients. Okay, I will move on to the next section. MRSA, क्योंकि ये लिटरेचर वेस्टर्न कंट्रीज से आती है जहां MRSA का इंसिडेंस होता है. अमेरिका में जाएंगे 10%, वेस्टर्न यूरोप में जाएंगे 2%, इंडिया में आएंगे 5%. तो वर्ल्ड वाइड डाटा देखें MRSA का केवल 5%, सारे इन्फेक्शंस का आईसीयू में 5% MRSA है. लेकिन क्योंकि ये वेस्टर्न लिटरेचर, ये इसमें जितने भी गाइडलाइंस वाले लोग हैं, केवल यतिन मेहता को छोड़ दूं तो कोई भी इंडिया का नहीं है पूरे इस गाइडलाइन के अंदर. ओके, सो दीज आर ऑल वेस्टर्न मीडिया पुश्ड गाइडलाइंस. हाई रिस्क ऑफ MRSA, यू नो योर MRSA burden. Upfront you can use MRSA cover. on the day 1 of writing an antibiotic for your patient. Low risk of MRA, please don't use it. Next, our problems are MDROs, gram-negative MDROs. Previous recommendations for was broad spectrum antibacterial. कितने broad spectrum? 1, 2, 3, 4 कितने antibiotic use करना है? Recommendations are for 2 gram negative cover, not for 1 gram negative cover. Recommendations for 2 gram negative coverage. Empirical, septic shock, day 1, day 0. अभी हम क्या लिखते हैं? एक carbapenem plus an MRSA. Now they are pushing the idea of writing 2 gram negative coverage plus an MRSA if the risk is there of the percentages rise. So there are changes, there are subtle changes happening because literature is changing, evidence and support is changing. So you have to change with times. I am changing with what I am reading. I am sure you are wise enough to learn these things and move on. Don't get stuck on two ideas कि हम तो एक ही ग्राम नेगेटिव लिखेंगे. ये पुश कर रहा है आइडिया कि हम 2 ग्राम नेगेटिव लिखेंगे, एक MRSA लिखेंगे सेप्टिक शॉक के पेशेंट को. ओके, दे आर पुशिंग दिस आइडिया नाउ. मूव एंटीबायोटिक टाइमिंग, अगेन सेप्टिक शॉक प्रेजेंट है तो बहुत जल्दी विद इन 1 आवर. सेप्टिक शॉक एब्सेंट है तो 3 घंटे का टाइम है एंड देन यू ट्राई एंड डिसर्न. आई एम जस्ट फिनिशिंग इट ऑफ फास्ट एंड एनफ. न्यू थिंग्स दैट हैव कम आर रिस्क स्ट्रैटिफिकेशन. पहले एंटीबायोटिक्स लिखते थे, फिर आया एंटी फंगल लिखें, फिर तीसरा आया एंटीवायरल भी लिखें. तीनों चीजों को डाल दिया. अभी पुश कर रहे हैं आइडिया कि एंटी फंगल की रिस्क स्ट्रैटिफिकेशन करें. ओके, MRSA का रिस्क स्ट्रैटिफिकेशन करें एंड देन पुश दी एंटीबायोटिक एंड दी एंटीमाइक्रोबियल और दी एंटीफंगल इनटू योर पेशेंट. एंटीवायरल नो प्लेस फॉर द मोमेंट इन सेप्टिक शॉक मैनेजमेंट इन दी ICU. ये सब यूज करने के लिए अब आ गया PKPD के बिना नॉलेज. इसलिए मैंने कहा लिखना बड़ा आसान है, ये जानकारी चाहिए. ये बिना MIC वैल्यू तो जानोगे नहीं. तो आपका माइक्रोबायोलॉजिस्ट इतना ट्रेंड नहीं है कि जो आपको MIC दे रहा है तो आप ये करोगे क्या? तो सहारा में क्या करोगे? सहारा क्या बोल रहा हूँ, मतलब सब सारण डिस्ट्रिक्ट्स में क्या करोगे? इंडिया में भी बहुत सेंटर्स है. वी डोंट नो दी MIC. हाउ आर यू गोइंग टू डू दिस? सो दीज आर रिकमेंडेशंस कमिंग फॉर पुशिंग दीज आइडियाज. थर्ड एलिमेंट विच इज कमिंग इज कोर्स ऑफ एंटीबायोटिक. कितने दिन? शॉर्ट इज बेटर. स्मॉल कोर्स 5 days 6 days. 10 दिन नहीं देना है. किस में नहीं देना? किसमें नहीं देना? जिसमें आपने सोर्स कंट्रोल कर लिया, जिसने आपने सोर्स आइडेंटिफाई कर लिया, उसके लिए शॉर्ट कोर्स. हाउ शॉर्ट? 5 days. तो प्रिस्क्रिप्शन में 5 दिन लिखें केवल, कि गलती से वो जो MBBS वाले ने जिसने लिख दिया था वो 10 दिन ना चला दे. आप तो समझदार हैं, तो उसको ही आदत डालें कि वो 5 दिन से ज्यादा लिखना ही बंद कर दे अपने किताबों में एंटीबायोटिक. डोंट लेट एनी एंटीबायोटिक प्रिस्क्रिप्शन बियॉन्ड 5 days इन योर प्लेस if you have a better source control. Okay, if your source control कर ही नहीं सकते, कैथेटर प्रेशियस है, निकाल ही नहीं सकते, सोर्स ऑफ सेप्सिस ऐसा है मैं उसको टैकल ही नहीं कर सकता, तो probably the antibiotic course will increase, otherwise it has to be just 5 days. Okay, next, वेंटिलेशन में ज्यादा कुछ चेंज नहीं है, लेकिन HFNC, कोविड का फायदा HFNC समझने लग गए. NIV से पहले HFNC आ गया. 2016 की गाइडलाइंस में HFNC नहीं था. अब जहां पे भी हाई फ्लो ऑक्सीजन की जरूरत पड़े, डिमांड की जरूरत है, HFNC आएगा बियॉन्ड NIV. ओके, रेस्ट रिकमेंडेशंस ज्यादा चेंज नहीं करते. VV ECMO अगर आप रिसोर्स पुअर हैं तो वहां नहीं कर पाएंगे, रिसोर्स फुल हैं तो वहां आप कर लें. एडिशनल थेरेपीज, स्टीरॉइड, यस स्टीरॉइड स्टिल कंटिन्यू टू प्ले प्रोवाइडेड वॉल्यूम रिसस्टेशन कर लिया, एंटीबायोटिक सही कर लिया, नॉरेड लगा दिया, वैसोप्रेसन लगा दिया, ongoing continuation चल रहा है. You have to use 200 milligram total, 50 QID, hydrocortisone, it is still there. Against जो आया recommendations, poly B hemoperfusion, do not use this therapy. There are strong recommendations for against this poly B hemoperfusion, यानी blood purification strategies के against है. Company guys will come to you, give you lot of, आपको यूरोप का ट्रिप करा देंगे, आपको वहां का करा देंगे. प्लीज लुक एट दीज रिकमेंडेशंस. दे आर नॉट इन फेवर फॉर एनी ऑफ दीज थेरेपीज. डोंट गो बाय देम, डोंट लर्न थिंग्स फ्रॉम देम. ओके, सो 2016 है ये सारा. इसमें नया क्या ऐड हो गया? HFNC ऐड हो गया. ठीक है, यही ऐड हुआ केवल. नेक्स्ट, ये 2016 है, डेलिंगर का है. वहां पे क्या यूज हुआ? सब कुछ वही हुआ, बस नॉरएपिनेफ्रिन की डोजिंग आ गई. वैसो को 0.25 के ऊपर जब जाएंगे वैसो ऐड कर देंगे. पहले में था कि अगर फ्लूइड रिसस्टेशन के बाद नहीं, केवल यही डिफरेंस है और सब कुछ वैसे ही चलना है. आई एम स्किपिंग दी स्लाइड्स. अगेन सोर्स कंट्रोल इंपॉर्टेंट है. ये सब अगर आप रिसोर्सफुल हैं तो ना आपके पास अल्ट्रासाउंड है, ना आपके पास बेड साइड रेडियोलॉजी है, ना आपको इको आता है. तो अगर आप रिसोर्सफुल हैं तो अपनी आंखें हैं और हाथ है और कैथेटर देखना आता है, इन्फेक्शन पहचानना आता है. दैट इज योर रिसोर्स रिच एंड रिसोर्स पुअर. लास्ट, ये सब जगह परमिएट कर रहा है, एवरीवेयर इट इज एंटरिंग एवरीवेयर. पॉइंट ऑफ केयर अल्ट्रासाउंड is going to is the next stetho, or it is already replacing the stethoscope for the intensive care and the emergencies and the wards. So this is what is changing the paradigm. Use this false protocol to understand, because मेरा topic था septic shock / shock. तो ये है false protocol जो आपको help करेगा obstructive, cardiogenic, hypovolemic, septic shock को guide करने के लिए. I think I'll end this slide now. इनिशियल फ्लूइड रिसर्सिटेशन 3 घंटे का टाइम याद रखें, 3 घंटे में सब कुछ करना है फ्लूइड के लिए. चॉइस ऑफ फ्लूइड, बैलेंस सॉल्ट, अर्ली वैसोप्रेसर, नॉरएपिनेफ्रिन प्रिफर्ड. लैक्टेट ट्रेंड्स को फॉलो करना जरूरी है. वन टाइम वैल्यू डज नॉट कैरी एनी वेट टू मी. यू हैव टू फॉलो द ट्रेंड एंड सी फॉर पेशेंट्स ऑन whom the lactate is high. But remember, shock में lactate normal भी रह सकता है. You will never find lactate high in some of the patients of shock. So don't be misguided कि lactate नहीं बढ़ा है इसलिए shock नहीं है ना, इसलिए सेप्सिस नहीं है, इसलिए पुअर परफ्यूजन है. डोंट बी मिसगाइडेड बाय द सिंगल वैल्यू ऑफ अ लैक्टेट. अर्ली एंटीमाइक्रोबियल विद रिस्क स्ट्रैटिफिकेशन. रिस्क स्ट्रैटिफिकेशन किसके लिए? एमआरएसए के लिए. रिस्क स्ट्रैटिफिकेशन फंगल इन्फेक्शंस के लिए. यू हैव टू डू दैट. वायरल और एंटीवायरल्स का अभी फिलहाल के दिन में नहीं है. मे बी व्हेन द नेक्स्ट टाइम कम्स, मोर लिटरेचर अवेल्स, यू विल हैव राइट अ ब्रॉड स्पेक्ट्रम एंटीवायरल इन योर प्रिस्क्रिप्शंस आल्सो. शॉर्टर कोर्स 5 days अगर सोर्स कंट्रोल है. अच्छा, PCT for de-escalation, not for inclusion. Okay, I did not talk about PCT. PCT हम पहले यूज कर रहे थे कि इसको एंटीबायोटिक देना है इसलिए यूज करना है ना. इट हैज गॉन आउट. इसको बंद करना है कि नहीं करना है, 5 दिन काफी है कि नहीं काफी है इसके एंटीबायोटिक. एंटीबायोटिक बंद करना है, PCT बेस पे करना है. ओके, दीज आर रिकमेंडेशंस. गुड सोर्स कंट्रोल was important in 2016, is important. Good luck for a patient with septic shock. Sorry for overstripping my time. Thank you for the call, and thank you for a patient hearing.
Thank you.
It's too big a topic to be covered in 20 minutes. I've just tried and squeeze it. Thank you. If there are any questions, I think.
Thank you, sir. It was an excellent talk as usual. It's an honor to chair the session where sir is speaking. Sir happens to be my teacher from SGPGI, and sir's talks and slides are always excellent, as we saw today. So before ending the session, we invite the questions if anybody wants to ask questions on the 2 topics that we had.
Dubey can come up. No questions, then I can sit.
If there is no question, so I have a few questions. So
I may have skipped a lot of segments because there are 67 recommendations. I have taken only the ones which are bluish, which are updated from 2016. So I have left out lot of materials in this. So please.
So one thing regarding antibiotic de-escalation. So you said in cases where we have adequate source control, especially in abdominal sepsis, and it is recommended that it's 3 days to 5 days or 6 days therapy.
Good source control 5 days.
So and the concept of de-escalation starts from 3 days.
3 days.
So when we get a culture and we suppose we have sensitivity to ceftriaxone and we are continuing with piperacillin tazobactam, and on 3rd day we got this, so shall we continue for another
We are
days?
talking of septic shock patient.
Septic shock patient.
So if septic shock is there, piperacillin tazobactam is not considered.
Patient is improving.
Okay.
Patient is improving with piperacillin tazobactam. This is a real life scenario. Means everybody might have got this kind of patient, and now it's a 5-day therapy we are going to give. Patient is improving on piperacillin tazobactam. So shall we?
If the perfusion markers are improving, organ paraphernalia is improving for my patient, procalcitonin is on a downward trend, lactate is not rising. If all those parameters plus source control is there, I can definitely switch over my therapy from a piperacillin tazobactam to a more sensitive brand which will come, because it is dependent on this turnover time of my cultures which come. Usually 3 दिन में भी culture नहीं आते, अच्छे सेंटर्स पे भी नहीं आते, और आई एम श्योर KGMC में भी नहीं आते 3 दिन के अंदर कल्चर्स. तो ज़्यादातर तुक्केबाजी होती है कि ये कर दिया है 3 दिन में, ये करें कि नहीं करें. यूजुअल ट्रेंड्स यही है सब जगह, PGI में भी ऐसे ही है. हमें 3 दिन में कल्चर्स नहीं मिलते हैं.
Sir, actually, there is increasing literature on gut microbiome.
Yeah.
So, and de-escalation.
So जो de-escalation of gut microbiome है, even one dose of an antibiotic will influence your gut microbiome, ठीक है, इसलिए FMT वगैरह की तरफ लोग लिटरेचर जा रहा है, इसलिए C. diff और इन सब के बारे में लोगों को डर लग रहा है, इसलिए वो शॉर्टर कोर्स ऑफ एंटीबायोटिक के लिए प्रिस्क्राइब कर रहे हैं. अगर स्टेबिलिटी आ गई है 5 डेज के अंदर, वैसोप्रेसर ऑफ होने वाला है 5 डेज के अंदर, तो एंटीबायोटिक क्यों चाहिए मेरे पेशेंट को? सो वो एग्रेसिव अप्रोच चाहिए, क्योंकि अब आपको बैलेंस चाहिए लिटरेचर में कि कितना माइक्रोबायोम हिट हो गया, कितना सी डिफिसिट का पेशेंट हिट हो गया, कितना एंटीमाइक्रोबियल रेसिस्टेंस बढ़ गया. आई डोंट हैव दैट लिटरेचर अवेलेबल ऑन अ बेड साइड राउंड विद मी टू अंडरस्टैंड दिस. देयरफॉर हमारा एक ग्रे जोन रहता है कि 5 दिन ठीक है कम कर देंगे, लेकिन अच्छा चलो एक आध दिन और कर देते हैं, खींच देते हैं. प्रैक्टिकली यही होता है, क्योंकि हमारे पास वो लिटरेचर अवेलेबल नहीं है अभी. I don't know. So there will be a grey period between indecision to decision. So वो 5 दिन, अगर मैं 3 दिन से सोचना शुरू करूँगा तो शायद 5वें दिन पे I will be in a better position to consider stopping of a medication if all those parameters which I have told you are improving for my patient. That is what I will take. Plus there is an antibiotic, post-antibiotic effect different for each of the antibiotics. So वो मुझे पता होना चाहिए कि अगर मैं कार्बोपेनम यूज़ करूँगा तो इसका पोस्ट एंटीबायोटिक इफेक्ट कितने घंटों तक रहेगा. अगर मुझे ये मालूम है तो मेरा डी-एस्केलेशन में जल्दी हेल्प होती है कि आई कैन स्टॉप इट. आई एम वेरी वेल हैप्पी कि आई थिंक दिस वुड बी मोर प्रैग्मेटिक वे ऑफ सेइंग रादर देन अ वेरी डिसाइसिव डे कि 5वें दिन पे मैं बंद कर दूँ. आई हैव टू टेक, अगेन गाइडेंस है, विजडम तो आपके पास है बेड साइड की, वो आपको यूज़ करनी है. ठीक है
Sir, next question again. As you said, when the norepinephrine is increasing 0.25 mics per kg, we will have to add vasopressin. What about tapering?
Provided the fluid आपने resuscitation
Yes,
से
sir.
किया.
Yes, sir. That is precondition. What about tapering? Which one to stop or which one to taper when we have both the vasopressin?
So what we tend to do is 0.2 के नीचे अगर नॉरेड आने वाला है तो वेसोप्रेसिन आउट होना है, नॉरेड आउट नहीं होना है. ये स्ट्रैटेजी हम अभी भी यूज़ करते हैं और आज पिछले मेरे ख्याल से 15 साल से यूज़ कर रहे हैं. लेकिन वो 0.25 पे नहीं कर रहे थे, वो हम 0.1 पे कर रहे थे. तो वो थोड़ा सा चेंज अभी आएगा, क्योंकि अब 0.2 पे वेसोप्रेसिन को आउट कर देना है अगर उससे नीचे आ रहा है, एंड देन कंटिन्यू विद द नॉरेड. हम कब कर रहे थे? 0.1 पे कर रहे थे. 0.1 तक जब तक कि नॉरेड नहीं गिर रहा है तब तक वेसोप्रेसिन को आउट नहीं कर रहे थे. 0.1 आते ही वेसोप्रेसिन आउट और नॉरेड पे ही कंटिन्यू कर रहे थे. दैट वाज दी स्ट्रैटेजी. आई थिंक इट विल चेंज. 0.2 हो गया, डबलिंग हो गई बेसिकली डोज की. 0.1 टू 0.2 पे चला गया है.
Sir, just wanted to ask about my understanding. What I understand is we are adding noradrenaline to we are adding vasopressin in a NORAD refractory septic shock. So if we have added vasopressin and the NORAD is decreasing, that means the patient is having vasopressin insufficiency or deficiency.
Vasopressin insufficiency का literature available है. 24 to 48 आवर्स के अंदर वेसोप्रेसिन की insufficiency दिखती है. इसलिए वो इनिशियल आवर्स में नॉरेड देने के बाद में आपको वेसोप्रेसिन की जितनी भी स्टडीज़ आई, चाहे वो मैं नाम याद नहीं रख रहा, लेकिन नंबर ऑफ स्टडीज़ जो वेसोप्रेसिन को सपोर्ट, ये इसी आइडिया पे आई कि आपकी रिलेटिव इंसफिशेंसी होती है विद दी वेसोप्रेसिन लेवल्स इन दीज पेशेंट्स, इसलिए ऐड करते हैं. आई बिलीव जब आप रिसर्स्टेट सही कर रहे हैं, एंटीबायोटिक सही कर रहे हैं, नॉरेड का टेपरिंग की तरफ जा रहा है, तो आई बिलीव ये इंसफिशेंसी कम हो रही है, जिसके लिए, क्योंकि वो विंडो पीरियड है 24 से 48 घंटे का, जहाँ पे इंसफिशेंसी डॉक्यूमेंट की गई है. देर इज़ वेरी लेस लिटरेचर अवेलेबल बियॉन्ड दैट 48 आवर्स, इसलिए अभी रिकमेंडेशन उस तरह से नहीं आए हैं कि हम इसको कैसे करें. लेकिन टाइट्रेशन आपने सही बताया, 2 वेसोप्रेसर्स और 1 वेसोप्रेसर में स्विच ओवर थेरेपी क्या है. अभी भी लिटरेचर इसको सजेस्ट कर रहा है कि नॉरएपिनेफ्रिन को पूरी तरह हटाने से पहले वेसोप्रेसिन हटा लेना है. ठीक है, ये आइडिया अभी भी रैम्पेंट है लिटरेचर में. आई कैन से दिस पॉइंट.
Thank you, sir. Yeah, please.
Element. Then, sir, any difference in resuscitation or the same?
Ischemic heart disease में vasopressin is not recommended.
No, sir. I am asking about resuscitation.
रिसर्स्टेशन अगेन दी टाइप ऑफ फ्लूइड और कितनी रैपिड है वो है, 3 घंटा मैंने लिखा है ना उसके अंदर, वो उस पेशेंट्स के लिए रिकमेंडेशन है जिनका हार्ट डिजीज़ नहीं है, जो रीनल फेलियर में नहीं है, वो 30 ml से वो घट के वॉल्यूम आती है, प्लस वो जो टाइम पीरियड 3 घंटे है वो थोड़ा सा और एक्सपैंड होता है, बोलसेस छोटे हो जाते हैं, डायनेमिक इंडेक्सेस को मेजर करने की इंटेंसिटी बढ़ जाती है. दैट इज़ व्हाट इज़ बीइंग रिकमेंडेड. आई थिंक आई शोड वन स्लाइड इन 2016 जहाँ पे उन्होंने 3 कैटेगरी किया. एक पेशेंट जो हाइपोक्सिमिक हो रहा है, ठीक है, एक पेशेंट जिसको कि ESRD है, उसमें वॉल्यूम को कैसे देना है, जो हाइपोक्सिमिक हो रहा है उसको सपोर्ट देना है, या तो बाइपैप से पहले बोल रहे थे, अब HFNC से देना है, उसका वॉल्यूम का रेट स्लो कर देना है. उतनी स्पीड से नहीं दे सकते आप उसको, तो सपोर्ट के साथ तो दे सकते हैं. जैसे इंट्यूबेट कर दिया तो दे सकते हैं, लेकिन अगर इंट्यूबेट नहीं किया और आप वॉच कर रहे हैं, HFNC पे है, तो वो फ्लूइड 30 ml पे नहीं दे पाएंगे. तो देर आर, आई डिड नॉट कोट दिस स्टडी, 2018 में देयर वाज अ स्टडी कि लेस देन 20 ml पर केजी दें, 20 से 30 ml पर केजी दें, या 30 के ऊपर दें. तो सबसे अच्छे रिजल्ट 20 से 30 ml पर केजी वाले के लिए आए, लेस देन 20 वाले के लिए रिजल्ट अच्छे नहीं आए, 30 के ऊपर वाले के लिए भी रिजल्ट अच्छे नहीं आए. तो ये हमें क्या बता रहा है? ये हमें बता रहा है कि 20 से 30 तक मैं सेफ हूँ, 20 के नीचे पे जाने पे हो सकता है मेरा किडनी खराब हो जाए, 30 के ऊपर जाने पे हो सकता है मुझे वेंटिलेटरी डिमांड हो जाए. अगेन विजडम, बेडसाइड अंडरस्टैंडिंग वो चाहिए, इसलिए इकोकार्डियोग्राफी आया. बी लाइन्स है कि नहीं है लंग में? बी लाइन्स हैं तो वॉल्यूम क्यों पुश कर रहे हो इतना? विदाउट बाइपैप या विदाउट HFNC या विदाउट इंट्यूबेशन ये वॉल्यूम इतना फास्ट क्यों पुश कर रहे हो? तो ऑब्वियसली जब CHF का पेशेंट होता है, हम उसको 5 मिनट में तो फ्लूइड नहीं देते, उसको हम आधे घंटे में देते हैं, 1 लीटर 500 ml जो भी देना. तो ऑल दैट स्ट्रैटेजी हैज़ टू बी यूज. अगेन कार्डियक फेलियर आपने स्पेसिफिकली पूछा, वहाँ पे इंट्रिंसिक बोलसिस वर्सेस एक्सट्रिंसिक बोलस का स्टडी होता है. एक्सट्रिंसिक मैंने बाहर से 500 ml दे दिया, इंट्रिंसिक मैंने PLR करके 60 to 90 सेकेंड पे असेस कर लिया. हीमोडायनेमिक वेरिएबल्स वहाँ पे मैं यूज़ कर सकता हूँ. ये आपका इंट्रिंसिक स्ट्रेटजी जो मैं इंट्रिंसिक फ्लूइड बोलस को मैं आपको बता रहा हूँ, PLR का सेगमेंट बिना पानी दिए एक्चुअली में रिस्पॉन्स देख लेना कि इसका कार्डियक आउटपुट 15% से ज़्यादा इंक्रीज करेगा कि नहीं करेगा. दिस इज़ व्हाट हैज़ टू बी यूज्ड फॉर कार्डियक फेलियर. ओके. और रीनल फेलियर के पेशेंट्स में ऑब्वियसली यूरिन आउटपुट होता है इंपॉर्टेंट एक मार्कर. कुछ पेशेंट्स डायबिटिक होते हैं लेकिन उनका लैसिक्स इंड्यूस वो आउटपुट होता है और किडनी भी फंक्शनल नहीं होती, उनके लिए थोड़ा आइडिया अलग होगा. जो एन्यूरिक हैं उनके लिए आइडिया अलग होगा. ठीक है, वो रिसर्स्टेशन वॉल्यूम चाहिए. इतना सेप्टिक शॉक में इंट्यूबेट, शॉक रिसर्स्टेशन, डायलिसिस, CRRT, स्लेड, ये सारे एलिमेंट्स आएंगे. अगेन ये ऐसी सीढ़ी नहीं है कि ये करूँगा फिर ये करूँगा ये करूँगा, कई बार सारी चीज़ें साथ करूँगा. ठीक है, आप करते हो, पेशेंट सिक होता है तो आप उसको ऑक्सीजन भी लगा रहे हो, उसको लैसिस भी दे रहे हो, उसको प्रॉपडअप भी कर रहे हो, उसको नेबुलाइजेशन भी दे रहे हो, उसको बाइपैप की तैयारी भी कर रहे हो, सेंट्रल लाइन. सो यू आर डूइंग सो मेनी थिंग्स साइमल्टेनियसली, प्लस एंटीबायोटिक भी लगा रहे हो. कल्चर नहीं निकाला लेकिन एंटीबायोटिक भी लगा रहे हो. So you have to strategize your patient. Again, these are guidance, not your wisdom. You still have to use it. Okay?
Thank you, sir.
This is excellent discussion and a detailed discussion. Very nice to hear all the discussions. One question I would like to ask from Dubey sir on his first talk on beta-Electamase inhibitors and antibiotic stewardship is, this was a very good talk and a big topic to cover in 15 minutes. There were 2 separate topics and both of them are detailed topics in their own. And as rightly said, as not many antibiotics are coming up, infection control and antibiotic stewardship have a long way to go, and the rational prescription of antibiotics to conserve the antibiotics and to be safe and effective with the currently available antibiotics. As far as the antibiotic resistance is concerned, beta-lactamases tend to be, as already told by Sir, class A to class D, several types. Class A, ESBL, then we have B, C and D. And whatever the existing BLIs that we have generally tend to, like sulbactam, tazobactams and clavinates, are effective against the class A, most of them, and some against KPC type carbapenemases in class A. And still we don't have pan beta-lactamase resistant type covering all the classes, especially the class B beta-lactamases, the NDM varieties and all. They tend to be quite resistant. So my question is, and they may be coexisting several beta-lactamases in one bacteria, not just one class, maybe several classes. And besides one mechanism of resistance, there may be several mechanisms coexisting, like a beta-lactamase inhibition, and there are some modification in the cell wall or cell membrane or the binding receptors like the OPRD or the channels also besides the beta-lactamases. So with this limitation about the currently beta-lactamase inhibitors that we have, and also the recent ones like avibactams and the boronates that we have, avibactam, are not covering the MBL still. So how do we go about in the bedside practice in this current scenario, where we have quite significant number, or not significant, still a substantial number of class B also beta-lactamases. So how do you suggest that, what is the current role of BLBLIs in carbapenem sparing as a carbapenem sparing strategy, so that we can, rather than using left and right carbapenem in every type of sepsis or every type of shock, the BLBLIs rather step up and either spare the carbapenem or enhance the efficacy of carbapenem. Number one, where do we use it, and is it the same part of the question, is it empirical use, targeted use, or for term de-escalation? So how do you would like to suggest it based on your extensive discussion of the topic?
Regarding the first question, like we can assess the carbapenimases A, B, C and D via few tests like CarbaArg kit or a BioFire, the PCR panel, which can identify the genes, whether it is class B, MBL, IMP, VIM or NDM, or we can assess OXA23, OXA58, or we can assess their only KPC or KPC with MBL. So these are a few things via which we can diagnose. The other thing is that on the basis of our antibiogram and the genes report we had tested in previous patient, accordingly we can extrapolate to the data when we are deciding the things empirically. So as you asked regarding BLBLI, novel BLBLI. So as I mentioned, in current we have only one novel BLBLI, that is ceftazidime avibactam. So we have to be very much clear about the spectrum of coverage of ceftazidime avibactam, and if we are creating ceftazidime avibactam to Tnm avibactam. So in both the scenarios it is not covering CRAB at all. So for CRAB, like carbapenem resistance Dr. Bomani, we have to consider nowadays sulbactam as a newer BLI. Like previously we are using in a dose of up to 6 grams per day, but now the recommendation up to 9, sometimes up to 12. So we can smartly use sulbactam as a second agent in combination with polymyxins. So here we can use only BLI with the polymyxins to cover the CRAB. If culture goes carbapenem resistant Enterobacter Bomani. If we have sensitivity for tetracycline, minocycline along with polymyxin, there is no need to go for sulbactam directly. But if we have only option of polymyxin monotherapy, then we can use sulbactam here. Other than Enterobacter Bomani, if I discuss about Pseudomonas and the Enterobacteriaceae, so Enterobacteriaceae are smartly covered if we are using Tnm avibactam. For that, there is a sequential disc testing. One is the overlap testing. We can assess sensitivity in synergy for Tnm as well as avibactam. So that needs a specific microbiological lab testing. For that is called as either sequential testing or a synergistic testing for Tnm avibactam. So nowadays ICMR 2020 guidelines also recommends that if a culture is carbapenem resistance, even showing sensitivity for polymyxins, but if you have facility for synergistic testing of Tnm avibactam, and if it comes positive, then first line therapy is Tnm avibactam over polymyxins. But you have to test for that. And if the testing is not available, then obviously polymyxins are the first line therapy along with the other sensitive drug. If I go for the how to use polymyxins, the IDSA, SCCM and ESICM guidelines of 2019, I think. So in that they recommend not to use polymyxin monotherapy directly and use the second drug with polymyxins, which having a either sensitive, or if all resistance, then use the drug with the lowest MIC. But nowadays we are facing, I think you all are facing, meropenem is showing a resistance of MIC more than 16 usually. So 2 gram TDS fundamental is not in use, not useful in that scenario. So here we have to create a some drug to avoid polymyxin monotherapy. Now what are the some drugs? We have to assess for other non-beta-lactam like phosphomycin, tricycline, minocycline, all these options. If no option is available, then we have to come on again BLBLI to use a second drug with polymyxins. So option are, one is high dose sulbactam, one is ceftazidime avibactam, and other is Tnm avibactam. So we can assess sensitivity like most of the labs, and Vitek 2 is not testing for sulbactam directly. But if you in cultures, cephalosporin sulbactam is tested in Vitek 2. If you get a sensitivity in I, intermediate, MIC of 32, that means sulbactam is working on that. So we can use high dose sulbactam there. So this is the one way to assess the sensitivity for sulbactam. For Tnm avibactam, we can, as I said, we can directly test for sequential testing or synergistic testing. So these are the few ways by which we can handle these kind of situations.
Detailed microbiological backup, assessing all these things, which type of, what is the MIC, what is the type of the enzyme, only then we can be safe with the current usage of BLBLIs. That's what I take home. Still then, there's a lot of work to be done. Many new future BLIs may be in the lineup. Maybe they will answer the question more effectively. Thank you so much.
Thank you.
Thank you both the speakers, Dr. Dilip Dubey and Dr. R.K. Singh sir, for the excellent presentation and discussion. We announce the session closed. Thank you so much. Thank you all of you.
Thank you, sir. Thank you, speakers and chairpersons, for conducting a remarkable session. Now I invite Dr. Ved Prakash sir and Dr. T.P. Singh sir to felicitate our speakers and chairpersons for this session. Dr. Dilip Dubey sir and Dr. R.K. Singh sir. Chairpersons, kindly join. Huge round of applause, please. Dr. R.K. Singh sir. Dr. Haider Abbas sir. Dr. Suhail Siddiqui sir. Dr. Syed Nabil Muzaffar sir. Thank you sir. Yes. Moving on to the next session on lung cancer. I'll first invite the chairpersons for this session. Dr. Avinash Agrawal sir. He is a professor and chairman Department of Critical Care Medicine at KGMU. Dr. Ram Narayan sir, he is HOD Department of Pulmonary Medicine at Balrampur Hospital, Lucknow, and Dr. Isha Jaffa ma'am, Assistant Professor Department of Medical Oncology in KGMU.
Good morning everyone. Now we are starting a second session that is on lung cancer, And our speaker for this session is Dr. Ashish Tandon from Prayagraj. Dr. Ashish Tandon has done his MBBS and MD, MBBS from Lucknow King George Medical University and MD from Motilal Nehru Medical College, Allahabad, and working as Director and Chief of Consultant Respiratory and Sleep Medicine at Prayagraj at Hriday Super Specialty Hospital with special interest in interventional bronchoscopy and sleep medicine. Dr. Ashish, please.
Hello. At the outset, I am thankful to the organizers for inviting me here. Topic is staging of lung cancer, but I was asked by Dr. Ved that we have to focus more on the pulmonologist side and we have to see from the bronchus how the carcinoma looks. So the 8th Tnm classification is basically followed everywhere, where we see the tumor size, the nodal size and the nodal patterns and the metastasis. We all know and we have all been studying the Tnm classifications throughout T1, T2, T3 and T4, where the sizes vary from less than 3 centimeter to 3 to 5 and 5 to 7 and more than 7 centimeters. And according to the invasions, the T1, T2 and T3 is classified, and if it is more than 7 and involves the invasion of mediastinum, diaphragm, heart, great vessels and recurrent laryngeal, carina, trachea, esophagus, spine or separate tumors in different lobes of the ipsilateral lung, then it is T4. So my job has been given to carry forward the nodal assessments and how as a pulmonologist we are faced with the challenges of the nodal enlargements and how to go about it. So N1, N2 and N3 is the classification. N1 means ipsilateral peribronchial and or hilar lymph nodes or intrapulmonary lymph nodes. N2 is ipsilateral mediastinal or subcarinal lymph nodes, and N3 is contralateral mediastinal or hilar, ipsilateral, contralateral or supraclavicular scalene muscles involvement, or distance metastasis may be M1 means M1A or B, it can be contralateral lung or pleura or pericardial nodule or malignant effusion, and M1B means single extrathoracic metastasis including single non-regional lymph node. M1C means multiple extrathoracic. So this is the classification where nodal stations have been defined, and they are all seen nowadays from our EBUS scope and how it looks like, and it is very fascinating to do the procedures, interventional procedures, and do the staging. So these are all the boundaries where we see where the R means on the right side and L means on the left side. Can I have the pointer please? Pointer. So 2R, 4R, 7 and 10, they are basically very important lymph node from a bronchoscopist point of view, and usually when we see our patients, we are called for or see the patients to see the nodes whether they are malignant or non-malignant. These are the boundaries where 2R is the upper tracheal, 4R is lower tracheal, then you have hilar and the subcarinal, which is important group of lymph nodes. And this is how it looks, and its relation with the different vascular structures, and accordingly they have been identified. Superior mediastinal, aortic, inferior mediastinal, or N1 lymph nodes, which are hilar or interlobar lymph nodes. Accordingly it has been classified, and accordingly the boundaries have been demonstrated. The left border of the trachea forms the boundary for the 4R lymph node. It can extend till the left border of the trachea, and the 10L is the hilar one and the subcarinal one. Above the arch of aorta is the 2R. So why it is important? Because subcategorization and doing a Tnm classification leads to the yield where the patient can be surgically resected, or surgical intervention can be done, or radiation or chemo wherever is required, and also to prognosticate the things. So this is how we look for the different lymph nodes, the various lung masses and its relation with the things. This is the scope where we do the scanning or the EBUS, and with this needle we find the different lymph node FNACs and reach our final diagnosis. EBUS is basically for looking into these lymph nodes and is sampling them and doing the proving the outcome, or doing the biopsies which are in the form of core biopsies. The 4R lymph node, you can see this is close to the trachea, whereas the lymph node 6 station cannot be assessed from the EBUS scope. So 5, 6, 8 and 9 you cannot sample from the EBUS. You have to use the EUS scope, or you have to go through the esophagus. Otherwise, other than that, you can assess from the EBUS scope. 4R, this is 4L, you can see this is 4L, and the 5 and third 3A, they are farther to the airways, so they cannot be assessed through this. Okay, so these are the lymph nodes. This is very close to the airway, so it can be sampled very easily. 10, this is very close to the airway, so it can be sampled very easily. So these are the techniques where you have 6 regions: upper tracheal, lower tracheal, then you have right main upper part, then you have bronchus intermedius, then left upper and the left lower. These are the 6 major regions where you can sample the lymph nodes and take out the samples easily and classify them according to the TNM staging, and the different relations with the different relations of the vascular structures and the airways, where you can put in the scope, access, and then you can identify those structures through the ultrasound, and you can identify the various hilar and the relation with the lymph node. This is basically from the article the Dr. Malay Sharma has beautifully elaborated in his things, that there is the concept of rods and dots. So what are the dots? The dots are basically left brachiocephalic vein, the pulmonary artery, the pulmonary vein, and the arch of aorta. They look in the form of dots when we see the lymph node when we see through the EBUS scope. And the concept of rods is we see these structures or straight lines where you have superior vena cava, the aorta or the great vessels of the neck. They appear in the form of rod. So this is the structure where you can see when you scope through, you can see this is the arch of aorta in the form of dot, and the left common carotid artery and the brachiocephalic vein. So this is how you identify the vessels, and you can see this. This is the azygous vein and the superior vena cava, beautifully designed, and you can see the lymph node over and above this superior vena cava. So the rod you can identify superior vena cava, and over it is the 4R lymph node which is placed. Likewise, you can see the subcarina. Subcarina can be assessed both from right and the left side, and the vascular structures you can see in the form of dots like right pulmonary artery, pulmonary vein, and the aorta, which is real time seen like this in the sub-aortic space or the subcarinal space. So this is the structure in the left side, where you can have left atrium, left ventricle, and the aorta, and the vascular structures can be easily identified through the EBUS scope. Because of the paucity of time, I have to run fast and show you the how it looks like, how it seems from the inside. This is the descending aorta from the left bronchus. If you see from the left bronchus, this is how it looks like. And the part from the left side where you see the left atrium, the mitral valve and the left ventricle can be seen through this. So if you see, the left main bronchus is 2.5 centimeter, the intermediate bronchus is 2.5 centimeter, whereas the left main bronchus is 5 centimeter. The right main bronchus is 2.5, the intermediate bronchus is 2.5. So this is 5 centimeter and this is 5 centimeter, and the space between the two is the subcarinal space, which can easily be assessed. In the previous days, when we were not having any EBUS, it was the best place where we could have put in our blind needle and used to sample the subcarinal lymph nodes from those things. So that is the space where you can easily go through even blindly and take out the sample, and through the scope you can put your scope here and you can go through the subcarinal lymph node from the right side as well as from the left side. The AP window is formed by both the artery and the vein, and this looks like that there is the upper border is formed by the left pulmonary artery, and the lower part you have arch of aorta, and in between you have the 4L lymph node. It is also called Mickey Mouse sign, where you have this pulmonary artery and the arch of aorta, and in between you have a lymph node where you can sample it very easily going through the left main bronchus. If you put in your EBUS scope and rotate it downwards and just pull it little back, you will see this arch of aorta, then a little back you will see this pulmonary artery, and in between you will see the 4L or the lymph node. So you can sample all the lymph nodes 2R, 4R, station 7, station 10, and 4L on the left side and 10L on the left side. And using this, you have right paratracheal space, the pretracheal space, the precarinal space, subcarinal space, and the zygoesophageal recess. And on the left side, you have left paratracheal space, the aortopulmonary window, and the pre-aortic recess, where you can sample the 2R, 4R, 7, 10R, 4L and the 10L lymph node easily, and you can have a good yield as well as the samples from this. So this is the left bronchus. You can see the lymph node over there, and all the major samplings can be done using these 6 regions I have shown you, and this is how it looks like. If I can show you a video, this is from the subcarinal space, and this is how it looks like in real time. You have the azygos going on, and over it you have the big lymph node or the mass lesion. Sometimes you have lymph node, sometimes you have the mass lesion, where you can find the lymph node and you can sample it, and you can have core biopsies, and you can have histology or the tissue sampling. So EBUS TBNA has definite advantages in the staging of the lung cancers, where you find that the lymph nodes N1, N2 and N3 can be sampled from the farthest to the nearest. You start from the farthest, or if you have to see for the metastasis also, then you can start from the opposite or the contralateral side, move on to the farthest lymph node on the same side, or the intrapulmonary or hilar lymph node, and then move on to the mediastinal lymph nodes like subcarinal and the lower tracheal and so forth, and by that you can identify the lymph nodes, the samples, and the histology can also be done. So that is the crux, and I have been told about that you have to tell about the practical nodal staging or nodal sampling from the EBUS scopes, except 5, 6, 8 and 9, where EUS, or you can use even your EBUS scope putting through the esophagus, and then you can sample these 4 lymph nodes from the esophagus side. So this is all about the practical approach, how as a pulmonologist you are going to see the staging of the lung cancer. You can have the tumor size from the CTs, you can measure it and find out what is the size and whether it is invading other surrounding structures or not, and the nodal staging can be done very well from your interventional scope, EBUS scopes, and you can identify the correct staging of the lung cancer, and accordingly the treatment can be planned and the outcomes can be predicted. Prognostically you can identify what is the prognosis of that. So thank you all for the patient listening, and I think I have finished in time.
Yes, sir. You are very well in time. An excellent talk. Now the session is, we will take question answer after the finish of this session, sir. Dr. Ashish?
Yeah.
Oh, okay. Thank you, sir. Now I ask my colleague to introduce second speaker.
Thank you, Dr. Tandon. You have delivered a very nice lecture. Second speaker is Dr. Ajmal Khan. I am giving his brief introduction. He's a professor and in SGPGI Lucknow in pulmonary medicine. His area of interest is in interventional pulmonology and pulmonary critical care. He published 48 national and international papers and 800 citations. And welcome Dr. Ajmal Khan, please.
Thank you, sir. Good morning, everybody. So I will be talking about the targeted therapy in lung cancer, and I believe that this will be entirely different kind of a presentation, because this is something very new in the field, because in a one's lifetime we read the same drug and use the same drug throughout our life, and we retire with the same drug. But this is some area where we can see every 2 months, 3 months, there is some new thing has arrived, and there is a drastic change in the management of these lung cancer through the targeted therapy. So if we see, the lung cancer is the leading cause of cancer mortality worldwide, and most patients, when they present, they are already in an advanced disease, so there is nothing to be offered as for localized intervention as in the form of surgery. So the mainstay of treatment in these patients are the platinum-based chemotherapy doublets, which has typically confers modest survival benefits, and majority develop recurrence of disease within 3 to 5 months. And these traditional cytotoxic therapies are not specific, and they do not discriminate between the tumor cell and host cells. That's why they have a lot of side effects. So there is because of this lack of specificity of the conventional chemotherapy and limited efficacy of these traditional cytotoxic agents, there is a rational design and development of therapies that aims to differentiate between the malignant and the non-malignant cells within the host, with a high therapeutic index and less toxicity than the conventional therapies, and that is the targeted therapy. As for example, if we see, this is a stage 3A lung cancer where the Tnm staging is T4, T3 and N0, N1. And if you see the other variety of stage 3B or 3C, we all have a advanced disease. And in these advanced diseases, the only thing is concurrent chemoradiotherapy or consolidation immunotherapy, or else we can go for a targeted therapy, immunotherapy plus chemotherapy, or a supportive care. So thus, in these patients, we have to, there are multiple challenges, like one is that loco-regional control and the systemic control, as well as the brain metastasis, where most of the therapies are less effective. So for the background therapies, targeted therapies, newer treatment option for lung cancer has proved challenging because the remarkable heterogeneity of the disease in the form of lung cancer, because there is a different histological features, different genomics, and even the molecular biology is different. So there are several oncogenic drivers that can be actively targeted in these therapies. There is a significant advances in the field of targeted therapies because there is a targetable major and minor pathways, technologies for detecting actionable genetic lesions, and there is newly developed drugs to block the activities of the pathway. All of these improve the treatment outcome and quality of life as compared to the traditional chemotherapy. See, as only a decade back, lung cancer was supposed to be a single disease, but if you see, now there was a histological based subtyping, and now there is a molecular level of subtyping. So it is not a single disease, it has a many sub diseases within itself. And nowadays there is can be further classified in lung carcinoma by protein targets. This is a upcoming field. Maybe in a next 2 or 3 years we will have the answer of this also as a protein subtyping, as we have a histological based subtyping as of now. So if we see, initially we had a lung cancer which was classified into non-small cell and small cell, which was later on subclassified as a histological breakdown as a squamous cell carcinoma, non-squamous cell carcinoma, large cell or adenocarcinoma. Then there was a molecular pathology of EGFR, ALK, ROS mutation, and then there is a immunotherapy based PD-L1 expression levels. So if you see, we have moved from a traditional view to a present view, because the genotype directed therapy is now the standard of care in advanced lung carcinoma and has led to improvement in overall survival. So if we see, there is a much importance of the genetic profiling in lung carcinoma. If we see the Kaplan-Meier's curve of this, if the driver is positive and no targeted therapy has given or there were no driver were tested, in both of these circumstances the survival is less as compared to when we have a driver mutation is positive and targeted therapy has been given. So if you see the evolution of cancer, we have so much of driver mutation and a lot of drugs has been discovered in this field, and every patient has an individual molecular markers which can be treated according to these markers. So if we see the genomic alteration in lung cancers, chromosomal changes and alteration in gene copy number are the major one, which has a cell cycle mutation, rearrangements, amplification, deletion and altered pathways. If you see this DNA single nucleotide alteration, insertion or deletion, there is a KRAS, EGFR, BRAF, P1K3CA and MET rearrangements, or there is abnormal histone modification and DNA methylation, or there is a transcription alteration in the form of aberrant slicing of mRNA, gene rearrangement and pathway alterations. So let us see, these are the pathway which gets altered in the patients with lung cancer. This is the neuroendocrine cells which gets transformed into small cell lung carcinoma. These are the oxidative pathway, and these are the abnormalities in the cell cycle, and these are the main pathways of rearrangement in the lung cancer patient. So if we see the molecular evolution of lung cancer, the tobacco smoke is the most common phenomena which causes genetic susceptibility, which interacts to influence the carcinogenesis in the form of tissue injury, which initially occurs in the form of genetic and epigenetic changes, and then there was a global transcriptome changes are there. So now the therapy has moved from the palliative care to the earliest stage of cancer risk and prognostic markers as well as predictive factors because of this predictive therapy. These are the I have just put this slide to show there is a cell of origin and characteristic alteration is that in adenocarcinoma there is a mutation in the EGRF pathway, and in small cell there is a TP53 loss or RB1 loss, which are central malignancies, as well as in squamous cell carcinoma which arises from the vessel cells from the central location. So coming to the topic of tyrosine kinase, these tyrosine kinase are 58 in humans. There are 58 receptor tyrosine kinase in 20 structurally distinct families based on the molecular characteristics of their ligand and extracellular domain. EGFR gene is located in chromosomal region 7, short arm of 7. So if you see, the human genome contains approximately 90 tyrosine kinase and 43 tyrosine like genes which regulate the cellular proliferation, survival, differentiation, function and motility in the normal cells. And these functions are tightly regulated so that any alteration in these pathway will lead to aberrant proliferations of cancer cells. So if we see the tyrosine kinases, these are the EGFR receptor family which consists of EGFR 1, 2, 3, 4, which exists in the membrane of the cell as a homodimer. Before the activation, they need to form a heterodimer or dimer. So once the ligand binding occurs, there is a receptor dimerization and phosphorylation of tyrosine kinases and intracellular signaling cascade. So these are the main two types of tyrosine kinase receptor in the body. The one is receptor tyrosine kinase and the other is non-receptor. both these non-receptors lack the transmembrane domain and present in the cytosol, nucleus or inner surface of the membrane. These functions are tightly regulated at multiple levels so that there is no aberrant function occurs because of this cycle. So if we see the strategies for epidermal growth factor inhibition are either there is a extracellular, which in the form of monoclonal antibodies, bispecific antibodies, ligand conjugates, immunotoxin or vaccine therapy, or it is intracellular if we inhibit the tyrosine kinase inhibitor, which in the form of reversible or irreversible inhibition, as well as the gene therapy. So if you see, this is the fusion of tyrosine kinase to a partner protein with oligomerization, and subsequent there is a aberrant signaling of the pathway, so that there is causes constitution oligomerization in the absence of ligand binding and causes cell proliferation. The classical example is the BCR-ABL gene mutation, and the other is the mutation in the receptor TK causing constitutive activation. This without any ligand, there is a constitutive activation of the receptor which cause the initiation of the cascade of the internal pathway, which most commonly seen in mutation of FLT3 in AML, as well as deletion and mutation in kinase domain in non-small cell lung carcinoma. So this is the most common is the overexpression of receptor tyrosine kinase or its ligand, and there can be increased or aberrant expression of a receptor itself or its ligand or both, or there is a decrease in factor that limits the tyrosine kinase activity. So these accordingly these inhibitors has been generated and which can be given as a targeted therapy. So tyrosine kinase receptors, the most common mutation is the L858R and exon 19 deletion, which causes constitution of EGFR activation, as well as it reflects increased sensitivity to EGFR tyrosine kinase inhibitors, as well as it reflects that there is a good prognosis if these mutations are present in the NSCLC patient. These receptor kinases are first generation and second generation. First generation, the only difference is that they binds competitively and reversibly to the ATP binding site. In the second generation, they bind covalently and they are irreversible, and because of that which are less selective. So if you see, there is a ligand binding and there is a activation of this P13 pathway, MPAK pathway, and there were STAT pathway, which causes proliferation, invasion, metastasis and resistance to apoptosis, as well as angiogenesis, which in itself produces a VEGF, which causes a activating cycle of this proliferation, invasion and angiogenesis in cancer cells. So if we see the EGFR mutation epidemiology, that 10% of the non-small cell lung carcinoma patients have this mutation, 10 to 15%, and they are more common in never or minimally smokers, Asians, and especially in women. And among these mutations, the exon 90 deletion and exon 21 L858R mutations are the most common, with some of the atypical EGFR mutations are there, and there is a exon 20 insertion, which is the coming up therapeutic target of in the armamentarium of the targeted therapy that I will come later. So if you see, this is a wild type of EGFR which causes extracellular growth factor dependent receptor activation, and these dependent ubiquitin and related receptor degranulation. And if you see, there is a EGFR mutant positive NSCLC which has a multiple mechanism to activate the cascade towards the proliferation of the malignant cells. So this is the phase 2 study, Ideal 1 and Ideal 2, which was done in 2003, which was done for the dose escalating study for the Jeftinib. This was done in a patient with the pre-treated with 1 or 2 chemotherapy, at least one contained the platinum in Ideal 1, and pre-treated with 2 or more regimen of platinum and docetaxel in Ideal 2. Both of these studies showed there is a objective response of 20% or 10% and disease control rate of 50 to 40% and overall survival of 7 to 8 months. This is the breakthrough study in the genesis of these targeted therapies. Later on, in next 2-3 years, randomized controlled trials like ISEL, INTACT 1 and 2, TLCI, that is Tarseva lung carcinoma investigator study, and Tribute study showed there is a no benefit to adding an EGFR TKI to chemotherapy. So people has looked back, and this landmark study by Lynch et al. And Pace et al. At the same time in 2004, they have looked into the finding of this study that the subset of patients who responded to gefitinib harbored activating EGFR mutation. So there was a paradigm shift in understanding of the NSCLC pathophysiology and treatment, and these two studies are supposed to be a landmark in the modern era of targeted therapy, because they are, all other future studies has been planned according in a patient with selected patient of who responded to gefitinib who are having a activating EGFR mutations. So IPASS trial was the first prospective randomized controlled trial in patient with EGFR who has a mutation to demonstrate that EGFR TKI are superior to chemotherapy as first line therapy, inferior to however there is a inferior if there is absence of such mutation. These are the studies which shows more or less the same finding of this, the patient is having a superior to chemotherapy. If we see the timeline of this EGFR mutation positive advanced lung carcinoma, we see that there is a progressive increase in first generation, second generation, and there is a third generation which are being given right now. So if you see the EGFR mutational epidemiology, there is the most common is the exon 19 and L858R mutation, and there is the exon 20 insertion mutation in the EGFR, which is now the coming therapy is amivantamab, which acts as a bispecific antibody because it binds with EGFR as well as MET-C receptor and causes a antibody dependent lysis of the tumor cells. So these are the ongoing study which the earliest report will be available by 2025. So we have to wait till this period. So for the targeted therapy, the most important point is the biopsy. We have to establish the diagnosis, determine the histological subtype, and the biomarker testing. These are the EGFR mutation, ALK, ROS1, BRAF, NTRK, RET, MET, HER, and KRAS are the minimum biomarker that has to be done in the biopsy specimen to have a targeted therapy. So there is a recommendation of this use newer generation sequencing testing to detect the most mutation using least amount of tissue, and there is a also recommendation of PD1 L1 testing simultaneously while we are doing this. So turnaround time for PD-L1 is much shorter than this next generation sequencing. Based on this recent approval of osimertinib as adjuvant therapy after resection in EGFR mutated non-small cell lung carcinoma, molecular testing can also be performed in early stage lung carcinoma. So if we see the gold standard of EGFR mutation is tissue biopsy or cytological specimen. However, if we see in 24% of the patients are not candidate for tissue biopsy because of the insufficient availability of neoplastic tissue, presence of comorbidities, and biopsy is not technically feasible. So minimally invasive liquid biopsy, which is supposed to be a surrogate marker for cancer tissue, is that is the circulating tumor DNA released into the blood from the apoptosis or necrotic lung cancer cell. These are the methods of doing a liquid biopsy, which can be done as a plasma first approach, sequential approach, or complementary approach, as well as when we suspect there is a resistance to TKI. So see, this is the Nile study which shows that if you doing a tissue first study, there is a 67% chances of detecting these mutations, but if you add, there is a addition of 33%. Similarly, if we do this liquid biopsy, there is a 87% chance of detecting these molecular abnormalities. But if we add this tissue for tissue also, we have 100% of biomarkers are being detected in the cells. So if you see, the effective genotyping is this tumor next generation sequencing, negative this liquid biopsy analysis, which refers to tumor genotyping. These are the most reliable approaches, is either a panel based assay on a tissue biopsy or liquid biopsy. If the liquid biopsy is negative, obviously we have to do a re-biopsy and see the driver mutation in the histological specimen. So this liquid biopsy has a role in prognosis, identifying the therapeutic targets, monitoring the treatment, detect the resistance, and avoid the repeat tissue biopsy. Like every other test, they also have a limitation of sensitivity of 70 to 80% and specificity which is near 100%. Not all tumors shed that cell-free DNA and maybe negative plasma results, depending upon the tumor size, location, tumor vascularity, metastasis, and prior treatment. So if we see the testing paradigm to molecular biomarker in advanced non-small cell lung carcinoma is EGFR mutation, classical, uncommon, ALK, ROS1, BRAF, NTRK, RET, and KRAS mutations. Accordingly, because biomarker testing to identify optimal first-line targeted therapy has improved survival for patients with advanced non-small cell lung carcinoma in recent years. So these are the different drugs which has been approved accordingly, depending upon these biomarkers. And for EGFR, the classical we give the geftinib or erlotinib, or if there is a T790 mutation, then there is a possibility of osimertinib given as which is a third generation TKIs. So with the advent of these TKI, there is also a limitation that drug resistance inevitably limits the efficacy of all target therapy, because tumor cells are either TK sensitive or TK refractory, exhibit intrinsic or
Please summarize, sir.
Okay. Exhibit intrinsic or cardiac resistance, alteration within or outside the target to promote the survival. So if we see, these are the resistance mechanism, T790 in adenocarcinoma. These are the classical, and this is the along with the MET rearrangements. And if you see, this T90 is the mutation error exon 20 occurring at exon 20, and which is this methionine is replaced by the threonine at 790. So if you see the evolutionary model of drug resistance, is that if we have a pre-existing clone model of drug sensitive altered TKIs and bypass signaling, then if we give a TKI, what happens is there is a selective proliferation of this altered TKI and bypass signaling cells, which proliferate further and causes conglomerate of mass. And there is another model of persister evolution model, where there is a drug sensitive and persistent cells are there, and after exposure of this TKI, they have a evolution of this persistent model cells, as well as there is a altered TKI and bypass signaling cells. In another model, there is a mixed model. There is a drug sensitive, altered TKIs, persistent cells, bypass signaling. TKI is when the TKI is exposed, they have a selective selection of these cells, and there is a appearance of this new histotype, that it is a phenotypic transformation, that is the appearance of small cell carcinoma or squamous cell carcinoma in patient with non-small cell carcinoma. So if we see the personalized medicine, because of this targeted therapy, that earlier we have the office visit, CT scan, biopsy, then pathology, diagnosis, treatment plan, then again if there is a quality is insufficient, there is a re-biopsy, and there is a lot of time consumption. Now if we see, we are moving towards the targeted therapy to earlier in the disease course, from the advanced to earlier course, because now these targeted therapies are also effective as a prevention. So if we see the turnaround time is a paradigm shift in the molecular diagnosis, because now the patient has an office visit, CT scan, biopsy, pathology, diagnosis, and all the molecular testing at the same time and treatment plan. So these are the various sites of this TKI inhibition. So it is the moving the bar. First line from advanced non-small cell lung carcinoma is that once there is a small cell lung carcinoma, non-small cell, we have to do the PD-L1 testing, and if it is PD-L1 more than 50, then we have to give its inhibitor. If the targetable genetic mutation in the form of these are present, the specific therapy is given. If no mutation, PD-L1 negative, squamous histology, chemotherapy plus minus PD-L1 inhibitor, and if there is a non-squamous, the same treatment is given here. So these are the the other therapies which are there in the targeted therapy. In summary, targeted therapy has helped for personalized medicine in oncology, oncogenic driving alteration in tumor or peripheral blood specimen, selection of mutation specific treatment which is well tolerated and effective orally, while much more work remains in the prevention of treatment resistance. The success of targeted therapy in non-small cell lung carcinoma has transformed the lives. So with this I conclude my topic. If there is any question.
Thank you, Dr. Khan, for delivering such a nice and informative lecture. Now, next speaker is Dr. Mohit Bhatia. He is the Assistant Professor in Department of TB and Respiratory Diseases, IMS BHU Varanasi. He is awarded Indian Chess Society Travel Grant for APSR 2014 Bali, Indonesia, and Indian Chess Society Travel Grant for ERS 2016 London, UK, and Game Study Investigator Trainer of PMDT Uttar Pradesh and Organizing Secretary of NAPCON 2021 Varanasi. He published 15 national and international publications and 184 citations. Now, Dr. Mohit Bhatia, please continue.
Mic on. Hello. Good morning, everyone. First of all, I want to thank organizing committee for providing me opportunity. My today's topic is malignant pleural effusion, approach and management. So, what is a malignant pleural effusion? It is defined as presence of exudate in the pleura which are accompanied by the malignant cells. So, the two things, the presence of exudate in the pleura and the presence of the malignant cells or tissue. So, to define a malignant pleural effusion. So, malignant disease, malignant effusion is the second most common cause involving pleura after the infectious etiologies. So these are the different causes, which these are the different malignancies: lung malignancy, breast malignancy, lymphomas, ovary. So these are the common etiologies. Among them, lung cancer is the most common cause of malignant effusion among the males, while the breast cancer is the most common cause in the females. So what is the mechanism? So there are the different mechanisms. Some mechanism as a cause of direct results, or some from the indirect results. In the direct results, pleural metastasis, which can increase the permeability, pleural metastasis with obstruction of lymphatics, decreased pleural lymphatic drainage, thoracic duct interruption, bronchial obstruction. All these mechanisms may lead to the change in the Starling forces, and which can lead to the increased production or decreased absorption of the pleural fluid, which may result in the accumulation of fluid. In the indirect causes, hypoproteinemia, post-obstructive pneumonitis, pulmonary embolism, and post-radiation therapy. These are the indirect causes of the pleural effusion in the malignancy. So now coming to the clinical features. So most of the many patients may remain asymptomatic. They don't have any symptoms. But some patients have symptoms, like the most common symptom is dyspnea. Mostly patients present with a dyspnea, chest pain, anorexia, weight loss, and fever may also present. In comparison to the infectious etiology of the chest pain, if we compare with the malignant pleural effusion, the difference in the chest pain, in some studies it has been observed that in case of malignancy, the chest pain is more likely like a dull aching type of chest pain rather than a pleuritic chest pain, which is more common in case of infectious etiologies. So how we diagnose a case of malignant pleural effusion? If a patient come to us with a diagnosed malignancy, then we have to do a specific investigation to prove that it is a case of malignant pleural effusion. But if a patient come to us with undiagnosed malignancy and we are suspecting this is a case of pleural effusion, then we have to approach like a case of simple pleural effusion. Then we have to start from the beginning. First we have to rule out whether it is exudative, or what are the routine microscopy features, what are the biochemical features, what are the histopathological features in the pleural fluid. So if we have a underlying known malignancy, then we can have some certain non-specific findings which are not characteristic of a malignant pleural effusion, but which can present in a case of malignant pleural effusion. Just like mostly the fluids are exudative, it can be hemorrhagic, it can have low glucose attributed to the high metabolic rate of the malignant cells, presence of malignant cell, and it is mostly lymphocytic, and large cells and eosinophils may also present. If we are getting eosinophil and we are suspecting it is a case of malignant effusion, then we have to first rule out the other causes of increased eosinophil in pleural fluid, like presence of pneumothorax, traumatic tap, etc. So for the diagnosis of pleural fluid, a cytology examination of the pleural fluid and demonstration of malignant cells in the pleural fluid is required to prove a case of malignant effusion. In the cytologic examination of pleural fluid, or we can prove it through a biopsy of the pleura with the demonstration of malignant tissue in the pleural biopsy. So pleural fluid cytology have variable sensitivity. For a single sample, it can be as low as 55-56%. If we increase the number of sample, then sensitivity increase up to 76%. So if we compare the blind transcutaneous pleural biopsy with the pleural fluid cytology, if we are doing it blindly, so sensitivity with the repeat sample of the cytology, pleural fluid cytology, can be more as compared to the blind tissue transcutaneous pleural biopsy. because the malignant pleural effusion, the malignant tissue tends to deposit in the clusters. So during the blind transcutaneous pleural biopsy, we may miss the target tissue. So the sensitivity of the blind procedure is low as compared to the pleural fluid cytology. And with the advancement of technique in the cytological examination, so this sensitivity in some studies have been reported as high as 90%. In many studies it has reported as 90%. But if we are using image guided thoracoscopic pleural biopsy, then sensitivity become higher for the pleural biopsy up to 95%. So if it is we are doing with if the case of undiagnosed pleural effusion we are unable to detect in a case of in pleural fluid cytology, then we should always go for a thoracoscopic, if it is available, then thoracoscopic pleural biopsy. Now, what is the impact of the presence of pleural fluid in case of malignant disease? So pleural fluid in case of malignancy always indicate a advanced disease and carries a poor prognosis. So with a mean survival of 3 to 12 months, we will discuss about the survival prediction scores in the later part of the presentation. So this has been shown in the many studies. So it carries a poor prognosis with mean survival of 3 to 12 months. Now coming to the management part. So what is the goal of the management? As we already discussed, that presence of pleural fluid in case of malignancies is represent advanced disease and carries a poor prognosis. So our main aim of the management is to provide symptomatic relief to the patient, and as a part of palliative care, improve the health related quality of the life of the patient. So these are the only two goals. We are not going to increase the survival of the patient, but we are only increasing the health related quality of life of patient. So one systemic review which has shown that intervention in the case of malignant pleural effusion, either by therapeutic thoracocentesis or by thoracoscopic talc portrage or by intercostal chest tube drainage with talc slurry, improve the health related quality of the life in patient with malignant effusion. Now, as we discussed, that many patients may come present to us like asymptomatic patient. So what is the course of these patients? So this is a study, a multi-center retrospective study, which has shown that these asymptomatic patients going to be symptomatic a good amount. 46% of these patients are going to be symptomatic in next 1 year of the survival life. So we have to follow these asymptomatic patients. So what are the different management options we have? We can observe in case of asymptomatic patient, we can have therapeutic thoracocentesis, or we can treat the patient with underlying malignancy with chemotherapy and radiotherapy. We can put indwelling catheters in case of if the patient is not improving with pleurodesis and patient is having trapped lung. We can do chest tube drainage with talc slurry and thoracoscopy with talc portrage. We can do pleuroperitoneal shunt when the other things have failed, and especially in the case of chylothorax. And we can have indwelling pleural catheters also. So this is the basic approach we are keeping in mind when we have a case of malignant pleural effusion. First we have to think about whether the patient is symptomatic or not. If the patient is asymptomatic, then we have to observe the patient, and if the patient is symptomatic, then we have to plan the patient for the therapeutic thoracocentesis. Then we have to assess about the expansion of the lung after thoracocentesis, whether there is a lung entrapment is present or not. Then if the lung entrapment is present, then we have to plan for the chronic indwelling pleural catheters. If the lung entrapment is not present, then we have to plan the patient for the pleurodesis, either by chemical or mechanical methods. There are certain points for regarding the therapeutic thoracocentesis, whether USG guided is better or blind is better. So definitely USG guided has better outcome, less risk of complication during the procedures. So significantly lower risk of pneumothorax. So these are if we have to choose between USG, definitely a USG, there is no question to us. This is another study published in the chest that the USG guided has lower risk of the complication after USG guided. Then after therapeutic thoracocentesis, we have to evaluation of the symptoms, whether there is a improve in the symptoms are there or not, and re-expandability of the lung and the rate of the reaccumulation. So these points are important in case of deciding the further management of these patients. If the patient don't have any symptomatic relief, then we have to reassess the patient and we should look for another diagnosis, another etiology for cause of dyspnea, including infection and cardiac causes. In the re-expandability of lung, if the re-expandability is present, if the lung is re-expanded, then we can plan this patient for the pleurodesis, as well as if the lung is not expanded and there is a trap lung, then we can plan this patient for the indwelling pleural catheter. And what is the rate of reaccumulation? The higher the rate of reaccumulation carries a poor prognosis to these patients. So this is this is a PLEASE study, the pleural effusion and symptom evaluation. It is done to see the relief of the breathlessness. So these studies show that drainage caused significant improvement in the symptom of the patient, dyspnea of the patient, which is calculated by VAS score. So these studies show that there is a significant improvement after the therapeutic thoracocentesis, whether the lung entrapment is present or not. In both cases, there is a symptomatic improvement to the patient. So what are the different risk factors for the pleural effusion recurrence in the patient? So these are the different risk factors. High initial at the presentation, if the chest X-ray has showing the large volume of the fluid, and in the pleural fluid serum LDH is higher. So these are the different risk factors for the high recurrence of the malignant pleural effusions. So this is another very important thing. This is a Lentz prognostic score. It is very important in deciding the prognostic. It is basically a prognostic score which predicts the survival of the patient in the next whether the survival is in weeks or whether the survival in months. So in the Lentz score, in the pleural fluid, lactate dehydrogenase and the ECOG score, Eastern Cooperative Group, Cooperative Oncology Group score, and the neutrophil to lymphocyte ratio and the tumor types. So based on these parameters, the score is calculated, and the patient classified into the low risk, high risk, and moderate risk. So the low risk patient have survival, better survival. The high risk patient have approximately 65% survival in the next 1 month, but they have only 6% survival in the next 3 months. See, this is another scoring system. This is a PROMIS score system. Now coming to we have assessed the patient, and based on the assessment of the patient, if the patient survival is in months, then we can plan the patient for other interventions like fluoridasis is one of them. If the patient survival is less than weeks based on the prediction scores, then we can plan the patient for repeated therapeutic aspiration as well as other symptomatic management. So in the fluoridasis, basically we are killing the potential space in which the fluid can accumulate. So we are approximating both visceral and parietal pleura. So if for the fluoridasis there should not be entrapment of the lung should be expanded, and there should not be much deposition on nodular deposition on the pleura, so that there will be a better approximation of the pleura. So we can have the chemical or mechanical fluoridasis. In the chemical we have talc, bleomycin, doxycycline, povidone iodine. The route of they compare, and in the list the talc is in the most of the studies talc is believed to be the better result. We have our own experience using talc, bleomycin, doxycycline, povidone iodine. So we have also confirmed the result of the other studies that talc has a better result, and other also have. In the povidone iodine, there are some reports from the AIMS New Delhi that a case of blindness there were a few years back. So this is the point of concern here. Now what can be the route of the fluoridasis? Either we can do it with the intercostal chest tube drainage, we can do it with the thoracoscopic portage, or we can do it with the indwelling catheter also. Another question is regarding the fluoridasis, what is the choice of analgesia, whether NSAID are better or opioids are better, and what is the role of steroids in case of what is the effect of patient is having intrapleural steroids in case of fluoridasis, and whether the effect of the rotation of the patient after putting a sclerosing agent intrapleurally, and what is the role of ultrasound in the removal of the catheter or the putting of the catheter. So we will see this question one by one. So there is a comparison between graded talc, doxycycline, bleomycin, povidone iodine, and these two. So this is a systemic review which is shows that talc fluoridasis has the significantly higher success rate and less failure rate compared to the other molecules. So this is Cochrane review, another which confirm the same thing. Now one comparison between the thoracoscopic talc portage versus chest tube fluoridasis. So there is no much statistically significant difference among the success rate or failure rate between these two groups. So both can be used. So there is no much, but slightly less failure rate in a thoracoscopic talc portage. So another same thing. So what is the use of, regarding the use of local anesthetic agent? So as per the British Thoracic Society pleural disease guideline, so lidocaine 3 mg per kg with the maximum dose of 250 mg should be administered intrapleurally just prior to the sclerosing administration. It will relieve the pain and anxiety to the patient. So regarding the use of steroid, so use of steroid can lead to the higher failure rates in case of if we use the intrapleural steroids before the fluoridasis. So they have the higher failure rate and as compared to the patient in the group which are not using intrapleural steroids. Now if we compare this analgesic agent opioid versus NSAID, so this randomized control trial was performed in time 1. So this confirmed that there is not much statistically significant difference between the use of either opioids or non-steroid anti-inflammatory agents. So both have the similar results in a patient with performing pleurodesis. So another is whether the rotation of the patient is required after putting the sclerosing agent intrapleurally or not. So now this study confirmed that there is not much effect on the rotation of the patient after putting intrapleurally sclerosing agent. So it is no longer, this guideline should be abolished. The conclusion of this study was that the guideline should be abolished, this rotation point. So role of therapeutic ultrasound in case of pleurodesis, because in case of pleurodesis, expansion should be, complete expansion should be there. So we can do bedside or in the OT ultrasonography to see whether there are any adhesion or present or not, whether their pleural fluid is septated or not, what is the thickness of the pleura. So there is, ultrasound has a very important role in, so we should always perform an ultrasound, lung ultrasound before performing pleurodesis. Now if the septations are present, so is there any role of intrapleural streptokinase or urokinase? So earlier we think that hemorrhagic pleural effusion, we should not put this streptokinase or urokinase. So they have studied this group. This also doesn't have any significant benefit in case of pleurodesis, success or failure. So these are not longer recommended. Now what is the role of IPC indwelling pleural catheters? So as we already discussed that in case of the non-expandable lung, the trapped lung, we can put the indwelling pleural catheter which are tunneled under skin for a long outer patient, and we can drain pleural fluid as per the requirement of the patient and the symptoms of the patient, as per the symptoms of the patients. So these are the
time is yours.
So I am coming to, this is the recommendation from ATS. The patient with patient with symptomatic malignant pleural effusion with non or suspended expandable lung and no prior definitive therapy should IPC or chemical pleurodesis be used. So the recommendation is in the patient with malignant pleural effusion, so they both should be considered for the diagnosis. But in case of trapped lung, non-expandable lung, the indwelling pleural catheter should be the first choice. So another concept is coming out about pleurodesis is outpatient TAC administration by indwelling pleural catheter. So they are putting indwelling pleural catheter like Pleurex. So they are putting the talc slurry on the outpatient basis. So this study has shown that after 35 days of installation of the talc, there is a better results as compared to the single use of the talc in case of indwelling pleural catheter. So this is my
time is over, sir.
This is my last summary. This is my summary slide. Just to summarize and take home message. When we have a case of malignant pleural effusion, first thing that comes is we should look for whether the patient is symptomatic or asymptomatic. If the patient is asymptomatic, then we have to treat the underlying malignancy and observe the patient for symptoms, clinically, radiologically, as well as. Then if the patient is symptomatic, then we have to do ultrasound guided large volume therapeutic thoracocentesis. Then after that we have to assess the things that whether the symptoms are relieved. If the symptoms are not relieved after the draining the significant amount of the pleural fluid, then we should reassess our diagnosis and reconsider other differentials also. If the symptoms improve, then we have to assess the expandability of the lung, whether the lung is expanded or not. And meanwhile, we should also calculate the Lent prognostic score or the other score like PROMIS score. Then if the patient survival in weeks, then we have to offer the patient palliative treatment, dyspnea, for the management of dyspnea, large volume thoracocentesis or repeated thoracocentesis, and the analgesia, opioids, NSAID, bronchodilator and oxygen therapy is as required. If the patient survival based on the prognostic score in months, then if the lung is re-expanded, then we can consider this patient for the fluorodesis, either chemical or mechanical methods. If the lung is not re-expanded, then we have to consider this patient for indwelling pleural catheters and drainage as guided by the symptom of the patient. In the last, I want to acknowledge Dr. Sanjay Singhal, who is Associate Professor in AIIMS Rajkot, and I use most of the slides of his presentation, because earlier he was to be given this lecture, but later its opportunity come to me. So I acknowledge Dr. Sanjay Singhal. Thank you.
Now the session is open for question answers, if any.
In case of malignant effusion, the serology suggests adenocarcinoma. Tissue is not available because of the biopsy not done. So what you use, the pleural fluid is centrifuged regarding the EGFR mutation. Question to Dr. Ajmal.
No, which
Afzal,
carcinoma?
Dr. Afzal.
The point is which carcinoma? Adenocarcinoma.
Dr. Ajmal,
Yeah.
आप
If there is a malignant pleural effusion and we do not know the source, first we need to identify the source of the malignancy, where it is coming from, and for which we can do the CT or we can do a PET scan. And if it is amenable to tissue biopsy, then definitely we have to do a molecular analysis for targeted therapy. And if this tissue biopsy is not available, then even the cell-free DNA from the blood can be done as a surrogate marker for the biomarker testing. And on that we have to do a complete new generation sequencing, so that all the mutations are being identified at the same time.
Fluid is not centrifuged, we are using the fluid and making block.
No, but that is cell block. We can definitely move, but the point is it will only tell you it is adenocarcinoma or it is something, but it will not tell you where is the source. If there is a malignant cells, it is adenocarcinoma, it can come from anywhere, it can come from the ovary. So we cannot do the treatment will not remain the same. Even if it is targeted therapy, then targeted therapy is different for the ovarian malignancy than the lung malignancy. The major point is you have to identify from where this malignancy is coming. So once you have identified, then you have to act accordingly.
Sir, the cell block can be subjected.
Definitely cell block.
It can be subjected to immunohistochemistry to identify the primary.
No,
so primary, in case if it's not visible, if the disease is everywhere, suppose there's an ovarian mass as well and there's a lung mass also, and we do not know which is the primary. So the cell block from the effusion fluid can be subjected to immunohistochemistry, which can help in telling which is the primary.
No, actually cell block will
by
only,
the immunohistochemistry markers, sir.
No, cell block will only tell you the type of malignancy. It will tell you the histology of the malignancy, whether it is a squamous, whether it is a adenocarcinoma, or whether it
sir,
is
it can tell the cell of origin also. If they put the markers, the IHC markers can tell the cell of origin also.
No, but that may not be accurate, because these markers is supportive evidence.
Obviously, it is not as accurate as a tissue biopsy.
Yes.
But in case of
so when we have something that is more accurate, then we have to go for that instead of pressing for something which is not being routinely done.
No, I'm just answering what sir had asked. So,
Then
yes.
If that is what I am trying to tell you, if tissue is not available, then patient can be sent to a center where it is available. Number one. Number two, if any circumstances, then madam is right. We have to do the cell block histopathology, and then we have to put the markers on that. Yes, we can go.
Can I sum it up? आपका सवाल था पेशेंट प्लूरल फ्यूजन का है, उसके पास एडिनोकार्सिनोमा की सस्पिशियस रिपोर्ट है, उसके पास टिश्यू नहीं है. दोनों ने आंसर सही दिया. अगर आपके पास फैसिलिटी है सर, तो आप यू कैन गो फॉर अ लिक्विड बायोप्सी. व्हाट डॉक्टर ईशा जफा इज सेइंग, अगर आपके पास फ्लूइड है, उसको आपने सेल ब्लॉक बनवा लिया है, तो सेल ब्लॉक बनवाने के बाद सर आप उसके अंदर उसमें इम्यूनोहिस्टोकेमिस्ट्री करते हैं. इम्यूनोहिस्टोकेमिस्ट्री आपको बता सकता है कि ये प्राइमरी कहाँ की है या सेकेंडरी है, क्योंकि जो फ्यूजन आता है वो कहीं से भी आ सकता है, एज डॉक्टर अजमल खान इज सेइंग. अब सवाल ये बचता है कि ये जो ओरिजिन है आया है, उसको अगर आपको टारगेटेड थेरेपी जो जिसके ऊपर पूरा लेक्चर डॉक्टर साहब का था, उसके लिए जाना है, तो यू कैन गो अहेड फॉर व्हाट ही इज सेइंग इज अ लिक्विड सेल फ्री डीएनए इज टेकन फ्रॉम द ब्लड. वो सर एडवांस सेंटर पे होता है. और व्हाट शी इज सेइंग यस कि लिक्विड बायोप्सी कैन नॉट बी एज रिप्रेजेंटेटिव एज यू हैव अ टिश्यू. उसी के लिए सर उसीलिए बायोप्सी है. चाहे आप प्लूरल बायोप्सी कीजिए, चाहे ब्लाइंड बायोप्सी कीजिए, चाहे आप थोरेकोस्कोपिक बायोप्सी कीजिए. अगर नहीं है तो व्हाट ही इज सेइंग आप सर ब्लड से करा सकते हैं सेल्फी डीएनए. अब वो होता है. और अगर आप इतने लकी हैं कि आपके पास हिस्टोपैथोलॉजिकल बैकअप है और सेल ब्लॉक बना सकता है, तो यू कैन गो हेड, यू शुड गो फॉर इम्यूनोहिस्टोकेमिस्ट्री. इम्यूनोहिस्टोकेमिस्ट्री के बाद का स्टेप होता है सर टारगेटेड थेरेपी के लिए, वो म्यूटेशनल स्टडीज़ होती हैं. उससे हम पर्सनलाइज या बेसिक ट्रीटमेंट जो पेशेंट को देना होता है वो हम ऑफर कर सकते हैं. आई थिंक इम्यूनोहिस्टोकेमिस्ट्री भी अभी तक हम लोग को ये बता देता है कि ओरिजिन कहाँ का है. उसके बाद का स्टेप है जो पूरा लेक्चर था वो टारगेटेड थेरेपी का था सर, उसके बाद जाएगा.
Actually, what we used to do is a protocol-based chemotherapy earlier. Now, every patient in targeted therapy, every patient is treated as a unique entity, and we have to search for the biomarker and then give the therapy according to the available biomarker of that patient. So, this is kind of a personalized therapy that we are giving in the lung cancer now.
Thank you, sir. Any more question from audience?
Thank you.
Sir, one question, sir, from Dr. Bhatia, sir. Sir, if pleural effusion is non-homogenic, streptomycin have any role? We can
Sir, as I get your question, if the pleural effusion is non-hemorrhagic,
yeah,
then streptokinase has any role? So this is your question, sir. So streptokinase, it was proposed that it has the only role when there is case of adhesion or septations. So before performing pleurodesis, so there should be the approximation, better approximation of the pleuras. So lung should be fully expanded. So if the lung, if there is a presence of septation or adhesions, so lung is the both pleura will not be able to approximate. So the chances of failure of pleurodesis will be more. So it was proposed, and in some cases we also try in some cases of malignant effusion to give the patient symptomatic relief. If the patient is having symptom, to provide the patient symptomatic relief. If the patient is having dyspnea and we are unable to tap the pleural fluid due to the adhesion or the septations, so if we are unable to, we have also tried in some patient, and patient got symptomatic relief. But as I shown in the trials that there is no much relief. The only role should be to prevent the adhesion and septations, so that the pleura can be better approximate and the success rate of the pleurodesis is increased. And The second number is to prevent the symptomatic relief from dyspnea, which was our primary aim of the management.
Thank you, sir. Any more?
See, this streptokinase is something entirely different from what we are dealing in a malignant pleural effusion. They are two extreme end of the spectrum. When we give the streptokinase, we are lysing the adhesions. We are not letting these adhesion to fuse the visceral and parietal pleura. But in malignant pleural effusion, most of the time we would like to adhere the pleura. So in malignant pleura, there is a very less role of this streptokinase. And if we see the streptokinase, now if you go to the rest of the world, it is never being used. Now they are come with the DNAs and urokinases, streptokinase is something obsolete in them. In Indian scenario, there is still a role in infectious disease rather than in a malignant disease.
So,
thank you very much.
Thank you, sir.
Now we will close this session and we will move towards next session.
Thank you. This was very wonderful session, eye-opener for youngsters. Now I call upon our HOD, Dr. Ved Prakash sir, to honor our speakers and chairpersons. So I request speakers, Dr. Ashish Tandon sir, Dr. Ajmal Khan sir, Dr. Mohit Bhatia to come on the stage. Chairpersons also please join on the stage. So first Dr. Ashish Tandon sir. Dr. Ajmal Khan sir. Dr. Mohit Bhatia. Dr. Avinash Agrawal sir. Dr. Ram Narayan sir. Dr. Isa Jaffa ma'am. Thank you chairpersons and speakers. Thank you sir. Now we start our session 3, that is radiology in pulmonary medicine. So for this I call upon Dr. S.N. Gupta sir. He is senior consultant Sanjeevani Lung Care and Multispecialty Hospital, Lucknow. Dr. Ashwani Mishra. He is head of department in pulmonary medicine, BRD Medical College, Gorakhpur. Dr. Utkarsh Kumar Srivastav. He is assistant professor, Department of Emergency Medicine, Dr. Ramnath Lohia Institute of Medical Sciences, Lucknow. Welcome sir. Now I hand over mic to respected chairpersons for next session.
Okay. So I think this session is a mixed session, not only based on the radiology. It will be covering the in critical care also, in which the Ashok will deal with it. His topic is the difficult weaning. The second is the HRCT, where we have very well known speaker, Dr. Khushbu Palania, and Dr. Mansi Gupta is also from Lucknow. She will be talking about what is the role of USG in pulmonary medicine. So to start with, I'll invite Dr. Ashok Kumar Singh, who is a junior from KGMC only. He has done his MD from KGMC itself, DNB respiratory medicine, and he has done the European Diploma in Adult Respiratory Medicine, very early phase of the European Society when he started the EDRM course, and I think he has passed his examination way back in 2008. And then he has fellowship in critical care medicine. His special interest is in critical care. So we'll invite Dr. Ashok Kumar Singh for his lecture on the weaning.
So good afternoon, everyone. At the outset, I would like to thank you, Dr. Bed, and my friend Dr. Rajiv for this kind invitation. So next 18 minutes I'm going to talk about a very important part of respiratory critical care, because you all are the pulmonologists and anesthetics are dealing with a lot of respiratory failure, and many times we feel the patient, we are not able to wean up the patients. How to do it, I will discuss. So if you look up data and you retrospectively analyze, you will see that most of the flight accidents that occurs during the landing. Why? Because there is a lot of physiological changes and it is the protocol based. If the pilot is not following or missing any step of landing, so there is accident. The same thing happened when we wean off the patient from the long-term ventilation, because a lot of changes is going on, especially the physiological changes, that is from positive pressure to negative pressures. So we have to follow some protocol. So the point to be addressed, the weaning in day-to-day practice and how to make a strategy for difficult weaning. So by definition, the weaning is a transition process from total ventilatory support to the spontaneous breathing, and that involves the three important steps. One is the testing of the readiness, whether my patient is ready to wean off or not. Second is application of the weaning protocol, and third is extubation and monitoring. That part is also very, very important. So successful weanings, we need a good clinical assessment and justified application of physiological indices. So it's just not a one-step process. So you have to analyze the various indices, and that should be applied clinically. Only then you can take the decision that we are able to wean off this patient. So weaning is a combination of art and science. There are three types of weaning. One is the simple weaning. The most of the patients, they belong to this category. 70% patients can be weaned off by single spontaneous breathing trial, like in a patient with the fluid overload or pulmonary embolism, pulmonary edema. We are ventilating these patients for 24 hours or 48 hours and wean off the patients. And then it is difficult patients, like 10 to 15% patients belong to this category. And by definition, if we need near about 3 spontaneous breathing trial to wean off these patients within 7 days, then it is called as difficult weaning. And most of the patients of the ARDS, they come into this category. Now, third one is the prolonged weaning. Most of the patients of COVID-related ARDS and various complications, sepsis, multi-organ failures, they need ventilation for more than 3 weeks, 4 weeks, and the weaning is very, very difficult and the challenge for the clinician. And when, by definition, it is called when we give the spontaneous breathing trial more than 3 times in 7 days, more than 7 days, this is called as prolonged weaning. So my topic is difficult weaning, but I will discuss simple weaning first. So it is not only this clinical based decision that should be included the protocols. And there is a large number of studies which says that, you see here, that most of the studies say we do the weaning based on the protocols, the results are favorable. If we compare from the usual care, means it's a physician based decision, just saying the patient has recovered, you extubate the patients. So probability of getting failure is more with usual care as compared to the weaning protocols if we follow this. So weaning is always a teamwork. It should be started, the planning should be started in evening, and we have to involve the physician, nurse and the patient as well. the duty of a physician is to communicate and make a plan and write down on the file that this is my planning to wean off this patient. And clinician should explain to the patient that tomorrow we will take out your tube and you will be able to speak. So good communication is a very, very important part of the weaning. So how to proceed? When you are standing the bedside in a patient who is on ventilator, you are planning for the weaning, you have to follow these steps. 1, identify the readiness of the weaning, preparation of the weaning, and do spontaneous breathing trial, and then monitor patient closely during this trial and extubate the patient. And the last step is again very important. After extubation, you have to look for the post-extubation respiratory failure. So first step, what are the prerequisites? Means what are the readiness criteria? The most important one is the primary cause had been established. Means if we ventilated the patient for the respiratory failure or pneumonia, the fluid overload, that part has recovered or not. That is the first requisite. Only then we can think about the weaning of the patients. Second is, patient should be hemodynamically stable or minimal support. Patient should be able to initiate spontaneous breathing. Oxygenation should be satisfactory, means the PF ratio should be minimum at least 200 with minimum PEEP, that is 5 and 50% of FiO2. Adequate metabolic correction should be there. There should not be a metabolic or respiratory acidosis. pH should be more than 3.2 and good GCS. So decision making should not only be based on the physiological parameters, but clinical decision is of paramount importance. Just as indices are not important. So it's a collaboration of clinical finding as well as various indices. So second step is preparation for the weaning. So stop sedation in the morning, at least 4 or 5 hours, depending on what type of sedation you are using. And do the spontaneous waking trial. Meet you communicate with the patient. If the patient is able to communicate, it means your patient is ready for that. And if the patient pass spontaneous awakening trial, then the plan for the spontaneous breathing trial. If you fail, always look for the sedation, hypercapnia, and any CNS insult like an hypoxic failure or septic encephalopathy or stroke. How to proceed? Do this spontaneous waking trials. You have to look for the active seizures, alcohol withdrawal, agitation, paralysis, myocardial infarctions, and normal intracranial pressure. If fail, the possibility is patient is having anxiety, agitation, pain, or respiratory rate is very high, or SpO2 is less than 88%, respiratory distress, acute cardiac arrhythmias. If this spontaneous waking trial failed, you put the patient again on the sedation, continue for the next 24 hours, and just wait. If patient pass to spontaneous waking trial, then move to third step, means spontaneous breathing trial. The various methods are available here, what we are practicing the day-to-day critical care. The TP's trial, that should be given for 30 minutes to 120 minutes, and the pressure support with the most preferred method, that is 6 to 8 centimeter of the water with 4 PEEP. Spontaneous SIMB is not preferred now. There's some new modes are also available at new meaning what like volume supports or auto modes or auto care modes. But routinely we are not practicing this. The best method theoretically and practically is low pressure support, that is 6 to 8 centimeter of water. So when we compare, because there are two thoughts, some they prefer the TP's trial, some prefers the pressure support ventilation for spontaneous breathing trial. The literature says there is no significant difference in the outcome. That depends on the personal choice and personal experience of the clinician. But if you are dealing with a patient who is having critically ill, long-term ventilations, and especially in patient with a prolonged weaning, a prolonged ventilation, patient is already on 3-4 weeks, or there is a high risk of extubation failure. In that condition, literature say the pressure support ventilation is little bit better as compared to the TP's trial. So I always prefer in my patients this pressure support ventilation. So how to do it? So when we give the spontaneous breathing trials, you have to see patient strictly, or you have to observe the patient strictly. There are two types of criteria. One is the subjective criteria and objective criteria. In subjective criteria, you have to look for the patient comfort, whether the patient is having some respiratory distress or not, sweating is there or not. And you have to look for the degree of hypoxia, you have to look for tachycardia and hypotension. There the few parameters are given in that, but the subjective parameters are equally important as compared to the objective parameter. So ABG and only is not a criteria. You have to stand bedside and look for the failure of spontaneous breathing trial. Now step 4. After undergoing a successful spontaneous breathing trial, a few more criteria should be fulfilled before deciding the extubations, like an adequate cough reflex, which we can see during the suction of the endotracheal tube. A second is cough leak, although we are not practicing routinely this. And then you have to come to the step 5, the post-extubation monitoring. That is very, very important part, because patient was on long-term ventilation. The probability of getting the post-extubation failure is quite high. And always, if a patient needs a re-intubation, the probability of mortality is more, but is more than 20% in that conditions. So the sign of extubation failure, the respiratory rate is more than 25 in next 2 hours, heart rate is more than 140, and clinical sign of respiratory muscle fatigue is there, and there is a low oxygen saturation and a little bit of hypercapnia from the baseline. So these are the few signs by which we can say that patient is going into post-extubation respiratory failure. So weaning failure is said, then when there is a failed spontaneous breathing trial, need of re-intubations, resumption of ventilatory support, and death within the 48 hours, this is called as weaning failure. So application of the protocol in a difficult weaning is very, very important to prevent the weaning failures. So post-extubation respiratory failure, about 14 to 20% patients, they develop post-extubation respiratory failure, and most of the patients, they have within 24 hours, they need re-intubation. If your patient is comfortable after 24 hours, probability of getting the post-extubation respiratory failure is unlikely. So how to do a difficult weaning or weaning failure is there, how to evaluate their patients. Then you have to do comprehensive evaluation of especially the airway, resistance, compliance setting. You have to do the cardiac component, maybe the poor ejection fraction that can lead to the post-extubation pulmonary edema, the very, very common complication. If somebody is having less than 30% ejection fraction, you are going to wean off this patient, and extubation, always give the diuretic, because you are converting the patient from the positive pressure to negative pressure. These are practical points. And look for the nutritional status. Ventilator-induced diaphragmatic dysfunction is very, very important in the underdiagnosed conditions. Always do the ultrasound in the difficult weaning just to see the diaphragmatic movement. And neurological problems, what we call as critical illness polyneuropathy. 70% patients are having some component of critical illness neuropathy if the ventilation period is more than 7 days. So do comprehensive clinical evaluation to treat all the reversible cause of the weaning failure if your patient is not able to wean off. So make individualized strategy for the difficult weaning patient. 70% patient you can wean off with a single trial, but in difficult patients you have to do the multiple trials, you have to make a different strategy. So this is one protocol which is given that ABCD, you have to evaluate the patients when there is a weaning failure, that's airway and lung functions, look for airway resistance, endotracheal tube obstructions or unresolved ARDs. Brain dysfunctions, you have to look for the septic encephalopathy, CBA or oversedation. In cardiac dysfunction, especially for the low ejection fraction, diaphragmatic dysfunction, endocrinal abnormality, especially hypokalemia. That is one cause of weaning failure or associated metabolic acidosis. But in practice, these are the 4 important causes which we see in day-to-day practice, that the first one is the most important, that is unresolved primary disease. Because this picture you will not be able to make out your diagnosis on an X-ray. For that we need a good quality CT scan. You see here, there is the consolidation plus some degree of the fibrosis, there is the pneumomediastinum and the pneumothorax. So if primary disease is not resolved, there will be weaning failure. This is the commonest cause of weaning failure, what we call a premature weaning. The second important part is the critical illness polyneuropathy. The patient is conscious, hemodynamically stable, but is not able to move his limbs. Because in more than 70% patients, they have some component of critical illness polyneuromyopathy if a ventilation period is more than 7 days. So you have to evaluate. And a smart clinician always start preparation from the day 1. When we think that patient is having COVID associated sepsis, we need ventilation for more than 3 weeks. So Do not give drugs like aminoglycosides, vancomycins, and decrease the duration of sedation, relaxants, maintain the electrolytes, maintain the pH, give the good insulin therapy, good glycemic control. These are the few points by which we can decrease the probability of development of critical illness neuropathy. And third is poor nutrition. Now, many patients, they have chronic illness because of the poor nutrition. So they are not able to move the diaphragm. They are not able to generate that much of the tidal volume. And abdominal pressure, like in the case of pancreatitis, ascites. These are the four most common cause of weaning failure in clinical practice. Specific management, this is the common problem, common mistake by the resident. Whenever there is a weaning failure from the TPs, they always put the patient on the pressor support. Please do not do that. Go to the assisted control again, and then pressor support, then TPs. From TPs, pressor support and assisted control, it is wrong. If TP's failure is there, go for assisted control, then the pressor support. So, and find out and treat the reversible cause, management of the cardiac, which I have discussed, management of psychological limitation of the weanings, consider the use of protocols if you are not following that, and weaning protocols should be practiced strictly, especially in case of difficult and weaning and prolonged weaning. You may skip this in patient of simple weaning. So what are the options we have? One is role of NIV, role of ultrasound, and tracheostomy in prolonged weaning and difficult weaning. These are the three strategies we can apply. Now coming to the role of weaning. So it's a learning point. It can be applied to prevent the post-extubation failure, but not to treat the extubation failure. Remember this sentence. If you think your patient is going to develop post-extubation failure, apply the BiPAP or NIV support, but anyway. If patient develops post-extubation failure, it's a learning point to do not apply NIV, intubate the patient. Otherwise, there will be the bradycardia and patient will die immediately. So learning point is this. So NIV is particularly helpful in condition where its role is proved, like in COPD, in post-operative respiratory failure after the lung resection surgery, or decompensated obstructive sleep apnea. These are three conditions where NIV is a wonderful option to treat these patients, even patient of post-extubation failure, but not in other cases like in a patient of sepsis-associated complications or COVID-associated complications. The role of ultrasound, that needs very expertise to assess this critically ill patient. You have to look for two things. The contraction of the diaphragm, if the movement exclusion of the diaphragm is more than 1 centimeter, it means the diaphragm is working properly. Or during inspiration, the thickness of the diaphragm is more than 40% of during expiration. It means the patient is having good intact diaphragm activity, because the diaphragm is the most important respiratory muscles that help in extubation of the patients. And then the tracheostomy. These are the most important interventions in weaning failure patients or the prolonged patients, because this decreases the work of breathing and make the patients conscious of sedation. These are the two things by which we can wean off the patients. And most of the patients of difficult weaning, tracheostomy is a one intervention that saved a lot of life, but the decision has to be taken early in these patients. If you suspect your patient is going to need ventilation for more than 10 days. So this is my last slide. The patient receiving mechanical ventilation, the first look whether there is a complete reversible cause of reversibility of component is there or not, like an ARDS, pneumonia, whatever it is. And then monitor weaning readiness. Then if the patient criteria are positive, give the spontaneous awakening trials, give the spontaneous breathing trials. If they are successful, you can extubate the patient. If failed, do not give it again. Ventilate the patient for next 24 hours with good sedation with assisted control. This is a learning point. So in a patient in which there is simple weaning failure, you can give the trials 2 times, 3 times. But in a patient who is already on ventilator for last 3 weeks and there is a failure, so do not give the 2-3 trials in a day. It's better to sedate the patient for next 24 hours and give trial in the next day. So take home message: for successful weaning, we need a good clinical assessment and justified application of physiological analysis. So it is just not a clinical finding, it is just not an indices that AVG is saying partial pressure of oxygen is 80%, hemodynamically stable, extubate the patient. No, you have to combine both these things, only then you can get the success in patient to prolonged weaning and difficult weaning. Thank you very much.
So, thank you Ashok for the wonderful, and you have given so number of points which I think it is a learning point for most of us, and also for the students who are sitting here who are doing their MD and DM in the critical care. See, any questions for the Ashok? Otherwise, I will add 1 or 2 points which Ashok also has mentioned. One point is nutritional status of the patient. Most of us who are practicing the critical care, they miss the nutritional point. And I believe that it should be taken care of from the very first day the patient comes into the critical care unit. Because if you want to go for a good weaning, then the nutrition is very important. And one must take into care of that. Second, most of the critical care units now they have the ultrasound machines in their unit. So the students, they should also learn to see how to do the dynamic scanning. The dynamic scanning definitely will help them to see what are the movements of the diaphragm. And from the day one, that will also remind them that you do have to maintain the strength of the diaphragm. Only then you will be able to go for a good weaning and comfortable weaning for the patients. Thank you, Ashok. Thank you very much.
Thank you very much.
Thank you, sir, for very nice lecture. Next, we move to imaging in chest medicine. We all know that whenever we see a suspect a patient of ILD and we have done a CT scan, it's very easy to say ILD, but after that our role starts how to classify that. And we all face this difficulty, and to enlighten us on this, we have Dr. Khushbu Pilania, MBBS MD Radiology, who have got a special interest in chest radiology and musculoskeletal radiology, and she is currently affiliations with Eisen Imaging and Interventions Noida, and picture this by Jankaria sir. She is a member of Indian Radiological and Imaging Association, Joint ILD Guidelines Committee of ICS and NCCP. She is also a member of Society of Chest Imaging and Interventions and Non-IPF ILD Consensus Statement Group, International Weight Bearing CT Society, ICRI Musculoskeletal Subspecialty Team, Musculoskeletal Society of India, and Indian Musculoskeletal Oncology Society. So I invite Dr. Khushbu Pilania for her the next lecture, and she will enlighten us on the topic of HRCT thorax in ILD.
Very good afternoon, everyone. At the outset, I would like to thank the organizing committee and the chairpersons for that kind introduction, and Dr. Ved Prakash for having me here. It's always a great pleasure to be in Lucknow and speak on HRCT ILD, all a passion for me. So what I'll be doing over the next 20 minutes is talking about how HRCT helps in interstitial lung disease. The agenda will be to begin with the ideal protocol for HRCT, which is the bottom line for an ILD diagnosis and an ILD management as well. Then I'll talk about the systematic approach to interpreting an HRCT. We will talk about how we can differentiate fibrosing from non-fibrosing ILD, what is the recent pattern definition of IPF, how we can differentiate and diagnose hypersensitivity pneumonitis and NSIP, and a bit on the latest scoring pattern for interstitial lung disease. So this is one slide which is the most important slide and which needs to be imbibed in each one of us as pulmonary physicians, as general physicians, as radiologists, that the scan needs to be done right. The moment the scan is done right in the current era with so much of digitization, if you have the correct scan of the patient, it can be flown across the world for a correct diagnosis. So the utmost important is not so much how it is read, but how it is done. This is the ideal protocol for an ILD, which requires a full inspiratory scan, which should be a volume scan, followed by an expiratory scan, again a volume scan with adequate HRCT reconstructions, then a prone scan, which should be a mandate in every patient who's being scanned for the first time for an interstitial lung disease. In subsequent follow-ups, this can be avoided. And the documentation, which is equally important, should be always on a soft copy based modality. Either it can be in the form of a cloud share, which is easily available nowadays, or at least a CD or USB. Films should be avoided as much as possible because they cannot be reproduced, and at the same time we understand that all interstitial lung disease patients are chronic patients. They will require subsequent follow-up where we will need to answer whether it has increased or decreased. It cannot be followed up on the films as well. So this is one thing which is very important, and if we send our patients for any HRCT for an ILD, maybe we can, just keep a snapshot of this and attach it to the patient's prescription so that we make sure that the scan is done in a proper protocol. Having said that, and once we've got our scans right, now we come to diagnosing an interstitial lung disease. So we are looking at a specific subset. We are looking at interstitial lung diseases. The first question that comes when I, as a radiologist, report a case of an interstitial lung disease is whether it's a fibrosing interstitial lung disease or a non-fibrosing. We forget about everything else, but the first question that we need to answer to our referring physicians, the pulmonologist, is whether it's a fibrosing or a non-fibrosing interstitial lung disease. The bottom line to diagnose a fibrosing interstitial lung disease is to know how honeycombing looks like. The moment we know it is honeycombing, we know it is fibrosing interstitial lung disease. So it's the key point. The only thing which you take away apart from the protocol is maybe to diagnose how honeycombing looks like. So this is the specific definition. All these 5 parameters should be met. The moment all these 5 parameters are met, we know it is honeycombing. If either of these are not met, we should think twice before calling it honeycombing. So it means a cluster of cystic air spaces with a consistent diameter. By consistent, we mean that the diameter is more or less equal. It can be a single or a multiple layer. Honeycombing is usually almost always subpleural. They share their walls, and there is architectural distortion. So on this image, if you see, we have a subpleural stack of cystic air spaces which are sharing the wall. There is architectural distortion and it has subpleural distribution. Once all these criteria are met, we know we are dealing with honeycombing. These are the common differentials of honeycombing, and we'll see one by one how we can differentiate one from the other. This is a very characteristic honeycombing. Again, we see some lucencies throughout the lung, but when we look at these lucencies, there are no walls. They are not subpleural, they are not sharing the walls, there is no architectural distortion. It is not honeycombing, it is centrilobular emphysema. We look at this and we say that they are sharing walls, they are subpleural, but there is no architectural distortion at all. So it is not honeycombing, it is paraseptal emphysema. Again, we have cluster of air spaces sharing walls, but in this cases they are not subpleural, and if we see the min-IP images, reconstructions on the volume data that we have with us, we can see that these air spaces are all intercommunicating and moving towards the hila. When we see such a kind of an appearance, it is bronchiectasis and not honeycombing, because honeycomb cysts do not have an intercommunication with each other and they do not move towards the hila. Again, a conglomerate of cystic areas within the lung, but we see them scattered randomly. Intervening lung parenchyma is normal. They are of varying sizes. This is definitely not honeycombing, and we are dealing with cystic air spaces and a cystic lung disease in this case. So this is how we can differentiate honeycombing from the other causes which cause lucencies within the lung parenchyma. Now, when we have honeycombing, we know it's a fibrosing interstitial lung disease. Apart from honeycombing, there are few other features which also point towards a fibrosing interstitial lung disease, which includes traction bronchiectasis. So traction bronchiectasis is a cicatricial kind of a bronchiectasis which develops due to the fibrosis within the lungs, This is also more often in a subpleural distribution, though it can be seen towards the hyla as well. But when we see a lot of architectural distortion, thickening of the bronchi and tiny dilation of the bronchi, this is where we are dealing with a traction bronchiectasis. When we see it in a setting of interstitial lung disease, we know we are dealing with a fibrosing interstitial lung disease. Persistent reticular opacities with architectural distortion. So when we see these lines all over the lungs, which are irregular and there is architectural distortion, this also points towards a fibrosing interstitial lung disease. So if either of these three features are present in a patient with interstitial lung disease, we know we are dealing with a fibrosing interstitial lung disease. So the moment we've diagnosed that the interstitial lung disease we are dealing with is a fibrosing interstitial lung disease, the next question is, what is this? Which interstitial lung disease? Which fibrosing interstitial lung disease it is? To be able to answer that question, now we look at the predominant pattern. We go into more meticulous details of the lung parenchymal involvement. We see which of the following patterns is involving the lung parenchyma most. We decide on the distribution of the disease. So whether the disease is involving the bases more than the upper or the mid zone, or in the axial scans, whether it is involving the periphery more than the center. On the basis of these findings, then we can further characterize the fibrosing or the non-fibrosing interstitial lung disease into a specific subtype. So we go one by one. So one of the most predominant patterns that we look for are the reticulations. Once we see reticulations, which are seen as a lot of lines all over the lungs. So when you see the HRCT scan and you say that there are a lot of lines, all we see is a lot of lines all over the lung, then we know that the predominant pattern is reticular. Now we try to characterize the reticular pattern further. So for example, in this case, this is a normal lung parenchyma and this is an abnormal lung. We see a lot of lines in this. How are these lines? These lines are all irregular lines. So when you see such irregular lines, we know we are dealing with a fibrosing ILD, most often seen with a UIP/IPF pattern or a chronic hypersensitivity pneumonitis pattern. Another pattern of these lines are, again, we are seeing a lot of lines. This is a normal lung, a lot of lines in this lung, but these lines are rather smooth. I'm not seeing any architectural distortion. So when we see such smooth lines, the top differential is pulmonary edema. In this case, we are also seeing this pleural effusion. So it's a case of pulmonary edema. So when the lines are smooth, it's pulmonary edema. Another pattern of lines are when the lines are accompanied by nodules or the lines are themselves nodular. So when you see these nodular lines, then sarcoidosis and lymphangitic carcinomatosis should be your top differentials. So this is how, just on the basis of the way the lung parenchyma is involved, we can narrow down our differentials. The other predominant pattern in which the lung can be involved is by ground glass attenuation. So this is a normal lung, again the abnormal lung, where we are seeing large areas of ground glass attenuation. The predominant pathology involving the lung is ground glassing. The ground glassing can be in the mosaic pattern, as we see in this case, where we have patches of normal lung and interspersed well-defined patches of ground glass, or it can involve the entire lung diffusely. Then we have the nodular pattern. So the nodular pattern can again be characterized on the basis of how it is distributed and what is the character of the nodules. So when I look at this scan, I see a lot of nodules. What is the distribution of the nodules? The nodules are all with a peribronchovascular and fissural distribution, and they are discrete nodules. By discrete, I mean that these nodules can be pinpointed with a sharp pencil. We can easily see the nodules well. So such a pattern of peribronchovascular fissural distribution of discrete nodules is again seen commonly with sarcoidosis and lymphangitic carcinomatosis. In this case, again I am seeing discrete nodules but with a rather random distribution. So when you see these discrete nodules with a random distribution, we need to talk about pneumoconiosis and miliary tuberculosis. The other very characteristic pattern of the nodules is a centrilobular pattern of ill-defined nodules. So this characteristic ill-defined nodular pattern, where the nodules are not seen so well, you see the nodules all smudged over, is very characteristically seen with acute hypersensitivity pneumonitis. So it's a very characteristic picture of acute hypersensitivity pneumonitis. Then we have consolidations, which we are all well aware of. It is seen with organizing pneumonia. When we talk about the distribution, when I say peripheral, we draw a circle in the center of the lung, and if we see that the involvement is outside the circle, we know that the disease is peripheral. When the disease is peripheral, the second thing we ask ourselves is whether it is reaching up to the pleura or not. So it is reaching up to the pleura. This is a disease which has a peripheral subpleural distribution, as against this case again, where I am seeing that the center of the lung is rather spared, but at the same time the pleura is also spared. So the disease has a peripheral distribution but with subpleural sparing. This is a case where there is no specific center versus peripheral distribution, so the disease has a diffuse axial or a peribronchovascular distribution. This is how the disease is distributed on the basis of the axial involvement. When we talk about the zonal pattern, we say whether the apices are involved more or the bases. So when we do our MPR reconstructions, we can easily differentiate that the bases are involved more than the apices. We can very clearly define this distribution. Even when we put the axial sections all together, we can clearly see that in this case, the upper and the mid zones are involved more while the bases are spared. So it is very important to make a note of how the disease is distributed, because this defines what can be the underlying etiology. So now we've talked about the fibrosing interstitial lung disease. We've learned on how we can differentiate into a specific subtype. The second important question comes is that yes, it's a fibrosing interstitial lung disease. Is it IPF or is it a non-IPF fibrosing interstitial lung disease? To answer this, we have the pattern definition by the ATS-ERS, which defined it into 4 specific patterns on the basis of HRCT, which helps us differentiate which amongst the fibrosing ILD will be an IPF fibrosing. So we look at these 2 specific patterns. In a typical UIP pattern, the disease should have a subpleural basal predominance. It should have a heterogeneous distribution. Reticulation is the predominant abnormality. There is presence of honeycombing, and there should be nothing else as the predominant pattern. So no no ground glassing, no cyst, no nodules. If there is ground glassing, it should be much lesser than the amount of reticulation. So once all these 5 criteria are met, we know we are dealing with a typical UIP pattern. A probable UIP pattern has the same set of criteria, except that the honeycombing is not present, but we have traction bronchiectasis and bronchiolectasis. So once you have this pattern, it characterizes and classifies into a probable UIP pattern. The indeterminate UIP pattern is a wastebasket term, wherein this is the category which requires biopsy more often, and we cannot characterize on the basis of HRCT findings. There are certain CT features and distribution which help us define an alternate diagnosis, and we should be aggressively searching for them, which includes the presence of cyst, mosaic, ground glass much greater than reticulations, nodules, consolidation, and when the disease has an upper or mid lung predominance or a peribronchovascular distribution. I'm not going into this because this is more for radiologists. What we want to say is that once we have a fibrosing ILD with a typical or a probable UIP pattern, then only an HRCT can be considered diagnostic of IPF if the patient is more than or equal to 60 years of age and there is no identifiable cause. There is no need of biopsy in these cases to prove the patient to be having IPF and to start that treatment. This is again a more robust clinical likelihood put forth by Cotton et al. In a recent paper, which helps us be more specific about the diagnosis basis the HRCT findings itself. Amongst the non-IPF fibrosing ILD, these are the 5 most important, of which chronic hypersensitivity pneumonitis, CTD, ILD are the topmost scorers and which we should be knowing. A brief word, I think I'm falling short of time, so a brief word on hypersensitivity pneumonitis. The classification is non-fibrotic, fibrotic, the latest classification. The typical HRCT findings, as I said, are these centrilobular nodules, the ground glass which has a mosaic pattern, and a typical upper lobe fibrosis. And they say that if the extent of mosaic attenuation is much greater than the reticulation and the disease has a diffuse axial distribution, then in a patient who is suspected to have hypersensitivity pneumonitis, again the specificity is very high and a biopsy is not needed. A very typical acute hypersensitivity pneumonitis picture where we are seeing these centrilobular nodules with a ground glass attenuation and diffuse distribution. a typical mosaic pattern seen with hypersensitivity pneumonitis, the upper zone fibrosis, and the inspiratory expiratory scans accentuating the air trapping. This is very, very characteristic of hypersensitivity pneumonitis, and that is why the expiratory scans are a mandate. The non-specific interstitial pneumonitis is a pattern commonly seen with connective tissue diseases. Idiopathic NSIP is very rare. Please aggressively evaluate a patient for connective tissue disease before labeling them as idiopathic NSIP. This is a very characteristic pattern of NSIP, wherein we see predominant ground glass opacities with a basal predominance, a very homogeneous distribution of the disease, and with subpleural sparing, very minimal reticulations and no honeycombing. So a very characteristic picture, and in this case we can see this dilated esophagus. The patient was a case of scleroderma. So just to wind up the diagnostic algorithm for interstitial lung diseases, the first question is fibrosing versus non-fibrosing. How do we answer that? We look for honeycombing, traction bronchiectasis, reticulations. The moment either of these is present, we know we are dealing with a fibrosing interstitial lung disease. Now the question is whether it's an IPF or not. If the pattern has a definite or a probable UIP pattern, the patient is more than equal to 60 years of age and there is no other identifiable etiology, then it becomes an IPF, UIP ILD. If either of these is not present, then it becomes a non-IPF fibrosing interstitial lung disease, in which case and also in the cases of non-fibrosing ILDs, we need to put the pattern of the disease involvement and the distribution of the disease to make our final diagnosis. What we should remember is that chronic hypersensitivity pneumonitis, sarcoidosis and CTD ILD are amongst the top scorers for non-IPF fibrosing ILD as well as the non-fibrosing interstitial lung diseases. So this is the final algorithm on this, and I will just, I'm skipping on the scoring part for the, I will just put ahead the take-home messages, wherein I would like to say that an adequate technique is an absolute must. Whenever we are dealing with a diffuse lung disease, try to define whether it's a fibrosing or a non-fibrosing ILD. In a patient greater than or equal to 60 years, if we have a typical or probable UIP pattern and no obvious identifiable cause, then we can label it as IPF without the need for biopsy. Rest all fibrosing ILDs require an aggressive evaluation for the etiology. All UIP is not equal to IPF. Hypersensitivity pneumonitis is a very common ILD, and AI-based techniques, which I did not touch upon, when used judiciously can make lives much easier, but a lot needs to be done still to implement them. Thank you.
Thank you. It's always difficult to type the ILD, but with your enlightened lecture.
With that. So just about that point.
So this is where the ATS, ERS and the Fleischner guidelines, everyone put it ahead that the moment we see
there is a microcystic honeycombing. My question is it some related to...
Thanks Dr. Khushbu for the excellent lecture.
Thank you.
Thank you, ma'am. Next in the line we have Dr. Mansi Gupta, ma'am, to enlighten us on role of USG in pulmonary medicine and critical care, and she is having so this is MBBS, DNB and DM in pulmonary medicine and fellowship in sleep medicine, European diplomate in adult respiratory medicine, and she is currently associate professor in Department of Pulmonary Medicine, SGPGI, Lucknow, and she has got a total professional experience of 12 years, DM fellow from VMMC Safdarjung Hospital, and she was assistant professor in Department of Pulmonary and Critical Care, PGIMS Rohtak from 17 to 18, and Department of Pulmonary Medicine, SGPGIMS from 18 to 21. She has many honors and awards in her CV. She is Best DM Fellow, Gold Medal in Pulmonary Critical Care and Sleep Medicine from Vardhaman Mahavir Medical College in Safdarjung Hospital, Delhi. She was awarded Gold Medal in Fellowship in Sleep Medicine, ISDA 2012. She has got Best Research Paper as Young Scientist Award in NAPCON 2012. over 45 publications in national and international journals and books, over 60 presentations in various national and international conferences, and she is a reviewer and editor for some reputed national journals in our country. Next to you, ma'am.
Thank you, chairpersons, for the kind introduction. And before I begin with this, I have to thank Dr. Ved Prakash sir and his entire department for giving me an opportunity to be here and deliver this talk. So I'm going to talk about about the basic things about ultrasound. What is the role of ultrasound in pulmonary medicine, more so in pulmonary medicine and critical care also. So as clinicians, we all want that we need to have an accurate and rapid diagnosis so that the patient outcomes are best. And there is an inherent need to have a rapid access to making accurate and reproducible imaging techniques to diagnose the pathology and implement and then monitor the treatment. So what do we have for these, making a clinical diagnosis? We all rely on our physical examination, but as we know, in critically ill patients or who are walking in the emergency, the diagnosis cannot be made with physical examination. It is insufficient, and patient is sometimes not cooperative. The bedside sonography, chest radiography, it has again a limited accuracy, as we know that the patient, routinely we are doing chest radiography in a standing patient with a PA film, but in critical patients, patients are they are laying supine, and the film is also AP, so a lot of features cannot be delineated on that kind of a chest radiography. Regarding chest CT, is a very good modality, but then for critically ill patients, we have a risk of transporting the patient. You can't do that all the time. Again, ionizing radiation is the biggest risk. You can at the max achieve 1 CT scan for a patient, but a critical patient has a very dynamic clinical status, so it keeps on changing. So you need something which you can do it more often. And again, not many hospitals or smaller setups would have the availability of CT scan in their center. So that brings us to the role of ultrasound, which is already being done by the critical care people and trauma people. It has been used as a bedside echocardiography for a long time, but pulmonologists were shying away from this modality for a long time, and now it is being recognized as most centers as a very important tool for diagnostic assessment. Now, what are the advantages? Very easy to understand. It is a point of care portable diagnostic tool, which means you can have it at bedside and you can start doing it right away as soon as the patient walks in. It is easily available. One ultrasound machine can be there in every setup. It's not a big investment. It is non-invasive. There are no ionizing radiation risk. You can do it more often. It is quickly performed. And you get repeatable and reproducible images. So if you're trained, and they say that the training for ultrasound is the fastest to achieve. You can learn it in a day or two of a workshop, and you can start practicing, and once you are versed with the imaging and the signature styles of ultrasound, you can actually be as good as a radiologist. Then you have real-time dynamic images, and as I said, it is quick to learn with a steep learning curve. Just one slide on the basic physics about lung ultrasound. It is all about the air, water, and the echoes that are created with that. So ultrasound are basically sound waves, and the appearance of the lung ultrasound that you achieve, the image that you get, it depends on the ratio of air and fluid in the lung, because there is acoustic impedance. Impedance is something which is the measure of resistance of particles or a medium to mechanical vibration. So that resistance, when the sound waves are encountering, they will be reflected back, and depending on the impedance of that particular tissue where it is hitting, the image will be created. And resistance increases in proportion to density of the medium and propagation velocity of the waves. That I'll be telling about. That is the probes that you are using, the frequency of the probes. Now, greater the difference in the impedance, greater will be reflection. So suppose there is a fluid, there will be constant impedance resulting in no echoes, and it will appear black. Soft tissues will have similar values and they will have minimal reflection. Now what happens in lung? You have air and soft tissue and bit of fluid. So air will reflect 99% of the US energy, and it will become impenetrable to ultrasound. But because of the soft tissues and other tissues in the lung, the normal aerated lung would look like a gray sort of picture. We will come to the images. Now, the practical part of ultrasound, very easy for the residents also to understand. There are 3 types of probes that we have in the ultrasound machines. One is the convex curvilinear probe, also known as abdominal probe. This is the most commonly used probe and the best probe. They say if you use this one, most of the lung ultrasound can be done by this. The other one is linear. The B one is the linear or vascular probe. And the C, the smallest one, is the phased or sector array probe or the echo probe, which is mostly used for cardiac screening. So the advantages of these, linear probe is the one with the highest frequency. So we should remember one thing, that as the frequency of the probe is higher, there will be good resolution for the superficial structures, and deeper structure scanning will be poor. So in linear probe, you will be using it for more superficial assessment, but that would be, you can actually do it for vascular access when you're putting your central lines and your other things, and also when you're scanning the pleura and the lung sliding sign, because they are the most anterior structures in the lung, so you can easily visualize, and with lot of good resolution, the superficial structure like the pleura and the lung rubbing against each other, so sliding sign can be very well delineated. But as you know that the penetration will be poor to deeper structures and the narrow width will be there, so you cannot have a very good depth scan. Then curvilinear probe, as I told, is the best all-rounder probe for ultrasound. It has got both good penetration, it has got a large sector as the shape of the probe is, and lung sliding can also be seen, and almost all pathologies that I'm going to talk about, effusions, consolidations, diaphragmatic movements, they can be done with it. The phased array probe is a smaller probe. So in patients who have smaller rib spaces, same thing with curvilinear probe, whatever you can do with this also. But since the frequency is little lower than the curvilinear probe, so the clarity of the images is not very good. And it is mostly used for cardiac assessment otherwise. So these are the 7 principles of lung ultrasound which I have got from a very good article on lung ultrasound. They say that a simple technique is suitable, so you should go in a very protocolized manner. As we've been talking about the air fluid mingling and ultrasound being dependent on that, so one can define a macro gas or fluid ratio like a pleural effusion and the aerated lung, and a micro gas or fluid ratio, which will be when they'll be in a smaller place and the 2 elements will coexist. Third is that you should be well defining your areas of interest. So see, the lung is throughout the thorax and you have a very big area to scan if you go otherwise. So actually they have made it simpler for us by devising a methodology or protocol in which you can scan the lung and still not miss on any important diagnosis. These points I will be coming to, are the blue points. All the images, they say that you have to start focusing, when you start scanning, look at the pleural line. So image should be made from the pleural line. You should focus on the pleural line and then start defining your image. And there will be a lot of artifacts in the ultrasound scanning based on many things. So these artifacts are definitely, you should be aware of them, but they are not supposed to be ignored because many of them will actually help us in making a diagnosis. Since I have already said lung is a dynamic organ, the first thing you have to visualize in a lung scan is a normal sliding sign. This is where we start. And life-threatening disorders, they said, as a principle they have mentioned that mostly they are abutting the chest wall, and even small ones, they have extensive location. Now, performing the scan, most commonly there are 2 ways to put a probe. It is not a difficult thing to know. You can either put the probe longitudinally, as you can see on the figure on the left side, or you can put the probe transversely. So the most commonly used position is the longitudinal scan, where you can see there are, is there a pointer here? So in this you can see that this is basically covering an area where there will be 2-3 ribs here. So all these black lines are basically rib shadows, and the other one is the lung with the pleural line. So this is a bigger area. Now when I want to focus on one area, I can actually make one portion by changing the sector settings and the depth settings, and I can change it to my area of interest. So this is how a lung scan would look like if we put the probe like this in the longitudinal scan. This is about where all to scan. So if you're actually scanning the patient overall for making a diagnosis as a person handling a critically ill patient, so you have to do it at least at 6 points on both sides. So one is the anterior upper blue point, which is just below the clavicle. You can place your hands like this. Is a rough assessment. It is nothing calculated. And then putting the second palm one above the other, this is a second blue point. It is basically corresponding to the lobes of the lung. So you are covering the upper lobe also, lower lobe also. And then the third point is basically in the posterior axillary line. When you extend this point backwards to the posterior axillary line, where they meet, you have to go as posterior lateral as possible to scan this portion. This will give you a good area to scan for your postophrenic angles and also all the lower lobes also. So this is what a normal lung looks like. This is the magnified view of the longitudinal cut that we had seen. So we are focused on one sector, one intercostal space. So this is one rib here, the other rib is here. And there is a pleural line that you can see, which is the first thing which is said. This is above, what all you can see is the skin and the subcutaneous tissue and the fat. And there, this is the visceral pleural line and the, parietal pleural line and the visceral pleural line, and their movement against each other will be the sliding sign. This space, actually they have given names to these. So one sector that you create, this is the Merlin space. This is one Merlin space limited by the pleural line and the shadows of the ribs, and the bottom is the screen. This is in the B mode. Same image, you can actually change modes on the ultrasound machine, and this is the M mode image of the same thing, where you can see a seashore or the sand sign, where you can have a granulated appearance of the lung, and this is the pleural line corresponding to this pleural line. This is what a normal lung looks like. So this is the normal lung sliding sign. Again, a magnified picture. We have decreased the depth again and seen the trying to focus on this. This you can actually, to visualize sliding better, you can change the probe. If you are not able to visualize in patients who are obese, you can change the probe with a vascular probe and definitely document lung sliding sign. So this is basically a homogeneous twinkling or shimmering, whatever you can say, of the surfaces that you can see in the Merlin space. Now coming to 5 major things, you have to pick up basic pathologies with lung ultrasound. One is diagnosis of pneumothorax, pleural effusion, pulmonary consolidation. When I say consolidation, it is means a dense lung which is filled with something. So there are many things which can fit into this kind of a image, okay? And then there is interstitial syndrome, which could be due to again filling of alveolar spaces and other in cases of pulmonary edema. And then there is PLAPS. So coming to pneumothorax, this is basically, like I said, that there is this Merlin space with a sliding sign. So there will be absent sliding sign here. There will be no sliding sign. And when you shift it to M mode, there will be barcode or no sand appearance, as I had shown in the normal lung, also known as stratosphere sign. And so how a pneumothorax is going to be diagnosed? Absence of sliding sign, there will be no B lines, and we'll come to lung point and lung pulse. So this is what a pneumothorax, actually they say it is the most sensitive method in an emergency setting to diagnose a pneumothorax. First you document a lung sliding sign. If it is not present, look for the B lines. Then look for the lung point. So if you scan the lung at different points anteriorly and other the 3 points that I mentioned, you can find out this kind of a profile. This is a normal lung and this is the barcode sign. So this is, if you see this kind of a pattern where both the things are meeting, this is a pneumothorax and this is air, so you can actually confirm the presence of a pneumothorax. And lung pulse is nothing but basically sometimes you have a false kind of a lung sliding sign which is coinciding with your heartbeat, which is just kind of a small motion artifact created by the cardiac pulsation. So when all these things are ruled out, then only they say that there is no pneumothorax. For pleural effusion, it is much simpler. So you go for the Plapp's view to even find out the small effusions. And this is the visceral pleura, that is the parietal pleura. In between, you see the pleural fluid. And they have named it as Squad sign also. And if you put it in M mode, you can see the sinusoidal kind of a pattern where you can quantify the fluid and even use it for diagnostic tapping. For consolidation, there are multiple signs. So basically, when you have this ragged kind of a border appearance, and in between you see some punctate shimmering effects, which are basically, sometimes they are dynamic air bronchograms, then this kind of pattern is basically, and this is a shredded kind of appearance for non-lobar consolidations, when a small consolidations are there. So this is a pattern which is seen in lung consolidation. And if you have a translobar consolidation just like this, the whole lobe is involved, left lower lobe, then probably you can actually appreciate there's a spleen here and diaphragm here, and the entire consolidated lung looks like even the spleen. So this is the tissue, it's almost like a tissue look. So this is the whole lung is kind of consolidated. Air bronchograms can also be seen. So these are the dynamic air bronchograms. They are not must for the diagnosis of pulmonary consolidations. So you can see this shimmering effects if you see. These kind of, when active respiration will make these very prominent. Then this is just a slide, I will not go into the details. Basically lung, the kind of pattern that I showed you on for lung consolidation can be seen in other things like atelectasis also, pulmonary infarcts, lung contusions, and different types of pneumonia, sometimes the pulmonary embolism infarcts also. The last pattern is interstitial syndrome pattern, also known as lung raucous. They are defined by the B lines. So these are the B lines. So now B lines can be sometimes like, you know, they can be just artifacts also. So they have tried to, when you have to name a pattern, at least 2 to 3 B lines should be visible between the ribs. And B line definition also is very strict. So it has to start right away at the pleural line. It has to go all the way down to your screen. Sometimes your B lines will finish here. They are not exactly B lines because they can be artifacts. And based on the numbers of B lines, they have tried to define whether it could be due to interstitial septal thickening or the curly B lines, or maybe when there are more in number, it could be just alveolar flooding and ground glassing patterns. So they can be more towards that. Again, with the appearance of the B lines, with practice, when we have started scanning more and more ultrasounds, we can actually find out that they can be used to differentiate between cardiogenic pulmonary edema and ARDS. In ICU patients, if you have done all these profiles and you know how to pick up these effusions, pneumothorax and everything, so if a patient walks in with a dyspnea, then this is a very good protocol, blue protocol that we have been using for a long time, and it helps us in kind of ruling in a lot of diagnosis and ruling out other pathologies. So these kind of profiles are easy, that I have already explained how to make them, and following this flow chart, we can go and make the diagnosis. I will just take a couple of more minutes, that's it. So this is about the sensitivity and specificity of ultrasound, and as you can see that it's almost above 90% sensitivity and specificity beyond 95% for all the things that we have learned. So final slide about the critically ill patients, we can use it in patients with respiratory failure. With the blue protocol, you can find out the cause of the respiratory failure. There is a false protocol for patients of circulatory failure, a patient walking in with shock. So again, ultrasound can be very handy in kind of finding out the cause at the bedside. Things that are otherwise, which we do it very often, I'm just mentioning because this talk is too small to cover all those topics. We can guide fluids with ultrasound therapy. We can assess for deep venous thrombosis. Weaning has already been stressed out by the previous speaker. Then we can assess the rightness of NG tube placement and the bladder filling. Sometimes your patient is not passing urine. You can put a scan and find out if it's a obstructive cause or not. You can actually aid your procedures like thoracocentesis and tracheostomies. And other uses will be, there are certain more protocols that you can that have been developed for patients in ICU. This is the false protocol. We can all find out how the circulatory shock will work. And the final take-home message is that lung ultrasound science, either alone or combined to other point of care techniques, are helpful in diagnostic approach to patients with acute respiratory failure, circulatory shock and cardiac arrest. And it can be used for early detection and management of many complications, especially when your patients are ventilation, mechanical ventilation. Picking up pneumothorax or pneumonia, ventilator-associated pneumonia and effusions is much easier with ultrasound because patient is not shiftable anywhere. So thank you for your patient listening.
So thank you, Dr. Mansi, for the excellent talk and practical talk. I believe that these points which you have mentioned are our previous speakers have taken care of, will definitely going to help our students of the critical care medicine, and also we are also learning the same. See, one point which I want to just mention, add on this, that what we are doing in our clinical practices, I think most of the hospitals now, what you have mentioned, they have the ultrasound machine in their critical care room. Mostly now as a pulmonologist, it is helping in pleural aspiration, especially in localized effusion. Now, if you have that modality, if you have ultrasound with you, definitely you can pinpoint that where actually the fluid is collected, and that guides us for the better management. So this is what we are mostly using for in our practice. Thank you very much. Any comments or the questions? Dr. Ashok Kumar Singh, I think. No? Ashish? No. Thank you, madam. Thank you so much.
Thank you, chairpersons. Thank you, speakers. Now I call upon our HOD, Dr. Ved Prakash sir and Dr. Rajendra Prasad sir to honor our speakers and chairpersons. So for this, first I call Dr. Ashok Kumar Singh sir to come on stage. Dr. Khushbu Plania ma'am, Dr. Mansi Gupta ma'am, please come on the stage. Dr. Khushbu Plania ma'am. मिल जाएगा मैम, वो भी है. डॉक्टर मानसी गुप्ता मैम. डॉक्टर SN गुप्ता सर. डॉक्टर अश्विनी मिश्रा सर. डॉक्टर उत्कर्ष कुमार श्रीवास्तव. Thank you, sir. Thank you, chairpersons. Thank you, speakers. So this is last session, and in this session, this is surgery in tuberculosis pulmonary medicine. Only one lecture is there because of some emergency. Dr. Rahul Chandola is not able to come. So for this session, I call upon Dr. Anurag Rai. He is Additional Professor, Department of Thoracic Surgery, King George Medical University, Lucknow. Dr. Abhishek Goyal. Dr. Abhishek Goyal. He is Consultant, Pulmonary Medicine and Intensive Care Unit, Lucknow. Dr. Jalis Fatima, she is here. Okay. So now I hand over mic to our chairpersons to start session. Thank you.
I think this is the last session. This is a surgical section in the academic section. So I call upon Dr. Suresh, Professor Suresh Kumar, to deliver his talk, and he will be delivering his talk on this section. This is a brief CV of Dr. Suresh Kumar, and he is professor in charge in Pulmonary Surgery Unit and Department of Surgery. His main area of interest is pulmonary surgery, and he has got 36 national and international publications to his credit, and he has a vast experience of 18 years in teaching. So, and he has also written 2 book chapters, has delivered many lectures in pulmonary on pulmonary surgery, and he is also a co-investigator in New Ward's phase 2 therapeutic trials. So over to Professor Suresh sir.
Thank you, Chairperson. Good afternoon, all the respected dignitaries, speakers and delegates, resident and organizing team. Special thanks to Dr. Rajiv Garg, Dr. Kushwaha, Dr. Rajendra Prasad sir, he is our teacher, and special thanks to Dr. Ved Prakash to giving opportunity to deliver this lecture. It is a difficult task to present a lecture in front of pulmonologist to what are the treatment of the tuberculosis. Tubercular treatment is initiated from surgery, and lastly surgery is the required when the drug resistant occur. शुरुआत भी हुई सर्जरी से और अंत भी सर्जरी से होती है. Thank you to give him an opportunity. Our topic is role of thoracic surgery in management of tuberculosis. First, thoracic surgical procedure is performed by Hippocrates. Procedure was a open window thoracostomy for a pleural empyema. Thoracoscopy is introduced in 1912 by Jacobius to take a pleural biopsy and do the adenolysis. Before the laparoscopy, thoracoscopy is the came. These are some historical background. First, pneumonectomy was performed in 1895, and after that, lobectomy, bilobectomy. Then, in 1950, introduction of double lumen tube, who easy out the thoracic surgeon to do the pulmonary surgical procedure. In 1954, and introduction of medistinoscopy for the diagnostic purposes. You better know about the tuberculosis historical background, but I give a brief about the tuberculosis. In 1882, Robert Koch identified the tubercular bacilli, and there is after some time, initially the surgery is the treatment of the tuberculosis, but after 1940 and 1960, when the anti-tubercular drug came, then changed the treatment scenario in the tuberculosis, and transmission through the droplet spread, and diagnosis is the basic is the sputum, and the other exudate pus are the other material, pleural fluid, and and X-ray radiological investigation is the supportive for the tuberculosis. Basic symptom of the pulmonary tuberculosis and extrapulmonary tuberculosis, you know, there is some prodromal symptom and specific organ-based symptom. And what are the indication of surgery in the urgent when patient have a profuse thoracic hemorrhage due to the tuberculosis, or most of the time spontaneous tension pneumothorax need a immediate intervention like a intercostal drainage in the tension pneumothorax, and urgent surgery is needed, irreversible tuberculosis progression despite of adequate anti-tubercular chemotherapy, and sometimes in recurrent hemoptysis. Localized in elective cases, localized pharmacavitary lesion in the post-tubercular, and in the MDR and XDR, failure of anti-tubercular drug is the choice of the surgery. There is some common indication due to the complication of tuberculosis, and after tuberculosis there is some sequelae developed to the pneumothorax, like maybe sometime development of pneumothorax and pleural empyema with or without bronchopleural fistula, aspergilloma, and chest wall abscess, cold abscess, and empyema necessitans, constructive pericarditis. And this is important is the post-tubercular sometimes tracheal stenosis and large bronchial stenosis, symptomatic post-tubercular bronchiectasis, and spinal, especially dorsal spine, sometimes is the needed some drainage. These are the some post-tubercular complication which needed a surgery. There is some contraindication of the surgery in the tuberculosis is the extensive cavitary lesion in the both lung, maybe sometime needed a lung transplant, and in impaired pulmonary function test and pulmonary heart failure, BMI is the large, severe comorbid condition, and active bronchial tuberculosis. These are the some techniques of the surgical technique we apply in the pulmonary resection. Is the wedge resection is when the cavitary lesion, healed cavitary lesion less than 3 centimeter in diameter, non-anatomical resection is performed. Maybe sometimes in the bronchiectasis or fibrocavitary lesion, in the segmental involvement go for the segmentectomy, lobectomy, and if the entire lung is the involved, is the one side is the go for pneumonectomy. And in the open drainage, when patient is the comorbid condition not tolerate the extensive surgery and the anesthesia, then they go for the window thoracostomy. And in this case, maybe sometimes needed when the cavity is the small, lung is expanded, needed thoracomyoplasty. Decortication is the large chunk in the thoracic surgery at our center. We are doing regularly decortication in the pleural empyema, the VATS, and open thoracotomy. These are the diseases, tubercular diseases, which needed a surgical intervention in the during active tuberculosis and after the tuberculosis, after the treatment of the tuberculosis. Chest wall abscess is the empyema necessitans, Kerizri, pleural empyema. These are the list which needed a surgical intervention. What are the chest wall abscess? You know, the collection of the pus in the chest wall, most of the time in immunocompromised patient. What the type of infection? Bone and joint involvement and sternoclavicular arthritis, primary soft tissue infection. These are the, there is the some soft tissue. This is the radiology of the patient, and this is the soft tissue side with the posterior lateral side of the abscess is the present, the soft tissue elevation. This in this case is also the one is the abnormality is the eventration of the diaphragm is the present in the same patient. And this is the same patient. There is the CT scan shows is the minor collection in the lateral posterior lateral side of the right side of the chest, along with the some reactionary pleural thickening is the present. In this case is the how to manage. First is the drain it. If the muscle is the necrose or the soft tissue is the necrose, need the debridement and dressing and start the antitubercular drug. Another, this is the picture of the a patient who is operated is the 5 year back for the pleural empyema, decortication is the performed. He is coming in the OPD, there is some collection in the anterior side, we are suspecting this is the empyema resistance. When CT is the performed, there is the superficial collection. This is the post-thoracotomy, post-decortication patient, in the 5 year back, he was operated for the pleural empyema. There is a collection in the pleural. This is needed only simple drainage in the local anesthesia. Another case is the X-ray, shows there is elevation, soft tissue elevation. In the CT scan, the same patient, there is some chest wall abscess, needs surgical intervention and drainage. And later, this is the CT scan of the same patient. This is the collection which is coming in thoracic but pre-pleural space. This is simply done in the local anesthesia. Other problem is the empyema resistance, is the characteristic of the pus coming in the soft tissue and skin of the chest wall along with the connection with the pleural cavity. Clinical feature is the patient is presented with the swelling, which is sometimes reduced in the lying down, and cup impulse is the positive in the empyema resistance clinically, and most of the time is the causative organism is the Mycobacterium tuberculosis and other fungal infection, maybe Pseudomonas. These are the classical picture of the empyema resistance. This is the pleural collection, this is the chest wall collection. This needed initially the chest drainage simply from the remote area, not go through the bulging area, and after that maybe sometime patient needed decortication when the pleural thickening is present and fibrosis is the present in the stage 3 empyema, needed decortication. Sorry. What are the caries rib is the destruction of the bone, is the present in the destruction in the clinically this is the present in the mass in the chest wall, which is the cystic in nature. What the spread is the hematogenous, maybe sometime direct spread to the pleural cavity. This is the destruction of the bone in the X-ray, and the same patient, this is the CT scan shows a collection as well as osteolytic lesion is the present. This needed, what are the needed? Needed a antitubercular drug excision of the rib along with the drainage of the pus. And other is the common problem in our scenario is the aspergilloma in the post-tubercular treated patient. Most of the time patient presented with the recurrent hemoptysis, pain and dry cup, and this needed a surgical intervention. This is the CT scan of the patient, which shows that there is some collection, fibrocavity lesion, and this is the crescentic shadow. And in this case, for the surgical procedure is applied, wedge resection when the size is small, when the 3 centimeter size of the lesion, go for the wedge resection. If the lobe is involved, needed a sometime lobectomy. If the entire lobe is the fibrosis, multiple site is involved, needed pneumonectomy. This is the short video which is presented with the patient is presented with the recurrent hemoptysis for the 6 months, and after that he is diagnosed as the aspergilloma and refer from the pulmonary department, and we plan it for the White's guided thoracoscopy. This is the initial photo. When we are started the White's, we are taking a photo from the facility to apply the recording from the recorder. These are taking video from the monitor. This is the short video. After that, making a port and identify the lesion, and this is the apply the stapler. This is the endostapler, and take the chunk, and this is the and put in the endo bag, remove from the thoracic cavity. Other lesion in the post-tubercular patient is the sequelae of the tuberculosis, the fibrocavitary lesion, pulmonary and associated with the nodule and mass and consolidated lung. This is the fibrocavitary lesion in the left side of the lung, And investigation how to confirm chest X-ray and CT scan is the confirmatory. These are the differential diagnosis of the fibrocavitary lesion. This is the intraoperative photograph. This is the lesion of this is the same patient. This is the diseased lung. And initially we planned for the segmentectomy, but the more than 2/3 parties involved. Patient is the needed lobectomy. We plan is the lobectomy. This is the some intra photograph. This is the resected part. After that, when we did the lobectomy, this is the cross section is the done. There is some finding the clay colored material is the present. This is the aspergilloma. This is the fungal infection. Other post tubercular sequelae is the bronchiectasis, and this is the basic pathology of the bronchiectasis you know better. And this is the post tubercular bronchiectasis change, fibrocavitary lesion. This is the compensatory hypertrophy occur in the right side. This patient is the needed pneumonectomy. The whole lung is the involved. This is the other picture is the bronchiectasis, not a post tubercular. How to treat? You initially apply the some medical treatment is the airway, bronchodilator and pulmonary rehabilitation, but the main chunk is the surgical resection. If the segment is involved, segmentectomy is the lobe involved, go for the lobectomy. If the entire, sometimes entire lung is the involved, one side is the go for lobectomy is, and other is the Pott's spine in the paravertebral abscess is the common extrapulmonary manifestation of the tuberculosis. Vertebral is the involved, is the dorsal spine is the commonly involved, the lumbar, then cervical. These are the clinical feature of the dorsal spine. This is the patient presented initially in the neurosurgery department, and MRI is the performed, initially diagnosed with the neurogenic tumor in the radiology department. But we came in our OPD, we go for the other investigation, CT scan, there is some collection of the pus in the paravertebral area and with the destruction of the bone. This needed the patient have a severe radiculopathy. Patient needed some surgical intervention. We drain it and the bone is the nebuled out. And other is the common problem is the taken in the last slide is the empyema. Pleural empyema is the problem, major problem is the our country is the in our scenario. These are the etiology is the primary cause is the pneumonia, but we concerned about the tuberculosis. Most of the patient chronic empyema is the coming in the our department is the post tuberculosis, and they are coming in the very late condition. These are the some secondary causes. You know about the secondary causes: thoracic, extrathoracic, in the traumatic, iatrogenic and non-iatrogenic. And these are the secondary causes. And skip this slide. And this is the X-ray of the chronic empyema, not a initial X-ray. This is the there is fibrosis of the visceral pleura, and in the CT scan this is the posterior lateral collection, and along with the some air entrap in there. This patient is the repeated thoracocentesis were performed in the outside. After that he referred, it is not resolved by the antitubercular drug and chest physiotherapy. This needed a surgical intervention because there is some pleural thickness, visceral and parietal pleura, needed the surgical intervention. This is the another X-ray. There is the split sign and needed surgical intervention. This is the CT scan of the old treated tuberculosis for the pleural empyema. He was taken antitubercular drug 8 years back, and he is complaining a chest pain in the left side. He is coming in the OPD, and X-ray is the show some dystrophic calcification, and the other investigation, further investigation, CT scan shows there is the some collection, pleural collection along with the dystrophic calcification of the visceral pleura and the pleural parietal pleura. This needed a surgical excision of the how to manage this. Initially the pleural empyema, put the chest drain and give the ATT. If the not resolved, go for the decortication, open or the White's procedure. And other is the our scenario when the patient is coming in the late, which is the not adequate pulmonary function test, not adequate for the major surgical intervention, go for the window thoracostomy. What is the decortication? Surgical removal of thick and elastic restrictive pleural peel, approach open or the White's guided, and this is the contraindicated in the active tuberculosis. These are the some benefit and drawbacks of the and contraindication of the video thoracic surgery. These are the patient which is coming in the our OPD. There is the laculated collection in the right side, and patient have a healthy lung and go for the White's guided decortication. We have so the short video. कैसे चलता है कहाँ चलेगा नहीं चलेगा अच्छा चलो कोई बात नहीं बैक करो इसको इसको चला दो हाँ ये वाला दिस इज द देखो वीडियो चल जाएगा इतनी दिस इज द short video. There is first is the confirm the pleural cavity, then make a port, 3 port is the made, and make a triangular line, and after making a port put a telescope and find out the cavity. This is the posterior lateral side of the cavity, laculated collection. There is the fibrosis present around the cavity. By the help of the hook, we remove the fibrous band, and this is the cavity. This is the cavity. This is the cavity. And all lung parenchyma is the removed from the lung laculated collection, and after that we put the suction cannula within the cavity and suck all the pus, and take the care to not spillage out in the thoracic cavity, otherwise infection is the spillage in the cavity. This is the dissected part, and after that positive pressure is the given and check the lung is the expanded. This is the post-operative X-ray of the same patient, and another short video of the White's. This is the acute type empyema. This is the acute type empyema. There is the debris is present in the cavity. First is the removed with the help of the sponge, and after that find out the peel, visceral peel, remove with the help of the sponge holder. This is the special type sponge holder. This is the lung parenchyma. See, this is the lung parenchyma. Visceral pleura is the present. This is the dissected out. This take more than 2 hours. Sorry. Another procedure is performed at our scenario, the window thoracostomy. This is the when patient is not able to tolerate the large surgery, and this is the same picture is the pre-thoracostomy, thoracomyoplasty. We are doing the window thoracostomy. After some time, secondary healing the occur, or cavity is obliterated, and after that we mobilize the latissimus dorsi muscle, pectoralis major, serratus anterior. These are the muscle to mobilize and do cavity, put in the cavity, and this cavity is the obliterated. We reduce the morbidity, the economical, psychological, physical, and social. These are the thoracomyoplasty. And another is the tahak, which is not coming. Dr. Ved is requesting कि सर 2 स्लाइड आप दिखा दीजिएगा. तो this is the another topic is the lung transplantation. It involve removal of the one or both diseased lung from the patient, replaced by the lung with the healthy organ from the donor. These are the indications of the, and how to do. First is the investigate this patient. This is the donor selection. Is the younger than 65 year, and absence of severe trauma and infection, and minimal pulmonary secretions, no history of the malignant neoplasia. These are the indication. Surgical techniques are the heart lung transplantation, single lung transplantation, double lung transplantation, and these are the complications of the lung transplantation. Thank you. Any question?
Thank you, sir. I think you have briefly covered all the surgical options for various pulmonary diseases, and you also touched regarding transplant, lung transplant. Is there any questions from the audience? If me, yes.
Thank you, sir, for nice presentation. Sir, my question is regarding the post-operative follow-up of the patient. The case you have shown in your presentation, that patient with the thickened pleura presented to you with the pleuritic chest pain. So what is the course of the patient after the post-surgical intervention?
The VATs are open.
You have performed the VATs, I think, in that particular case which you have shown. So whether the patient relieved completely with the pleuritic chest pain, or after surgery, what are the in your experience, what are the incidence of fibrosis recurrence in these kind of cases?
It is the major morbidity. Thank you for asking good question. In the VATs or in the open thoracotomy, pain is the chronic morbidity. This is the one post-operative complication occur in the both in the VATs as well as in the open thoracotomy. But the hospital stay in the VATs is the short, and in the open thoracotomy, hospital stay is the long. Either take 10 to 15 days hospital stay, but in the VATs is take 3 or 4 days. In the acute cases, we are selecting the patient in the VATs is the acute empyema, stage 2 empyema. We debride it, and most of the cases we are taking acute cases are a trauma cases, not a tubercular, because tubercular cases is coming in the late. Most of the tuberculosis patient is the coming in our OPD, in our department, in the 3 months, 6 months, even year or 2 years. So that type of patient is the needed. There is rib crowding of the rib, and there are thick fibrosis, even the 2 centimeter of the pleural thickness is the present. In that cases, we do the open thoracotomy. In this case, is the major morbidity is the every patient somehow they are complaining a pain. No patient is the pain free. We are giving long duration of the pain. We send the pain clinic in our institute. They are managing by they sometimes needed a barbiturate.
Thank you, Suresh. Let me confess, and I'll share one story. Suresh is my batchmate. I was doing MD TB and chest. He was doing MS general surgery. We both became faculty here. There was one patient whom we put an ICD, and that patient was roaming for last 6-7 years. Dr. Bhatia,
16 years.
16 साल. एंड जब हम बन गए फैकल्टी बन गए, और ये फैकल्टी बन गए। वो पेशेंट जब आई तो हमने उसको पकड़ा और इनके पास भेज दिया। हमने कहा भैया इसका कल्याण करो, शायद उसका इसने सर्जरी किया। सो दिस इज़ द फेट of some of the post-tubercular patients. They roam around in absence of the facility of the thoracic surgery per se. We have to look forward for a chest surgeon, because earlier he is being credited for starting a pulmonary surgical unit. He took initiative in very beginning, because earlier what he was showing one case of open window thoracostomy. That was the only option left. But now, say gradually, so say we at our institute, now he and now Anurag is there, few more person are there. These post-tubercular patients, they have certain things, but yes, morbidities are there. So ये एक मैंने कहा कहानी सुना दें, उसकी कहानी सुनाई नहीं, बहुत पुराने
कहानी
पेशेंट
इन्होंने नहीं सुनाई।
हाँ।
वो पेशेंट आया मेरे पास, तो इन्होंने भेजा, तो ये 2005 की बात है, 2006 की बात है या 7 की। तो पेशेंट से इन्होंने कहा कि ये बताई कि साहब हमें 35 टाइम्स उसका आईसीडी किया गया था, 35 बार बदली गई थी इंटरकोस्टल ड्रेनेज ट्यूब। तो इन्होंने कहा किसी इडियट ने डाला, तो कहा साहब आप ही तो डाले थे जब पढ़ रहे थे। तो तब इन्होंने स्टोरी बता कर कि भैया इसका कुछ करो, क्योंकि हमारा किया हुआ केस है और बहुत पुराना केस है। तो आई डिड द सिंपली द स्मॉल कैविटी, वी मोबिलाइज द लैटिसमस डार्साई मसल एंड पेक्टोरिस मजर एंड डिड द thoracomapllasty.
I think it's the last session and
okay. Professor Suresh is always rescue for us. कई बार ऐसा हुआ कि रेजिडेंट ने वो स्कैल्पल का ब्लेड अंदर छूट गया, एक दो केस ऐसे हुआ, तो वेट से तुरंत हम लोग आउट करवाते। थैंक यू सुरेश।
थैंक यू सर, थैंक यू सर।
okay, I think I should wind up the last session and I hand over the mic to Dr. Hemant.
Thank you, chairpersons. Thank you, speakers. And this was very good session. All have enjoyed. So, I call upon Dr. Ved Prakash sir, Dr. Rajendra Prasad sir to honor our guest speakers and chairpersons. I request speakers, Dr. Suresh to come on stage. I request chairpersons also to come on stage. I request sir to give memento to Suresh sir. Dr. Anurag Rai. Dr. Abhishek Kumar Goyal. Thank you, sir. Thank you, speakers. Thank you, chairpersons. And this is time to close the session. And for closing a ceremony, we need to have closing ceremony to close it.
वहीं बैठ जाएंगे उसी पर, कितने लोग बैठ।
I request all delegates to collect their certificates after closing ceremony or after lunch. बस 5 बहुत हैं, 5 बहुत हैं, बस हटा दो दो हटा दीजिए, नहीं छोड़ो, हटा दो। I request Professor Rajendra Prasad, he is organizing chairman of our conference. Welcome, sir. I request Dr. Ved Prakash sir, he is organizing secretary of UPTBCCON-2022. I request Dr. R.S. Kushwaha sir, please come on dais. I request Dr. Rajiv Garg sir to come on dais, and Dr. T.P. Singh sir, please come on the dais. I request Professor Rajendra Prasad, organizing chairman, to give closing remark.
So good afternoon. हर चीज़ जब कोई चीज़ शुरू होती है तो उसका एंड भी होता है. So we have come to the end of this very important conference. Let me say why I say it was very important conference, because UPTB Association used to hold a annual state conference of TB and chest diseases, and Dr. T.P. Singh is here, who is the Secretary General of TB Association of State of Uttar Pradesh. So we decided, we are trying for this conference for last 3-4 years, but unfortunately because of the COVID, we could not do it. This year also little plus and minus was there, but then we decided, no, we have to do it. So I must thank the Ved Prakash, organizing secretary, that who did this conference. And to my understanding, he did it very effectively, and he needs a compliment for that. जब मैं यहाँ वैलिडिक्टरी सेशन में बैठा हूँ तो मुझे अपने पुराने कॉन्फ्रेंसेस की याद आ जाती है, जिसमें कम से कम ये वेद प्रकाश और ये टीपी सिंह साहब और राजीव गर्ग, ये सभी सीखे हैं कि कैसे कॉन्फ्रेंस किया जाता है. क्योंकि हम लोग शायद लखनऊ के अंदर कंट्री का एक बड़ा यूनिक अपॉर्चुनिटी हम लोगों ने क्रिएट किया था कि सारे नेशनल कॉन्फ्रेंसेस चेस्ट डिजीज़ के, शर्मा जी भी बैठे हैं हमारे सामने, हमारे उस वक्त हमारे डिपार्टमेंट में हेड मतलब क्लर्क हुआ करते थे, वी ऑलवेज रिमेंबर हिम। और तो बड़ा ही मैं आज के दिन एक ही बात कहना चाह रहा हूँ कि कभी कभी हमें लगता है भाई ये सब हमारे बच्चे ही हैं, हम तो यही मानते हैं, और एक विभाग से 2 विभाग बन गया, ये और खुशी की बात है। तो मिलजुल के ही काम करना चाहिए, तो काम हमेशा अच्छा हो जाता है। और मैंने देखा कि ये काम काफ़ी मिलजुल के लोगों ने किया, और होप, क्योंकि डॉक्टर वेद प्रकाश के लिए भी मेरे ख्याल से जहाँ तक मेरा ज्ञान जाता है, इनका इंडिपेंडेंट ये पहली ही कॉन्फ्रेंस थी शायद ये स्टेट इतने बड़े लेवल की। So he must have gained experience, and I thank you all, TP Singh for UPTB Association, although I am also Senior Vice Chair of UPTB Association, RC Tripathi ji, जो उन्होंने मतलब it was his brainchild, वो मेरे पीछे पड़े रहते थे 2-3 सालों से कि डॉक्टर साहब करवा दीजिए किसी ढंग से। हमने नहीं सर करवा देंगे, घबराइए नहीं, शुरुआत कर हो जाएगी। तो द गुड थिंग दिस हैज स्टार्टेड, एंड आई प्रॉमिस दैट आई एंड डॉक्टर टीपी सिंह प्रॉमिस फ्रॉम टीबी एसोसिएशन साइड दैट इट विल हैपन एवरी ईयर। क्योंकि मेरा मानना है एजुकेशन बहुत ज़रूरी है। देखिए मुझे बड़ी खुशी है कि वैलिडिटी सेक्शन मतलब वैलिडिटी सेशन में बहुत कम लोग मिलते हैं आम तरीके से, लेकिन आज देखिए कितने लोग यहाँ अटेंड कर रहे हैं। That shows the enthusiasm of the participants, and so मैं ज़्यादा ना बोल के बस एक बार पुनः मैं पूरी टीम को जो यहाँ सामने बैठी हुई है और कुछ लोग सामने भी बैठे हुए हैं, ये लोग खड़े हुए हैं, बहुत अच्छा ये रेजिडेंट्स ने आई थिंक दे डिड एक्सलेंट जॉब। मैं हाँ पूरे डिपार्टमेंट ने बहुत अच्छा काम किया। मैं एक कहानी सुना के ख़त्म करना चाहूँगा। जब रेजिडेंट्स की बात आई, नाम आई, तो मैं 2008 में, आप लोगों को शायद कुछ लोगों को याद होगा, 2008 में हम लोगों ने के उस डिपार्टमेंट में नैपकान किया था। उस नैपकान के वैलिडिटी फंक्शन में एक डॉक्टर गुंडू पल्ली थी जो पूरा कॉन्फ्रेंस अटेंड। और गुंडू पल्ली थी कौन? ये थी प्रेसिडेंट एलेक्ट अमेरिकन कॉलेज ऑफ चेस्ट। जो सी इज़ इंडियन, वो अमेरिका में रहती थी, बट सी वॉज प्रेसिडेंट एलेक्ट ऑफ अमेरिकन कॉलेज ऑफ चेस्ट फिजिशियन। व्हाट ही सेड इन द लास्ट, आई ट्राई टू रिपीट हर वर्ड्स। उसने ये कहा कि मैं हिंदी में बता रहा हूँ उसको, उसने तो अंग्रेजी में बोला था, रिकॉर्डेड है अभी भी वो। उन्हें कहा मैंने संसार में बहुत से कॉन्फ्रेंस अटेंड किए, क्योंकि वो इंटरनेशनल वो थी, मैं भी उस वक्त इंटरनेशनल गवर्नर था अमेरिकन कॉलेज ऑफ चेस्ट फिजिशियन का। तो बोले ये जो कॉन्फ्रेंस हमने नैपकान देखी, इट वॉज टोटली मैनेज्ड बाय द पीजी स्टूडेंट्स। ये वो कह के गई, बोले मैंने किसी देश में, अमेरिका में, यूके में कहीं नहीं देखा कि पीजी स्टूडेंट्स, उस नैपकान में 350 प्लस फैकल्टी थी, 3000 लोग अटेंड किए थे। तो उनने कहा कि दे कंडक्टेड ब्यूटिफुली, and I still remember those residents. Now they are all professors, they all, most of them have become DM, most of, वो दिखता है उनके कला को। तो जब आप काम करते हो, खासकर मैं इन लोगों को कह रहा हूँ, रेजिडेंट्स लोगों को, जब काम करते हो उसका बहुत चीज़ें सीखते हो, उसका बहुत रिवार्ड। मैं उन रेजिडेंटों को याद करूँ तो वो सभी इस वक्त प्रोफेसर लेवल पे हैं, और क्योंकि इतना उनमें डेडिकेशन था। और एक बात मुझसे और लोग कहते थे, सर आपकी ये तो 5वीं कॉन्फ्रेंस है, पहले तो आप थोड़े घबराते थे, लेकिन आपकी तो आप बहुत आराम से बैठते हो, क्योंकि ये इतनी भीड़ है, इतने चार हाल चल रहे थे लखनऊ के लिए। उस वक्त 4 हाल चलाना नॉट इजी जॉब। मैंने कहा भाई हमारे बच्चे ये सभी लोग उस वक्त ये लोग तो खैर मतलब फैकल्टी में थे। वेद उस वक्त शायद रेजिडेंट थे। तो कहने का मतलब हमने कहा जब हमारे बच्चों को हमने ट्रेनिंग दे दी, हाँ ये भी पीजी थे, हाँ ये करा पाए, इनकी भी ट्रेनिंग थे, तो तभी इन्होंने कितना लैविश खाना, मैं खाना तो जरा कम ही खाता हूँ, लेकिन मैं गया था इनके लंच पे देखने के लिए खाना कैसा है, क्योंकि हम लोग की ट्रेनिंग है। डिनर हम कल नहीं आ पाए किसी कारण बस, लेकिन हमको टीपी सिंह ने बताया कि साहब बहुत अच्छा डिनर था। सब एक ट्रेनिंग का पार्ट होता है। कैसे ट्रेन, मेंटर, हमेशा हम कहते हैं मेंटर आपका कौन रहा है, कैसे आप ट्रेन हुए हैं। जैसे हम हमेशा, कल हमने अपने लेक्चर में खन्ना साहब की फोटो दिखाई, इसलिए दिखाई कि भाई देखो कैसे मेंटर थे वो, क्या उनका नॉलेज था, क्या उनका इफेक्ट था। तो कहने का मतलब मेंटर तो बहुत अच्छा इन्होंने ऑर्गेनाइज किया। तो वो मुझे गुंटूपल्ली के वो आवाज़ अभी भी याद है। उसने कहा भाई मैंने कहीं नहीं देखा कि क्योंकि मोस्टली क्या होता था उस ज़माने 2008 में भी कॉन्फ्रेंस जो है वो ये जो इवेंट मैनेजमेंट उस वक्त धीमे धीमे आ रहा था। इवेंट मैनेजमेंट इतना ज़्यादा डेवलप नहीं था उस वक्त, लेकिन अमेरिका और यूके में तो खूब डेवलप था। बोले वहाँ तो सारे कॉन्फ्रेंस हैं। हमने कहा, हमने जवाब उनको दिया था, मैडम ये कॉन्फ्रेंस हमारे यहाँ पीजी स्टूडेंट्स को इसलिए भी रखा है, दे हैव ऑल मैनेज द शो, और इनको इसलिए कि इनकी ट्रेनिंग हो, और उस ट्रेनिंग का असर आज हमको दिख रहा, अभी यही नहीं दिख रहा है। उसमें फिर मैं एक रेजिडेंट का नाम लेना चाहूँगा, उसका नाम क्या दो त्रिवेंद्र वाले का सुनीस के साथ किरण विष्णु नारायण, one PG at that time was Kiran Vishnu Narayan. Now he is a DM at current and he is a associate professor in Trivandrum Medical College. अभी जो त्रिवेंद्रम की नैपकान 2 साल पहले हुई थी, तो मैंने उसके वैलिडिक्टी में बोला था, क्योंकि ही वाज को ऑर्गेनाइजिंग सेक्रेटरी। तो मैंने इससे कहा देखो भाई ये वही किरण विष्णु नारायण हैं जिन्होंने नैपकान 2008, ही वाज द आर्किटेक्ट, वो उस वक्त सीनियर था। मैंने कहा इसी ने कराया था सारी ट्रेनिंग। हमें बड़ी खुशी है कि जो हम लोगों ने इन लोगों को ट्रेनिंग दी, नाउ दे आर रिप्लिकेटिंग इट। So with these few words, once again I congratulate all of you for organizing a very wonderful conference, and I hand over mic to.
Thank you, sir, for your blessings. Now I request Dr. T.P. Singh. He is Vice Chairman of UPTBCCON-2022 to give closing remarks.
सबसे पहले तो मैं सब आप लोगों को धन्यवाद देना चाहूँगा कि इस कॉन्फ्रेंस को आप लोगों ने इतना सफल बनाया। ये 20-25 साल से ये यूपी चैप्टर बंद था। इसको शुरू कराने के लिए राजेंद्र शाह साहब ने, कुशवाहा, ये सभी जो बैठे हैं यूपी टीबी एसोसिएशन के एग्जीक्यूटिव मेंबर्स हैं। डॉक्टर साहब तो सीनियर वाइस चेयरपर्सन हैं, डॉक्टर कुशवाहा सेक्रेटरी हैं, डॉक्टर गर्ग, डॉक्टर वेद ये एग्जीक्यूटिव मेंबर्स हैं यूपी टीबी एसोसिएशन के। और इसके पहले जब भी इसका यूपी चैप्टर टीबी एसोसिएशन कराता था, कभी इस तरह की कॉन्फ्रेंस हुई ही नहीं। एक दिन की होती थी, और कैसी होती थी बताना अच्छा नहीं लगेगा मुझे, लगता था जैसे गेट टुगेदर हो रहा हो। ये कॉन्फ्रेंस तो इस तरह से हुई जैसे कि नेशनल लेवल की तमाम फैकल्टीज़ आईं, और सुनने वाले, सुनाने वाले बड़े ध्यान से उसको और बड़े परिश्रम के साथ तैयार करके उसको सुनाया, और सुनने वाले इतने ध्यान से बैठे रहे। मैं तो नैपकान भी देखता हूँ, कभी कभी कोई हाल जो है 10 लोग बैठे रह जाते हैं। और इस सेशन में जबकि केवल धन्यवाद देने का सेशन होता है, उसमें सब लोग उठ के जाना शुरू कर देते हैं। इतने लोग बैठे हैं, आप सभी धन्यवाद के पात्र हैं। और मैं तो बधाई नहीं देना चाहता, मैं इन लोगों का शुक्रगुजार हूँ। उर्दू में कह दूँ कि इन लोगों ने ये कॉन्फ्रेंस इतनी बढ़िया कराई और कई जगह से ये आवाज़ उठने लगी कि अब इसको हर साल हम लोग कराते रहेंगे, और कई लोग तैयार भी हैं। अगली साल देखिए ये लोग कहाँ, डॉक्टर साहब जहाँ बताएंगे वहाँ हम लोग करेंगे। थैंक यू।
Thank you, sir, for your blessings. Now I request Dr. Rajiv Garg, sir. He is scientific chairperson. जितना भी कल से और आज तक पढ़ाई हुई है सब इन्हीं का कंटेंट था। ये अगर ये ना होते तो पता नहीं हम लोग क्या बनाते। ये
ऐसा नहीं है ऐसा नहीं है। हम लोग की एक कोशिश रहती है कि कोई भी कॉन्फ्रेंस हो या CME हो या कोई भी एक हम लोग एकेडमिक इवेंट्स करें तो उसके अंदर एक प्रयास होता है कि कंटेंट अच्छा डालें, स्पीकर्स अच्छे हों। तो वही एक प्रयास था और सर का गाइडेंस था, प्रसाद साहब का, और इनका एक आदेश था कि नहीं ये होना है। तो वी वर दी सिंस, अगर कहा जाए UPTB एसोसिएशन को एक लुटी पिटी और एक मरियल सी एसोसिएशन बोला जाता था, उसके लिए था कि उसको जस्ट रिवाइव करना था। तो इट वाज अ डिफ़िकल्ट टास्क दो, बट इट वाज अकम्प्लिश्ड इन अ सक्सेसफुल मैनर एंड इसके लिए वाकई में डॉक्टर वेद प्रकाश बधाई के पात्र हैं। और इनके साथ इनकी पूरी डिपार्टमेंट की टीम, जो भी इससे पर्दे के पीछे या जो भी काम कर रहे थे, चाहे वो रेजिडेंट हों, इनके DM कलीग्स हों या SR हों या इनके सपोर्ट स्टाफ जो कि डिपार्टमेंट के हैं, वो सब बधाई के पात्र हैं। एंड आई मस्ट कॉन्ग्रेचुलेट। अगर इसमें से बहुत सारी कुछ कमियां रह गई होंगी तो विल डेफिनेटली ट्राई टू इम्प्रूव अपॉन देम। तो कुछ एक टाइम का फैक्टर ज़रूर रहता है, उसको हम लोग मना नहीं कर सकते। यहाँ का कुछ कल्चर ऐसा है कि वी कैन नॉट स्टिक पॉइंट टू पॉइंट, बट वी आर से इम्प्रूविंग ऑन दोज पॉइंट्स ऑल्सो। विल कीप दैट थिंग इन टू कंसिडरेशन इन नियर फ्यूचर।
Thank you, sir. Now I request Dr. R.S. Kushwaha, sir, to give closing remarks.
जैसा कि आपने इन 3 दिनों में देखा कि इतना सुंदर कॉन्फ्रेंस कराई गई जिसका साइंटिफिक कंटेंट किसी भी नेशनल कॉन्फ्रेंस से कम नहीं था, बल्कि मैं तो जज करता हूं कि काफ़ी बढ़िया था, बहुत ही अच्छा था। और इसमें एक उत्साह और पार्टिसिपेशन लगातार डेलीगेट्स का बना रहा और हम सभी ने सीखा। वर्कशॉप आपने देखा, सारी वर्कशॉप इतनी बढ़िया थी, इतनी जो फैकल्टी थी, जो ट्रेनर्स थे, इतने अच्छे थे कि हम लोगों को भी काफ़ी कुछ सीखने को मिला, सबको सीखने को मिला। जो वो प्रोसीजर और वो जो डायग्नोस्टिक्स हम लोग करते थे उसमें भी काफ़ी कुछ हम लोगों ने सीखा, रिसेंट एडवांसमेंट सीखा। जो एडवांस PFT वर्कशॉप थी या आपने उधर ICU वाला पार्ट देखा, सब कुछ बहुत ही एक्सेलेंट हुआ था, सभी ने कुछ नया सीखा है इससे। तो एक तो बहुत ही अच्छी कॉन्फ्रेंस हुई और इसके लिए मैं प्रोफेसर राजेंद्र प्रसाद सर, हमारे पहले हेड सर, पैटर्न या जो भी कहा जाए, हम लोगों के लिए पितामह जैसे हैं, डॉक्टर TP सिंह सर, और ये पूरे UPTB एसोसिएशन की तरफ से मैं डिपार्टमेंट ऑफ पल्मोनरी क्रिटिकल केयर प्रोफेसर वेद प्रकाश और इनके पूरे टीम, पूरे डिपार्टमेंट को मैं बधाई देना चाहूँगा। इतना बढ़िया से ऑर्गेनाइज किया, बल्कि UPTB एसोसिएशन के पार्ट में कुछ ऐसा लग रहा था कि इतना नियर डेट में हो पाएगा कि नहीं हो पाएगा, लेकिन कल्पना जितनी कर सकते थे उससे हज़ारों लाखों गुना बहुत ही अच्छे तरीके से हुआ है, बहुत ही बढ़िया से हुआ है। Everybody has appreciated and everybody is giving feedback that how excellently it has been done. एक चीज़ इस मौके पे मैं अपने जो मीडिया के बंधु हैं उन लोगों ने बहुत ही अच्छा कवरेज किया जो जिस दिन जो प्रेस के लिए प्रेस को एड्रेस किया गया उसके बाद से लगातार बहुत ही अच्छा कवरेज उन्होंने किया है। उसके लिए उनको मैं हृदय से धन्यवाद देना चाहूँगा कि इस कॉन्फ्रेंस में जो डेलिब्रेशंस थे, जो चीज़ें थी, उसको जन जन तक पहुँचाने में आपने इसका अपना एक जो सहयोग किया है, अपना रोल प्ले किया है, उसके लिए आप सभी बड़े धन्यवाद और बधाई के पात्र हैं। और एक बार फिर मैं प्रोफेसर वेद प्रकाश, उनके लीडरशिप, उनके मैनेजमेंट क्वालिटी, उसको मैं फिर से वेद प्रकाश को बधाई देना चाहूँगा। बहुत बहुत धन्यवाद।
थैंक यू सर। इस सक्सेस कॉन्फ्रेंस के पीछे वैसे टीम वर्क होता है, लेकिन जो सबसे ज़्यादा रोल होता है वो एक ऑर्गेनाइजिंग सेक्रेटरी का होता है। इसके बिना ये पॉसिबल ही नहीं था। ये पिछले 15 दिन से दिन रात काम कर रहे हैं और ना खुद सो रहे हैं ना हम लोगों को सोने दे रहे हैं। तो मैं सभी डिग्निटरी से मैं रिक्वेस्ट करूँगा कि वो सर को ऑनर करें एक शॉल और मोमेंटो द्वारा। Thank you, sir. So now this is time to announce results of oral and e-poster of papers. So first oral presentation of papers. First I start from 3 and go to 1. So third is Dr. Manoj Kumar Pipal from SN Medical College, Agra. So third prize goes to Dr. Manoj Kumar Pipal for his oral presentation yesterday. Second prize goes to Dr. Kirtish from Jabalpur. And first goes to Dr. Shalini Lovyal from Institute of Medical Science, BHU, Varanasi. Is she here? Okay. So now e-poster. E-poster, third prize goes to Dr. Darvesh Rabbani. Please. Is here. Dr. Darvesh Rabbani is here. Second goes to Dr. Shivam Gupta. He is PDCC student in our department. And first prize goes to Dr. Maksumi Reza. She is intervention pulmonologist and doing PDCC in Department of Pulmonary Critical Care Medicine in our department. So, congratulations. इस कॉन्फ्रेंस में जो ऑर्गेनाइजिंग टीम है वो पिछले 15 दिन से दिन रात काम कर रही है। कुछ ऑफ द स्टेज, कुछ ऑन द स्टेज। जो ऑफ द स्टेज है, जो दिखाई नहीं दे रहे हैं, मैं उनको एक बार अनाउंस करके उनको बुलाना चाह रहा हूँ ताकि उनको भी हम लोग ऑनर कर सकें। फर्स्ट डॉक्टर सचिन कुमार, ही इज़ को ऑर्गेनाइजिंग सेक्रेटरी ऑफ UPTBCCON 2022। डॉक्टर मोहम्मद आरिफ, he is my colleague, Dr. Mohammad Arif. कोई बात नहीं। डॉक्टर अनुराग, डॉक्टर मृत्युंजय, अब मैं बुलाना चाहता हूं कि जब उन लोगों को जो नीचे काम कर रहे थे, हम लोग UPTBCCON में काम कर रहे थे तो पूरा ICU और डिपार्टमेंट संभाले हुए थे, एक भी मरीज को नुकसान नहीं हुआ। तो अवर सिस्टर इंचार्ज मिसेस निर्मला देवी है यहाँ पे, आइए सिस्टर जी। दूसरी सुशीला वर्मा सिस्टर जी, सिस्टर मर्सी, ये लोग वो लोग थे जो पेशेंट्स को संभाले हुए थे। अब मैं उन लोगों को बुलाऊंगा जिनका कहीं भी नाम नहीं है लेकिन वो दिन रात लगे हुए हैं। राजन यादव जी, इनको जो काम सौंपा गया था वो हम लोगों के बस के बात नहीं थी। मिस्टर प्रवीण गोस्वामी जी, प्रभात है यहाँ पे, जीतू पटेल, सुधीर, अनवर, ये लोग वो लोग हैं जो पूरा ऑफिस संभाले हुए थे, पूरा कॉन्फ्रेंस सेक्रेटरीट संभाले हुए थे ये लोग। जाइए अब ये जमा कर दीजिए। है तो उसके बाद उसको
Now it is my privilege to announce the name of my colleague and my senior, Hemant Boss. He has worked tirelessly for this event. A big round of applause, please. Now I request the organizing secretary, Dr. Ved Prakash sir, to kindly give the vote of thanks and formally end the UPTBCCON 2022.
Thank you, Arif. जैसा कि सभी ने बता दिया है पहले ही, मैं ज़्यादा समय नहीं लूँगा, लेकिन ये कस्टमरी है तो इसको भी निभाना है हम लोगों को। जब इसका प्लान हो रहा था, आपको शायद सब लोगों को नहीं पता होगा कि UPTB एसोसिएशन की जो सभापति हैं वो माननीय राज्यपाल आनंदीबेन पटेल जी हैं, और टीबी के लिए उनका जो लगाव है, टीबी के रोगियों से, टीबी मुक्त भारत अभियान को किस तरह से गति देना है, ये हम लोग उनसे सीख रहे हैं, उनको देख रहे हैं काम करते हुए। जब प्रदेश में पहला नागरिक अंतिम जो टीबी का मरीज है उसका हाथ पकड़ के हैंड होल्डिंग करने की तरफ आगे बढ़े, तो आप समझ सकते हैं कि जो लोग टीबी को एक कलंक की तरह से मानते रहे, एक स्टिग्मा सोसाइटी में परसिस्ट करता रहा, अभी भी करता है शायद कहीं कहीं, लेकिन इसमें उनकी कोई गलती तो है नहीं मरीजों की। और जब माननीय राज्यपाल जी ने इस तरह का एक वात्सल्य भाव उनके लिए रखा, तो मुझे लगता है कि आज जो केस फाइंडिंग में जो वृद्धि हुई है वो हम सब लोग देख सकते हैं। इसके लिए तो मैं सबसे पहले माननीय राज्यपाल जी को पूरी टीम की तरफ से, ऑर्गेनाइजिंग टीम की तरफ से उनको बधाई और धन्यवाद देता हूँ। माननीय मुख्यमंत्री योगी आदित्यनाथ जी, जिन्होंने लगातार प्रोत्साहन भी दिया और जो कमिटमेंट था, आप देखेंगे कि जब शुरुआत हुई माननीय राज्यपाल जी की तरफ से, और माननीय प्रधानमंत्री जी का जो सपना था 2025 में टीबी मुक्त भारत का, अब मुझे लगता है कि 130 करोड़ देशवासी इस सपने को देखने लगे हैं और वो दिन दूर नहीं हैं जब हम लोग, ऐसा नहीं है कि हम ही सच्चाई जानते हैं, हमसे ज़्यादा सच्चाई शायद जो डिसीजन मेकर्स हैं सरकार में वो भी जानते हैं। 2030 का ग्लोबल टारगेट सब लोग जानते हैं कि WHO ने रखा है टीबी मुक्ति का भारत से 2025 में 5 साल एडवांस करने का शायद कुछ मकसद होगा। ये हम लोग और आगे जानेंगे कि किस तरह से पोलियो अभियान को गति जब मिली तो देखा होगा कि हम लोगों ने कई बार उसको रिपीट करना पड़ा पूरे प्रोग्राम को, तो शायद ऐसी नौबत आगे भी आएगी। लेकिन एक जो सपना कोविड के बीच में हम सब ने देखा है, आप सब इसके साक्षी रहे हैं, बहुत ख़राब दौर हम सब ने देखा है, और 130 करोड़ देशवासियों ने एक नई छवि 21वीं सदी का भारत कैसा होगा, सशक्त भारत किस प्रकार का होगा, ऐसी छवि पेश करने का काम कोविड में किया। जब ऐसी परिस्थितियों में जब हजारों हजार लाखों लाख लोग विस्थापित मजदूर जब चले, तो ये शायद हमारा देश इकलौता होगा कि जिनके घर में 5 लोगों का खाना बनता था उन्होंने 10 लोगों का बनाया, जहाँ 10 का बनता था उन्होंने 20 लोगों का खाना बनाया, किसी को भूखा नहीं रहने दिया। इतनी बड़ी त्रासदी को जब दुनिया ये सोचती थी कि करोड़ों मौतें शायद हिंदुस्तान में हो जाएंगी, आज हिंदुस्तान का मॉडल, खास करके उत्तर प्रदेश का मॉडल, इसकी चर्चा अमेरिका की संसद में भी हुई और हमारी जो ब्रिटेन की संसद है वहाँ तक चर्चा हुई। उत्तर प्रदेश का जो कोविड कंट्रोल का भी मॉडल रहा, उसमें भी काम करने का अवसर मिला। माननीय मुख्यमंत्री जी ने सलाहकार की भूमिका में भी रखा, हम लोगों को OSD की भूमिका में भी रखा। जहाँ जहाँ कोशिश हुई, तो मुझे लगता है कि इसी तरह का प्रयास यदि ये पूरी टीम, पूरे 130 करोड़ देशवासी अगर इसमें सहयोग देंगे, तो मुझे लगता है कि जो 2025 में जो सपना माननीय प्रधानमंत्री का है, इसको शायद हम लोग कहीं तक पूरा करने की तरफ आगे बढ़ सकेंगे। तो मैं उनको भी धन्यवाद देता हूँ, माननीय योगी आदित्यनाथ जी, जिन्होंने लगातार इसमें सहयोग रखा है। कल हमारे बीच में माननीय उप मुख्यमंत्री जी जो सरकार की तरफ से उपस्थित थे, और माननीय राज्यपाल जी ने, जबकि पूरी कमेटी इस बात को जानती है कि माननीय राज्यपाल जी ने कहा कि मैं नहीं आ सकूंगी, कहीं व्यस्तता है, तो आप या तो मुख्यमंत्री जी को ले लीजिए या फिर उप मुख्यमंत्री जी जो विभाग देख रहे हैं उनको। और हमारे अनुरोध को उन्होंने बहुत कम एक शॉर्ट नोटिस पर स्वीकार किया और वो हमारे बीच में उपस्थित हुए, उत्साहवर्धन किया पूरी टीम का। मैं इसके लिए माननीय उप मुख्यमंत्री उत्तर प्रदेश सरकार श्री ब्रजेश पाठक जी का हृदय से बधाई और धन्यवाद देता हूँ कि उन्होंने सबका मार्गदर्शन करते हुए सबका उत्साह बढ़ाने का काम किया है, और इस सफलता में उनका नाम लेना बहुत आवश्यक है। हमारे जो चेयरमैन हैं वो इतने भले अधिकारी हैं, मुझे लगता है कि IAS अधिकारी और IPS अधिकारी काफ़ी हैं हमारी लिस्ट में, उनको काफ़ी फैमिलियर भी हूँ, लेकिन ऐसा IAS अधिकारी शायद हम लोगों ने कहीं नहीं देखा होगा। मैं राजेंद्र प्रसाद सर इस बात का वो भी कर देंगे कि इतने सीधे, इतने भले IAS अधिकारी शायद ही कहीं होंगे जो देश की राज्यसभा के सचिव रहने के बाद भी आज लगातार कई वर्षों से UPTB एसोसिएशन के चेयरपर्सन हैं, चेयरमैन हैं। और उनको बड़ी घबराहट थी शुरुआत में जब ये तय हो रहा था, लेकिन उनको भरोसा दिलाने का हमारे तो शायद बस की बात थी नहीं, क्योंकि हम तो नौसिखिए वाले ही हैं अभी भी। लेकिन राजेंद्र प्रसाद सर ने शायद उनको भरोसा दे के, उनको TP सिंह साहब ने, उन दोनों लोगों ने उनको तैयार किया और उनको बनाए रखा। कल हमारे बीच में यहाँ मौजूद थे, मैं उनको धन्यवाद देना चाहता हूँ कि उन्होंने लगातार हम लोगों को मार्गदर्शन भी दिया और पीछे एक दीवार की तरह से हम सब के पीछे खड़े रहे। हमारे वरिष्ठ उपाध्यक्ष जो हमारे टीचर भी हैं, हमारे मैं कहूँ कि जिनको फादर ऑफ पल्मोनरी मेडिसिन भी कहते हैं उत्तर प्रदेश में, जिन्होंने TB डिपार्टमेंट से जो आज जो पल्मोनरी मेडिसिन तक और पल्मोनरी एंड क्रिटिकल केयर मेडिसिन तक का जो सफ़र उत्तर प्रदेश ने देखा है, तो मुझे लगता है ऐसे हैं हमारे राजेंद्र प्रसाद सर, जिनको मैं बहुत बहुत धन्यवाद देना चाहता हूं इस अवसर पर। उन्होंने BC रॉय अवार्डी हैं और नेशनल टास्क फोर्स जो हमारी है इन्वॉल्वमेंट ऑफ मेडिकल कॉलेजेस इनटू द प्रोग्राम, उसके आप वाइस चेयर भी हैं। मैं आपको बहुत बहुत धन्यवाद देता हूं सर कि हमेशा ही आपकी प्रेजेंस हम लोगों के लिए एक ऊर्जा का काम भी करती है और साथ ही साथ वैलिडेट भी करती है। मैं कई बार मजाक में उनसे कहा भी कि सर ये आप यहाँ नहीं रहते हैं तो ऐसा लगता है कि यंगस्टर्स की बारात है। मैं कहा उसमें लास्ट में जो जन्माशा होता है उसमें एक बुजुर्ग का रहना ज़रूरी होता है। मैंने कहा सर आप जाया मत करिए, आपकी चाय वगैरह जो भी हम यहीं ला देंगे, तो आप न जाया करें सर। तो उनको बहुत मुश्किल से पूरी टीम ने बांध के रखा हुआ है, उन्हें निकलने नहीं देते हैं, इधर सब लग जाते हैं। तो ऐसे हमारे कुशवाहा सर, राजीव गर्ग सर मेरे टीचर हैं दोनों, और TP सिंह साहब की जो भूमिका है उसकी जितनी प्रशंसा हम लोग कर सकते हैं शायद कम होगी, कि उन्होंने पूरी एसोसिएशन की तरफ से जितनी भी आवश्यकताएं थीं, जब हमें ज़रूरत पड़ी, कई बार हमारे लोग मीटिंग में नहीं आते थे, लेकिन TP सिंह साहब नीचे से फ़ोन आता था कि मैं पार्टनर में आ गया हूँ नीचे। मैं कहा सर आप, हम लोग तो मैनेजमेंट की मीटिंग कर रहे हैं, कर लेंगे, साइंटिफिक का है कि नहीं भाई आपने अब ग्रुप पर डाला है तो भाई आना ही है। तो मुझे लगता है कि शायद कोई मीटिंग मिस की होगी, उन्होंने लगातार हमारे बीच में रहे हैं और महीनों से जो रात दिन काम चला, जो हमारी टीम जो बैक स्टेज टीम थी लगातार काम कर रही थी, तो सब ने इस बात के साक्षी हैं कि TP सिंह साहब ने लगातार हमारे बीच में रह करके इसमें पूरा मार्गदर्शन, पूरा सहयोग और ढांढस बनाने का काम जो लगातार किया है। सर मैं आपको बहुत बहुत धन्यवाद देता हूँ, इसके लिए बधाई देता हूँ आपको कि ये जो पूरा सफलता है इसमें एक बड़ी भूमिका में आप रहे हैं। हमारे प्रोफेसर RS कुशवाहा सर, वो ऐसे हैं, हम लोग अपनी रेजिडेंसी के समय से जानते हैं कि जब भी कोई समस्या आती है तो रेजिडेंसी में थे तब भी उनके पास हम लोग पहुंच जाया करते थे। हमें पता था कि चाहे समस्या सॉल्व हो ना हो, लेकिन उनसे एक उत्साह जरूर बढ़ जाएगा हम लोगों का उनके पास जाने से। इसी भूमिका को लगातार निर्वहन करते हुए आज मुझे लगता है कि हमारा जो एसोसिएशन है आपस में, उसको 18-19 साल हो गया है, लेकिन उनकी भूमिका लगातार ऐसी ही बनी हुई है हमारे साथ में, वो कभी बदली नहीं है। तो सर मैं आपको बहुत बहुत धन्यवाद देता हूँ कि जिस तरह से आपने इस आयोजन में हम लोगों के लिए मदद की, सहयोग किया है। और देखिए बिना पैसे के कोई काम नहीं होता है, तो पैसे का जो लेन देन हिसाब किताब है वो भी इन्हीं के जिम्मे है। तो इसीलिए उनको भी थोड़ा मैं मक्खन इसलिए नहीं लगा रहा हूँ कि अभी उनसे साइन होने चेक सारे। तो कुशवाहा सर हमारे इसके भी इंचार्ज वही हैं, तो जो पैसा वैसा इनको ये सब मुझे पकड़ते हैं। जो मैंने कहा भाई अगर कम पड़ेगा तो आप मुझे पकड़ोगे, लेकिन कुशवाहा साहब को मत छोड़ना, क्योंकि अगर दिवालिया निकलेगा तो हम लोगों को इकट्ठा निकलना चाहिए सबका। बोले आप लोगों ने इतनी बड़ी करा दी। अब चेयरमैन साहब भी कल घबरा गए, वही लग रहा है बहुत खर्चा कर दिया। तो जितना भी है मैं इनको भी बता रहा हूँ, ये भी सुन लें कि भैया कुर्ता जो है उनका भी पकड़ा जाएगा साथ साथ। तो कुशवाहा सर आप हमेशा हैं, मुझे लगता है कि मैं आपके बिना ये संभव नहीं था। मैं बहुत बहुत धन्यवाद देता हूँ आपको पूरी टीम की तरफ से कि आपने लगातार उस बात को हम लोगों के साथ में उसको पूरा किया है। डॉक्टर राजीव गर्ग साहब, हम लोग कल परसों से सब लोग कह रहे थे कि भाई ये क्वालिटी एश्योरेंस का मामला क्या है। जब भी मैंने कहा कि सर क्वालिटी कंट्रोल है, हर बार मैं उनसे पूछता था कि सर क्वालिटी कंट्रोल है, तो हर बार मुझे ये जवाब देते थे कि हाँ बिल्कुल कंट्रोल है, ठीक चल रहा है। तो जितना क्वालिटी कंटेंट है या जितना भी आप देखेंगे साइंटिफिक कंटेंट, उसके लिए जो आपने देखा राजीव गर्ग सर हमारे ऐसे गाइड रहे हैं हमेशा से ही कि जब साइंटिफिक कंटेंट और रिसर्च की बात जब आती है तो हम लोग उन्हीं को खोजते हैं, उन्हीं के पास जाते हैं। तो धन्यवाद सर, आप हमारे साथ लगातार रहे हैं और इस जर्नी में भी आपने रात और दिन हम लोगों की मदद की। मैं आपको बहुत बहुत धन्यवाद देता हूँ। हमारी टीम के कुछ ऐसे लोग हैं जिन्होंने रात और दिन, देखिए अभी लास्ट के दिन तो मैं भी रिलैक्स होकर बैठ गया उधर। प्रसाद सर कह रहे थे कि भैया ये तो पहली कॉन्फ्रेंस में तुम रिलैक्स हो गए, हम तो 5वीं में हुए। तो मुझे लगने लगा लास्ट के दिन तक कि भाई जो टीम है, आप सबने देखा है, और पीजीज को क्यों मौका दिया ये भी उन्होंने बता दिया कि इवेंट मैनेजमेंट वाले तो बहुत लोग हैं, पैसा भी बहुत मांग रहे थे, लेकिन सर इन्होंने, मैं आपको अलग से बताऊंगा कितना पैसा बचाने का काम इस टीम ने किया है। आपका इस टीम को बधाई देता हूं, धन्यवाद देता हूं। हमारे जो असिस्टेंट प्रोफेसर के लिए अभी चयनित हुए हैं डॉक्टर सचिन, एमडी मेडिसिन उन्होंने यहीं से किया है, मेरे साथ 3 साल तक काम किया, आज हमारे साथ में हैं। उन्होंने रात और दिन, जब भी हमने कहा होगा, कल डिप्टी सीएम साहब का फ़ोन आया कि डॉक्टर साहब वो प्रेस रिलीज़ भेज दीजिए। मैंने कहा सर हम तो भेज देंगे यहीं से। कह रहे यार बहुत अच्छा कार्यक्रम आपने करा दिया, हम भी उसको भेज देते हैं, हमारे यहाँ से भी जाएगी, आप भेज दो हमें जल्दी। तो मैं इनको लगाया इस काम पे कि भैया सब काम छोड़ो, प्रेस रिलीज़ थोड़ा जल्दी दे दो। तो प्रेस रिलीज़ को जितनी जल्दी तैयार करने का काम किया, वो सारा काम सचिन, और जितने भी कंटेंट, जब भी किसी का भाषण लिखने के लिए हमने कहा तो उन्हीं को लगाया, तो उन्होंने लगातार सबके, चाहे डिप्टी सीएम साहब का, बीसी साहब का, और अन्य लोगों का भाषण भी लिखा। तो इसके लिए मैं बहुत बहुत धन्यवाद देता हूँ। अभी यंगस्टर हैं हमारे ये, तो आगे काफ़ी लंबा रास्ता इनको तय करना है, इनको भी धन्यवाद देता हूँ। हमारी जो टीम है डीएम का, जब शुरुआत हुई तो लोहिया संस्थान में इनको काम करते हुए थोड़ा समय तो कम हुआ था। उनकी जो नियमावली है कि छुट्टी मिलने का एक समय होता है कि भाई कितने साल में मिल सकती है छुट्टी, स्टडी लीव, और उनको छुट्टी नहीं दे रहे थे लोग जब डीएम में सेलेक्ट हो गए हमारे यहाँ। और हेड ऑफ डिपार्टमेंट इकलौता आदमी वहाँ पे, तो मेरे पास आए, तो मैंने जो हमारे अपर मुख्य सचिव साहब हैं उनसे अनुरोध किया, मैंने कहा साहब वो छोड़ देगा नौकरी आपकी, लौट के जाएगा नहीं, डीएम करने आ रहा है, तो आप छुट्टी दे दीजिए। तो उन्होंने कहा कि भाई आप धमका रहे हैं आपके, तो मैंने कहा सर ये सच्चाई है, वो कह रहा था मैं छोड़ दूंगा। तो मैं ये चाहता हूँ कि हेमंत तुम छोड़ो नहीं, पकड़े रहो, लगातार हम सब तुम्हारे साथ हैं। और जिस तरह से उसने इस नेतृत्व किया है टीम का, वो काबिल तारीफ़ है। मैं तो सारी वरीज उसी को दे करके आराम से बैठ गया। डॉक्टर आरिफ जो एएमयू से हमारे बीच में हैं, वहीं से एमबीबीएस एमडी करने के बाद में पहले कैंडिडेट हमारे डीएम के, उन्होंने जिस तरह का उर्दू जवां का भी बीच बीच में मिक्स उपयोग काफ़ी किया है, तो मैं धन्यवाद देता हूं कि उन्होंने बड़ा अच्छा कैंपेनिंग की। यहाँ पे हमें भरोसा नहीं हो रहा था, हमने कहा भाई कई लोग हमारी यूनिवर्सिटी में हैं, शेर व शायरी अच्छी करते हैं, उन लोगों को हम रख लेते हैं, डिप्टी सीएम का कार्यक्रम है। तो उन्होंने कहा कि हेमंत जी ने कि नहीं सर ये कर लेंगे। मैंने कहा अच्छा। तो भरोसा तो हो नहीं रहा था, लेकिन हमें लग रहा है अब ये भरोसा भी जम गया है आगे के लिए। तो मैं धन्यवाद देता हूँ हमारे अन्य जो साथी हैं जिन्होंने लगातार काम किया है। फर्स्ट ईयर डीएम बैच डॉक्टर मृत्युंजय, इनका एक हुनर और सामने आ गया कि गाना भी बहुत अच्छा गाते हैं। अब ये भी हमें लग रहा है सॉल्व हो गया कि अगले साल से म्यूजिक का जो खर्चा है शायद उसमें भी कटौती कर पाएंगे सर हम लोग। तो अगली जो कॉन्फ्रेंसेज हैं उसमें ये इंतजाम भी हो गया है। एक अनुराग त्रिपाठी जी हैं, अब शिमला से आए हैं, उनके हेड साहब डॉक्टर मलय सरकार जी कल बहुत मुश्किल से पहुँचे, तो आते आते हाँफने लगे। मैंने कहा सर अभी आपके समय है सेशन में। क्या अरे डॉक्टर वेद मैं तो कंफ्यूज हो गया कि कैसे किधर से जाऊं, ये तो पूरा भूल भुलैया है। मैंने कहा सर भूल भुलैया ये नहीं है, जो हमारा चेस्ट वाला विभाग पुराना है उसकी बगल में है। तो मैंने उनसे कहा अनुराग से कि भाई कम से कम डॉक्टर साहब को घुमा देना लखनऊ में, कि भूल भुलैया KGMU को ही समझ लिया उन्होंने, वो सही मायने में उधर है जो हमारे नवाबों ने कारनामे पहले किए हैं, तो उधर भूल भुलैया हम पता नहीं उन्होंने क्या क्या किया होगा। तो मैंने कहा दिखा जरूर देना उनको। तो आप देखेंगे कि जो टीम के हमारे सदस्य हैं जो हमारे बैक स्टेज जितने भी हमारे जिनके नाम में सबके ले पाना मुश्किल है सर, टीम बहुत लंबी है क्योंकि विभाग में 248 सीटें हैं, 33 रेजिडेंट की सीट है, 9 फैकल्टी पोजीशंस हैं। तो विभाग तो सर ये सबसे बड़ा हो गया देश में कि नहीं हो गया। वेंटिलेटर की संख्या भी, वेंटिलेटर बेड की 45 है, इतनी संख्या शायद देश में किसी आईसीयू में नहीं है। तो ये लोग कहते हैं कि भाई आप 7 साल से छुट्टी नहीं लेते हैं, और ये सब जानते हैं कि मेरी CL 14 में से शायद 12, 11 या 13 लैप्स कर जाती हैं हर साल, और 7 साल से ये क्रम लगातार चल रहा है। हम लोगों ने कोई त्यौहार शायद मथुरा में घर पे मनाया होगा जब से विभाग खोला है। आप तो सर ये सपना देख के आप निकल लिए, हम लोगों को फंसा दिया आपने। राजेंद्र प्रसाद सर जब हम लोग रेजिडेंट थे तो सपना देखा करते थे कि भाई पल्मोनरी मेडिसिन में DM चलना चाहिए। सर आपको हम ही फंसाना था यहाँ। 7 साल से छुट्टी लेने का मौका नहीं मिला। अब ये सचिन आ गए हैं, हम सर से ही निवेदन कर रहे थे कि एक आध आदमी हमको अच्छा दिलवा दीजिए जिससे कि हमारा काम हल्का हो जाए। अब एक तो मिल गए सर, 1-2 इंतजाम और कर दीजिए। सबके सामने आपसे यही हम तो अनुरोध करेंगे कि हमें थोड़ा हल्का करिए, नहीं तो BP बढ़ गया है सर अब। तो मैं पूरी टीम को बहुत बहुत धन्यवाद देता हूँ, बधाई देता हूँ। हमारे नर्सिंग स्टाफ, हमारे ऑफिस के स्टाफ, हमारे राजन जी हैं, जितनी भी फ्लाइट आई हैं वो हमें पता ही नहीं है, वो अब बताएंगे, पता नहीं कितना बिल बताएंगे साथ में। तो इन्होंने सारी फ्लाइट मैनेजमेंट, जितना होटल्स के मैनेजमेंट, सारा सिंगल हैंडेडली संभालने वाले राजन यादव। ये नेता तो बड़े हैं लेकिन मैनेजर भी बड़े हैं, ये हम लोगों ने पिछले कई दिनों में देखा है। हमारे एक हैं जिनके लिए ये सब लोग ये कहते हैं कि भाई आपसे कुछ उनका मतलब जुगाड़ है, ये आ जाओ आप ऊपर। बोले साहब वो कुछ करते नहीं है लेकिन आप उनके खिलाफ सुनते नहीं हैं कुछ भी। मैं कहा भाई देखो ऐसा है कि ये ऐसे ही चलता है। सरकारी नौकरी में मैंने कहा लगाना मुश्किल तो आसान है लेकिन निकालना बड़ा मुश्किल होता है। तो मैंने कहा देखो निकाल पाओगे नहीं। अब ट्रांसफ़र हम करा दें तो ये BC ऑफिस और रजिस्ट्रार वाले हमसे इतने खुश नहीं हैं कि दूसरा आदमी दे दें। मैंने कहा भाई कुछ नहीं कर रहा है तो कुछ तो करेंगे। अब सर ये तो आगे पता चलेगा। तो हमने नहीं बदला है सर, पूछ लीजिए। हर बार इनके लिए सब लोग ये कहते हैं कि साहब इनको यहाँ से अब कहीं और भेज दीजिए जहाँ पे थोड़ी कसरत वाला विभाग हो, इनका वजन बढ़ गया है, इनका ही नुकसान हो रहा है। मैं कोई बात नहीं, वो उस कसरत करेंगे भाई यहीं, लेकिन कुछ नहीं से कुछ अच्छा है। तो अब कल सब वो आए मेरे पास कि चिकन सर नहीं दिख रहा है इसमें। मैं कहा भाई वो चिकन वाले को बुलाओ। तो उसमें फिश और वो तो सब भरा पड़ा था साइड में। मैंने कहा नॉनवेज खाते तो ये भी तो खाते होगे, ये टेस्ट करो जब तक। कि सर नहीं। तो उससे मैंने कहा भाई एक भगोना ज़रा इसमें लगाओ जल्दी। तो उसने दिया तो देखा थोड़ी देर बाद कि जितने लेग पीस उसमें थे सारे छांट के उन्होंने अपने उसमें कर लिए। तो ऐसे खाने पीने वाले आदमी सर आपको बहुत कम मिलेंगे, और मैं इनसे सबसे कहता हूं कि आपका मनोरंजन इन्हीं से होगा। जब स्ट्रेस में आओगे तो प्रवीण गोस्वामी जी हमारे लिए इस धन्यवाद के पात्र इसलिए भी हैं कि किसी को स्ट्रेस में नहीं आने देंगे। मैंने कहा हमारे पास पहले से होते तो शायद हमारा BP नहीं बढ़ता। तो उनको भी मैं धन्यवाद देता हूं। हमारी जो टीम है, बाकी ऑफिस के स्टाफ, हमारे 248 जो सीटें हैं, सिस्टर इंचार्जेज को भाई टोकन दे के आपने कर दिया अप्रिशिएट। लेकिन बहुत सारे स्टाफ हैं, बहुत सारे हमारे 4th क्लास कर्मी हैं, हमारे जितने भी लोग हैं A to Z, में नाम सबका नहीं ले पाऊँगा तो माफ़ करें भाई, सबका नाम नहीं हो पाता है। तो मैं सबको धन्यवाद देता हूँ, सबको बधाई देता हूँ कि आज ये सक्सेस हो गई है। अब मुझे पता नहीं कितनी सक्सेस हुई है, लेकिन ये डुअल मोड वाले हैं, ये पता नहीं कहाँ कहाँ दिखा रहे हैं इस चीज़ को। 5000 लिंक इन्होंने बांटा हुआ है देश भर में, 5000 लोगों को लिंक दिया हुआ है। तो जो आपकी बातें यहाँ से शायद पूरे देश में कौन सुन रहा होगा कोई पता नहीं, इसीलिए हम सत्य बोल रहे हैं सर, इसमें कहीं कोई गड़बड़ नहीं है। ये प्रवीण जी के लिए एकदम सही बात कही है। तो पूरे देश भर में लिंक और जिस तरह का एक फीडबैक आ रहा है, बहुत अच्छा आ रहा है कॉन्फ्रेंस के लिए। अब मैं तो यहाँ भी सुन लिया पूरा सबका, लेकिन सर आप उस समय न निकल जाइएगा जब इसका खर्चा निकल के आएगा पूरा, कि भैया इन्हीं को धन्यवाद दे दिया है, इन्हीं को बधाई दे दी है, अब इन्हीं को पकड़ो। तो दिवाला निकले तो इकट्ठा ही निकले, और जिन पे ज़्यादा है उन पे से हम ज़्यादा लेंगे, जितने बैठे हुए हैं यहाँ पे सब। तो ज़्यादा नहीं कहूँगा, लेकिन आप देखिए, चाहे हमारा बीपी बढ़ गया हो, चाहे कुछ हो, सबसे ज़्यादा जो सेक्रीफाइस है, जो नुकसान है, वो बच्चों का, घर का, परिवार का होता है। जो हमारे साथी हैं, जिनके साथ हम लोगों को ज़्यादा समय देना चाहिए, उनको शायद हम इस दौड़ भाग में भूल जाते हैं, वहाँ नहीं दे पाते हैं कई बार। तो किसी इस सब के पीछे, क्योंकि मैं राजेंद्र प्रसाद सर जब वैलिडिक्टरी में पिछली बार बोले कन्वेंशन सेंटर में, तो उन्होंने सही कहा था। अब इसका एहसास मुझे हुआ है कि वो सारा सेक्रीफाइस है, वो घर परिवार के बच्चे, माँ बाप, पत्नी, जितने भी लोग हैं और आपसे एसोसिएटेड, उन सब का होता है। तो मैं अब क्या कहूँ, अब यहीं पे बैठे हैं तो खुश तो होंगे ही, क्यों इतनी तारीफ हो रही है तो खुश तो होंगे ही सर। आपने खुश तो कर दिया उनको सर। सर ये आप हमारे लिए कह रहे हैं कि अपने घर का इंतजाम कर रहे हैं कि भाई हम सभी का करते हैं, हमारे मन में ये भाव है। जैसा आप कहें, हम तो कह नहीं सकते इसमें ज़्यादा कुछ। मैं सबका बहुत बहुत धन्यवाद देता हूँ। सब लोगों ने, जितने भी डेलीगेट्स हैं, जितने भी फैकल्टी हैं, हमारे पद्म श्री डॉक्टर डी बेहरा सर, जो आईसीयू के जो क्रिटिकल केयर वर्कशॉप हुआ, बहुत अच्छी रेटिंग आई उसकी, उसके डायरेक्टर थे, हमारे बीच में थे। डॉक्टर संदीप सालवी जो पुणे से आए, दीसा घोरपड़े, उनके साथ में पूरी टीम के साथ लग करके उन्होंने एडवांस एंड जो बेसिक पल्मोनरी फंक्शन टेस्ट के वर्कशॉप हैं उनको बहुत अच्छे से किया, बहुत अच्छी रेटिंग है। और डॉक्टर दीप्ति गोठी एंड टीम, जिन्होंने स्लीप मेडिसिन के वर्कशॉप को बहुत अच्छे से कंडक्ट किया। तमाम सारे हमारे बड़े नाम, कुलदीप सिंह सचदेवा साहब को कल आप सुन रहे थे, डॉक्टर सरीन, डॉक्टर बीरेन सिंह जयपुर से, डॉक्टर वीके जैन साहब, मुझे लग रहा है कि प्रसाद सर के सीनियर शायद अब ज़्यादा लोग नहीं, वही शायद कुछ ही लोग हैं। तो डॉक्टर वीके जैन साहब को हमने पकड़ा कल, ये तो निकल गए कहीं प्रसाद सर, तो मैं कहा चलो उनके सीनियर हैं, इनको रखें साथ, तो उनके साथ फ़ोटो करवाए, फिर उन्हीं के हाथ से सबको दिलवाया। तो ऐसे हमारे जितने भी लोग हैं, नदीम जी बैठे हैं, उनके अब मैं क्या कहूँ, सब लोगों ने पूरा माहौल को संभाल के रखा। प्रसाद सर की जो कमी थी उसको उनके ऊपर वाले और नीचे वालों ने पूरा किया। मैं आप सभी का धन्यवाद देता हूँ, जितने फैकल्टी हैं, जितने डेलीगेट्स हैं, जितने भी प्रत्यक्ष रूप से, परोक्ष रूप से जिन्होंने साथ दिया है, सबका धन्यवाद देता हूँ। हमारे जो सबका नाम लेना संभव नहीं है, लेकिन फार्मा इंडस्ट्री, जितने भी हमारे इक्विपमेंट इंडस्ट्री के लोग हैं मेडिकल की, उन सबको धन्यवाद देता हूँ। उन लोगों ने जो हमें सपोर्ट किया है। हमारे बैक स्टेज मैनेजमेंट, कपूर स्टूडियो, इन्होंने बहुत काम किया है, उनको धन्यवाद देता हूँ। जितने हमारे, इस बार उन्होंने कहा कि सर ये दूसरी स्क्रीन लगवा लीजिए। आप इस स्क्रीन के पीछे देखेंगे एक स्क्रीन लगा हुआ है ऑलरेडी हमारा फिक्स। उन्होंने कहा सर ऐसा ना हो कि कहीं उसका तार हिल जाए और वो हो जाए। मैंने कहा आपकी का तार हिल गया तो शायद या तो उन्होंने अपना लगाने को कहा होगा, किराया ज़्यादा हो जाएगा, चाहे जो भी हो, ये इतनी बड़ी स्क्रीन एक और लगा दिया आगे। मैं कहा हम उस पर काम चला लेंगे कि सर इसका पिक्सल बहुत अच्छा है। मैं कहा चलो बढ़िया बढ़िया सेलर हैं। तो मैं आपको धन्यवाद देता हूं कि इस बार कहीं कोई गड़बड़ी नहीं हुई है, अनइंटरप्टेड चले हैं सेशंस सारे, और लगातार जो रिले हुआ है इसकी क्वालिटी बहुत अच्छी है। जितना भी ऑनलाइन रिले हुआ है, ऑनलाइन एक्सेस में लोगों ने काफ़ी, अमेरिका में मेरे एक साथी हैं, उन्होंने बड़ी प्रशंसा की कि भाई बहुत अच्छा कार्यक्रम कराया। मैंने कहा आपने देखा क्या? कि हाँ आपकी लिंक मिली थी तो देख ले थोड़ा सा, तो बहुत अच्छी क्वालिटी। मैंने कहा ठीक था कि भाई अब तो एट पार लग रहा है, हम तो सोच रहे थे अमेरिका में कॉन्फ्रेंस हो रही है। तो ये जो सिस्टम्स हैं सबको अपडेट करने के लिए कपूर साहब, और फोटो तो भाई राजेंद्र प्रसाद सर बहुत फॉन्ड हैं। फोटो तुम्हारे गड़बड़ हुए तो तुम ही समझना प्रसाद सर से। तो ये फोटोग्राफर भी हैं, वीडियोग्राफी सारा काम उन्होंने किया है। अच्छा ही होगा शायद। बहुत बहुत धन्यवाद। जो हमारा खाने की तारीफ तो काफ़ी लोगों ने की है, अब पता नहीं, मैंने तो ज़्यादा खाने का मौका ही नहीं मिला। कभी कहें जब खाने बैठे तो कहे कि वहाँ पे बुला रहे हैं प्रसाद सर, कि वो सेशन आ गया वहाँ पे, तो मैं इधर भागा। तो मैंने तो सही मायने में ठीक से खाना नहीं खाया, लेकिन शायद आप सब ने खाया होगा, तो इसका फीडबैक आप जितना भी देंगे। लेकिन कुछ लोगों ने दिया है, तो मैं उनको भी धन्यवाद देता हूँ। चांसलर क्लब, जिन्होंने पूरा मैनेजमेंट, चाहे यहाँ से वहाँ तक फ्लैगिंग हुई हो, चाहे जितने भी होर्डिंग बोर्डिंग्स हैं, जितना भी प्रचार प्रसार है, उस सब की जो केयर की है रात और दिन लग करके, वो सब चांसलर क्लब जिन्होंने सारा टेक केयर किया, उनको भी धन्यवाद देता हूँ। काफ़ी और सारे लोग हैं, सबका नाम लेना संभव नहीं है, मैं सबको धन्यवाद देता हूँ। बहुत बहुत धन्यवाद।
Thank you, sir. Now I call Dr. Manju. She is wife of our secretary, Dr. Ved Prakash. I request all dignitaries to honor ma'am with memento. Anybody from audience want to give feedback or any comment or any criticism, anything?
मैं अपना परिचय दे दूं। मैं डॉक्टर यंत्र गुण गोरखपुर से, गोरखपुर से रीजनल हेडक्वार्टर को मैं देख रहा हूं और मैं एज ए रीजनल हेडक्वार्टर से आया हूं। तो सबसे पहले मैं बधाई दूंगा डॉक्टर वेद प्रकाश जी को। बहुत शॉर्ट नोटिस में इतनी बड़ी अरेंजमेंट, आप हमेशा प्रशंसा के पात्र रहेंगे। आपने एक माइलस्टोन एस्टेब्लिश कर दिया है सर, और मुझे लगता है कि इसको प्राप्त करने में लोगों को और मेहनत करनी पड़ेगी। राजू गर्ग साहब हमारे मित्र हैं, जानते होंगे कि मैं कॉन्फ्रेंस का बड़ा फैन हूँ। बहुत शॉर्ट नोटिस में सर मैंने रजिस्ट्रेशन कराया और देख कर लगा अच्छा लगा, कम से कम वैलिडेटेड में इतने लोग बैठे तो हैं, ये आपकी ताकत है सर। थैंक यू वेरी मच सर।
Thank you, sir, for positive feedback. If anybody want to say something, please come on stage. So, on the behalf of organizing committee, I thank you to all. Now, please proceed for lunch. And जिनके certificates नहीं मिले हैं, please काउंटर से ले लें। और जो प्रेजेंटेशन से ओरल वाले और ई पोस्टर्स, वो अपना मोमेंटो भी यहाँ से ले लें, रेशन काउंटर से मोमेंटो ले लें अपने। Thank you all.